Well, good morning, everybody. If I can ask delegates to take their seats. Okay. If everybody can settle down, that'd be great. Okay. Well, thank you. Can I give a very warm welcome to everybody this morning who's joined us here for what is the second ATiC Symposium here in the wonderful Dylan Thomas Centre in the heart of Swansea. My name is Ian Walsh. I'm the ATiC Director, but as you'll see throughout the day, many others have done the work. So it's my privilege to welcome everybody this morning. So croeso I Prifysgol Undydd Arloesedd. Welcome to University of Wales Trinity St David. Welcome to, as I said, the second ATiC Symposium. And I was talking to our Vice-Chancellor a moment ago that the first ATiC Symposium, which was about 3 years ago now, three and a half years ago, was an international symposium. And we were delighted at that time to welcome quite a large delegation from a partner institution in China, from a little known town called Wuhan. Now, I'm sure none of you have heard of Wuhan, but it's been quite in the media of late. But today really should have been like the fourth or fifth ATiC Symposium. But who'd have thought that we'd have entered into that period, which none of us will ever forget in terms of COVID, the impact of the pandemic upon normal life, and the impact of the pandemic upon projects and collaborations. So considering where we started and what we've been through, it's a minor miracle that we are here today in such good form. So I want to give a very warm welcome this morning to all our partners within Accelerate. This is as much an Accelerate core day as it is an ATiC celebration. So it's very much about the partnerships. And I think I'll leave it to others to talk more about the value of partnership later. But it's a delight to see partners here from not just the Accelerate partners, from Swansea University's Medical School, from Cardiff University's Medical School, and of course the Life Science Hub down there in Cardiff Bay, but also visitors and delegates from health boards. So particularly our partners in Hywel Health Board through TriTech, and others. I can see Donna there from Vlindre, and forgive me, I'll miss people if I start listing names. Now I said the first ATiC Symposium was an international symposium with a large delegation from China, where we're delighted to welcome colleagues from Lithuania this morning. So very good to have you with us. Welcome, croeso welcome to Wales. I hope you enjoy your day, and I hope it provides the catalyst for many fruitful conversations with people from the university and from the health boards going forward. Well, this morning, my role is really to warm up the audience and to welcome you, to also to remind you to please switch off your mobile phones. I know everybody's very busy, but if you could put them at least on silent, that would be helpful. Secondly, we're not planning a fire alarm, so if the alarm does go off, we will exit. You might have to squeeze through the gap to the fire exit, and certainly down the stairs, and you'll be guided. There'll be staff on hand to guide you to the exit and to the assembly point, which will be out the front square in front of the building. The other thing is for comfort. There are toilets, male, female, and disabled access toilets along the corridor, past the bar area as you come in to this room. So as I said, my job is just to welcome you and to set the scene. So we've got a packed agenda today. We have apologies from the Chief Science Officer this morning, unfortunately, Rob Alford. He's unavoidably unable to make it today. But nonetheless, we've got an amazing lineup. In a moment, I'll welcome our Vice-Chancellor, Professor Medwyn Hughes, to give a more formal welcome. And then we have Phil Clure from Hywel Health Board. Then we'll have a short break before we go into our main paper sessions. So please make the most of the day, have the conversations. Don't forget to pop up and see the stands upstairs with some of our partner companies. And please make the most of the day. We have a feedback form as well, which we'd like you to complete to give some feedback so we can improve next iteration of this symposium. But in the meantime, Croeso, welcome, thank you for coming along today. And now I'd like to call upon our Vice-Chancellor, Professor Medwyn Hughes, to say a few words.
Wel, bore da, gai na estyn croeso cynnes iawn I chi mae'r Prifysgol. Can I also extend a very warm welcome to you here to the University of Wales TSD here at Swansea. I'm so pleased that I can join you here for the second symposium. It's an opportunity to celebrate, isn't it? Celebrate the success of collaboration here in Wales, of the true value of world-class research institutions, health boards, government and agencies coming together to co-curate and to focus upon not only innovation, but the importance of collaboration and of making a difference. Our universities are at the heart of innovation and research. World-class research institutions, health boards, working with government. And I think today gives us an opportunity to look back within the symposium to consider the impact of what you have achieved within Accelerate, focusing upon innovation in health and well-being. You will know far better than I will in the context of an integrated system for Wales that focuses upon prudent health care, the need for that connectivity, of bringing together research, of applied research, innovation and design, and capturing what is required to make a difference to the health and well-being systems of our country. We have fantastic potential of working together. Wales as a country can work well where we collaborate. What we've seen in the context of this excellent project of bringing together universities, health boards, and a range of organizations in the name of government, what can be achieved. And although we are today noting the end of a particular program, we are also seeing the benefit and hopefully articulating a direction of travel for the future, where we can identify more funding and more opportunities for collaboration. The current program, as you know, ends in December 2022. And what we have today is a chance to consider the impact and to consider the reviews of what has been achieved. But we should now focus on the future. We should be working together to articulate within difficult times for funding for research. How do we now secure for Wales the best settlement to take forward research, design and innovation to make a difference for the citizens of Wales? Wearing another hat which I'll be formally taking on in April as chair of the Citizens' Voice Body for Health and Social Care, the messages that I'm having across Wales is the need for that connectivity and of the real importance of developing digital solutions that can make a difference. I urge you, therefore, in your deliberations to consider how do we do that effectively. I am absolutely sure that the best way to do that is through co-curation and collaboration, of bringing together the best of our research in Wales, of looking to the application of research and seeing how that makes a difference to our health and well-being systems. I wish you well with your deliberations. It's a great story of celebration of what we have done together, what we have achieved, and I'm certain what we can do again for the benefit of Wales. Croeso a gai ddymuno dda iawn I chi ar gyfer y gynhadledd. Diolch.
Well, bore da pawb. My name's Phil Claw from Hywel University Health Board. A warm welcome to this conference. A thank you to the organisers also for inviting me. It's great to be with you today. My perspective, I suppose, is from a health board perspective. And I do think this is an opportunity to look back and celebrate some of the achievements, a really packed agenda, which looks really exciting today, but also to look forward and think where we might target our efforts in the future. I suppose the first thing I was going to say is that the NHS and health services and social care services are under huge pressure at the moment. You know, that I'm not saying that looking for sympathy from all of you so that you're all sitting there thinking, gosh, that must be difficult to manage. I'm saying that because actually it's one of the fundamental challenges of society at the moment, and it affects each and every one of us, our friends and our families on a daily basis. We'll all know of people who are struggling to access the health system. And we also know that in our communities, there are people who develop conditions or go down a path where if something else had happened, actually that path didn't need to happen. And I suppose the challenge for us at the moment is that every year that gets more difficult. And I suppose that's why the Accelerate was so important, bringing together health, university partners and industry in a way that tries to tackle some of those real life issues. Because if we leave it to health and care and public sector services sort of on their own to meet those challenges, I don't think we're going to make the steps and the quickest steps that we could do. And so look, when we look at COVID, the recent experience we've had through COVID, we've seen some remarkable innovation. I just wanted to talk a little bit about the importance of innovation, not only from our staff. You know, when COVID happened, all of our staff in every institution, looking around the room, I can see all sorts of different institutions, you'll all be thinking of the sacrifices and the changes and the innovation that happened within your organisations from a staff perspective. But you don't have to think too much before you think about all the amazing innovations in technology that happened through that COVID pandemic, and how you saw the importance of industry, university partners and health working together. Just look at the vaccination programme, for one thing. I mean, that's something that should have taken 10 years to happen. And I kept getting pushed, I remember, by politicians about, well, when is local politicians, when are we going to have this vaccine? And I kept saying, well, normally this would take, 5 years at least. And there it was. In the middle of the pandemic, we had a successful vaccine, and then the innovation around the rollout. But there were so many other technological solutions to challenges that we faced in the health arena. When you look at the testing, the work around PPE, even non-invasive ventilation, high-tech machinery that was developed locally and supported by our university partners. So it wasn't all just big industry. It was also local people, local businesses coming up with innovations, creative solutions, which really impacted on people's lives. And so Accelerate had a really key role in that. And one of the things I feel that Accelerate has done is it's done something that's quite difficult when you look across the UK. It's multi-institutional collaboration. And a brief conversation earlier, that there's a sense that in Wales that our collaboration between our universities is much stronger than across the rest of the UK. Now, that's brilliant for the public sector, but it's also brilliant for industry to be able to look into our university sector and work with universities who are playing to their relative strengths. And that's what I see, certainly in Hywel, that's our experience. We work with multiple partners, and our experience has been that we have deep conversations with our university partners about their motivations, our motivations, and conversation about the difficulties of interacting with health boards, of which there are, I know there are many, but also how we do play to those strengths. A concrete example, which you'll hear a lot about later, is TriTech, which is this collaboration between our researchers, innovators, and our industry partners, and supported heavily by two of our university partners locally with joint posts, without which it would be really difficult to make that initiative work. And TriTech, it's only been in operation for a short time, but it's already connecting with things that are going to impact on people's lives. Just to mention a couple, the pain app that's been supported, and neuroelectrical stimulation, a new way of supporting people who have chronic pain. Now, chronic pain is a real population health issue. It affects so many people's lives, and it isn't just the pain, of course. It affects people's mental health. And actually the solution often in the past has been to give people medication and more medication and more medication to which they become tolerant to. So these things, I use these examples because they are a really important adaptation that has come locally and that we're supporting locally. And I suppose I was going to sort of think about looking to the future. So what do we need to think about in the future? I suppose if you look at various reports, the King's Fund report, for example, talks about, well, what are the things that are going to be important around tech for healthcare? And yes, they do talk about robots, AI, whole genome sequencing, all of those really, really high-tech things which are going to completely change the way healthcare works. So I don't know whether there are radiologists or pathologists in the room, but the great news is for you that you're at the forefront of innovation. The challenging news is that your jobs are very much likely to change. If you've just qualified, it's highly likely that it won't be just your opinion looking at one scan after the next, after the next, after the next, with all the human variability that we have. I mean, they're brilliant, they're trained, but, you know, we're human. AI is showing some amazing results with looking at X-rays and CTs. And I would foresee that AI would be the way that your X-rays, our X-rays and CT scans and MRI scans will be reported in the future. Same for pathology. Same for retina, looking at the back of your eyes. So ophthalmologists, opticians, look out, it's coming. It's going to be different, and it's going to be. This isn't something in a next generation's lifetime. This is in our lifetimes, and in fact, in the very near future. So I suppose those are some of the high-tech things that are going to fundamentally change the way we work. I would say, though, that when you look at that King's Fund report, there are some things which you might gloss over that I think are perhaps even more important. And these are the things that are much more about health promotion and about community cohesion. Because if you look at what determines health and well-being at the moment, what are the challenges within our communities, it isn't just disease. It isn't just caring for those with disease. The challenge actually a lot is loneliness, isolation, living with a chronic condition. You know, these aren't things that need really high tech stuff, but they still do need tech. Tech has a real role to play in helping us manage those challenges. So they don't all just default to A&E or the GP, who on their own can't really deal with those challenges. So I would urge future tech to be looking much more to keeping people healthy, supporting people to manage their own chronic conditions. How do they create and improve community cohesion? How do they help people to live at home safely? That kind of tech, I would be urging people to go to that way. And just to conclude, the other couple of things I was going to say was that one is that I think as a health board, particularly health itself, has tended to look quite inwardly and is quite nervous about tech and industry collaboration. Certainly has traditionally been that, and we've got, you know, life sciences are here and all sorts of people, university partners, to help us with that. But for sure, health on its own can't look inwardly to solve these problems. We do need that diversity of thinking and that creativity that our university partners and industry can bring us. The last thing I was going to say really around that was that we're not going to face the challenge of society just by small incremental change. Just a little bit more than what we're doing now. It's not going to be anywhere near sufficient to face the sort of challenges that we have now. We have to break the mould and we have to see step change. And it is at times of great difficulty, like the COVID pandemic, when you see the biggest innovations and the biggest step changes. So I think that's our challenge. We not just a little bit of the same, we need to be doing completely different things. So look, I would say Accelerate has been brilliant. I think it's hit at the heart of the issue around that health, university, industry collaboration. And as colleagues have said, we just need to find new ways and new ways of funding future efforts in that regard. But I hope you have a great day. Thanks for letting me be part of it. And let's keep up that effort.
Well, thank you, Phil. Phil mentioned innovation a lot there, and innovation is not just something you do, it's a mindset. And our next 4 speakers, really, which cover session 1, which is all about reflecting upon the impact of Accelerate, and also maybe exploring the future trajectory of Accelerate, epitomise that sense of doing things a different way, coming together with a different mindset to radically change. I think Phil talked about we can't just have incremental, we can have radical change in our health system. So to kickstart our formal session 1, I'd like to invite Carrie-Anne Quinn and Gareth Healy from the Life Science Hub. No, oh, it's Gareth, okay. So a bit of delegation from Carrie-Anne there. So Gareth Healy.
Thanks, Ian. Yeah, sorry, it's just me for the session. You're going to get Carrie-Anne later on, I promise. So my name's Gareth Healy. I've had the privilege of being the head of Accelerate for the past 18 months. And it's a great pleasure just to kick off this session on the impact of Accelerate. What you're about to hear is a series of case studies from both the partners that have provided that support, but also the businesses that have actually benefited from that support from Accelerate, to see what those benefits did for the business and the future potential impacts of them. Of course, the benefits go far beyond numbers, but just to, yeah, I can press there. I've broken it already. Fantastic. So, of course, the benefits go far beyond numbers. But just to give you some headline numbers to kick things off, these are taken from an impact report that we recently published earlier this year, just to highlight sort of the level of the benefits which Accelerate has had already over the past 4 years. And actually, by the time the program concludes in December, it will be even higher than this. So we are, as was mentioned earlier, we're looking as to how we're going to work more closely together in the future, continue the collaborations that we've had. Just to that, before I hand over to, I'm going to try and press a button again. Fantastic, it worked this time. Before I hand over to the first case study, just to highlight that as we move forward, of course, the collaborations between the Accelerate partners are incredibly strong. And this is an example of just one of the types of support that Life Science Hub Wales provides. I'd encourage everybody to go and see the Accelerate partners today at their stands, talk to them about the types of support that we have been able to provide and will continue to be able to provide in the future. And we will definitely, in whatever mechanism it is, be working very closely together for the future. I'm going to hand over to Chris and Aziz to tell you about the first case study.
Just manually clicking forward. There we go. So, yeah, my name's Chris Jones and I'm one of the partnership managers here at the Life Science Hub Wales. So I first met Aziz when it was a very early idea stage. And so we held an initial scoping meeting to discuss his aims and aspirations. And ultimately, he wanted to solve a challenge within the healthcare sector using a product that he was going to create. So during this meeting, we discussed what would be the best mechanism of support we could offer for that. And we decided that a market intelligence report was going to be that. So I invited our sector team into the meeting, and our market analyst discussed what topics would be really beneficial to help him move this along and to progress. So ultimately, we decided that a competitor analysis, an overview of the current landscape, any barriers to entry, and any emerging technologies are vital to know before we progress. So the benefits of this report have been that Aziz had a much greater understanding of the health landscape. And having this better understanding allowed him to navigate the system a lot more effectively. And as a result, he was able to ask the right people the right questions at the right time. And then taking this user-centered design approach, he was able to gain that clinical buy-in very early on. At a later date as well, this report was useful for funding applications. He put this into quite a few bids and he was actually successful with some of those. So I think it's a really good time to let Aziz tell you more about Goggle Minds, the company.
Thank you very much. Can I use this clicker? Is that going to work? It's funny we're here talking about technology and the technology lets us down at the wrong time, right? Here we are. Okay, so for those of you who don't know me, excuse me, my name's Aziz and I'm the CEO founder of Goggle Minds. And at Goggle Minds, what we do is we create medical simulations to help healthcare professionals and medical students practice and learn clinical skills in safe virtual environments. So I just wanted to talk about what we do at Goggle Minds, but I first thought it would be really useful for you to understand the context into which we became Goggle Minds, and of course when we met Chris and had the support from Accelerate. So I started off studying at Cardiff Metropolitan University, and I studied my first degree in environmental risk management, but I didn't fancy a career in oil and gas, so quickly switched over to go to law. I did a law degree and then decided that wasn't for me either. So then I went on to do a health and safety qualification, which was probably the best decision I've made because it enabled me to get my first role into the NHS. And my role was in health, safety and wellbeing. So we were looking after community services in the southwest of England. And one of my first challenges was around training. So at the time, I didn't realize how important that challenge would be and how important it would become. But one of the things I started to do was to incorporate activities into our training sessions and games. And it really engaged our nurses and our doctors and our surgeons. And so I knew I was onto something, but not long into that role, Virgin Care actually won the contract and I decided that I wanted to stay in the NHS. So I had my first role in NHS Wales in an Aneurin Bevan University Health Board. So I think there's a few people here from Aneurin Bevan today. And I was based at St Cadoc's, and so one of my first challenges there was again around training. So I could see there was a pattern developing, and so I thought to myself, I need to do something about this, but really kind of forgot about it and went into private healthcare. At the time, coincidentally, a friend of mine was asking me for advice around doing a master's degree, and in the process of convincing her that she should do a master's degree, I ended up convincing myself that I should do a master's degree, so did a master's degree. And my final project was actually during the pandemic, and it was a master's research proposal and research associated with that, looking at immersive technology usage for nursing cohorts. So specifically, we created a very basic simulation to help nurses train in clinical skills. And obviously by that point, I had read 100 or more research papers, and we had done this research, which was really positive. So I decided at that point that I would start a company. Of course, I've never started a company before. So I came to Accelerate, just pure chance. I'd been scrolling through social media, and then I come across this call to action, so I contacted them, and I spoke to Chris first. And what I found was that I was in this kind of landscape of uncertainty. I didn't know, what to do. I knew there was a problem to solve, and I knew I could solve that problem, but how would I do that? So what Accelerate did for us was really provide us with a soft landing and a safe pair of hands to guide us through that process. Because of course, healthcare is a really complex industry. And whilst I had first-hand experience in that, I really didn't know everything there was to know. So that was really invaluable for us. Fast forward to kind of today. So our mission now is to bring the best medical simulation training to healthcare professionals and students around the world. And so we're really proud to be in Wales because of course we are based in Cardiff. And I started at that point just myself. Today we are now a team of 10 and rapidly growing, and we've deployed solutions into the NHS. And of course we've worked with all of these people and these organisations in Wales. So you can see there, University of South Wales in Cardiff Metropolitan, BBC, CMET and Creative Wales and Bangor University. Unfortunately ATiC isn't on that, but that might soon change perhaps. So let me just show you some of the technology. So actually, this is a really poignant slide, actually, because this month is Black History Month. And of course, if any of you are familiar with medical simulation, you'll know that the plastic mannequins that we use are really underrepresenting the population that clinicians are serving. So it's really important that when we create our virtual patients, they represent that diverse population. And so she is actually Lorna, our first black female virtual patient. So we deliver medical services and training services across specialties. So not only do we look at medical students, but also post-registration and across surgery, dentistry, and general nursing. And our first commercial product, which we're launching imminently, is called the Mediverse. So how many of you have heard of the metaverse, just by a show of hands? Well, this is the Welsh take on the metaverse. This is the Mediverse. And in the Mediverse, healthcare professionals and medical students can go in and practice clinical skills alone or as part of a group safely, anytime, anywhere. And so we've created a number of simulational experiences, and this is actually one of them. I'm not sure if I can, how we press play on this. There's no play button, sorry, on the... Oh. And so this is one of our pediatric simulations related to tracheostomy emergencies. And so one of the big problems with traditional mannequin training is you can't practice on children in real life, so you have to use a mannequin. But with this, you get real-to-life reactions from this virtual patient. So it really brings that experience to life. And you heard there the beeping, the sounds that come with those clinical experiences, whereas with traditional mannequin training, you just don't get that. You get an actor who's pretending to be a patient, and how realistic is that? So obviously, everything that underpins what we do is based on science. It's critical to what we do, and I'm a strong believer in that with my background. And so we actually have run research studies alongside our product development, and that is a cornerstone of what we do, and will continue to be the same way for the foreseeable future. So you can see there's some really impressive stats, and I must be honest, they've not always been that impressive. And actually, we've managed to present a poster presentation at the Royal Society of Medicine. We've been invited to go to ENT Dubai World Conference next year to present a paper there. And of course, we've got collaborations in the NHS currently where we're developing some research which is really novel to the VR space and will really change the way we can deliver medical education. So this is, excuse me, quite poignant given what the first couple of speakers have already said about collaboration. So I remembered this African proverb. So by coincidence, obviously I've included it when somebody else has spoken about this today. So it says that if you want to go fast, go alone, but if you want to go far, go together. And I guess my call to action today is that as an industry, as a company looking to develop in the healthcare space and with healthcare providers and medical students and perhaps medical institutions and others here today, I would say that it's really important that we work together to bring these solutions to life and to really have that positive impact that we're all looking to make, because ultimately what we're all trying to do is improve patient safety and care. And so we should work together to do that. And I just wanted to leave you with this virtual replica that we made of an Iron Bevan. So it's just a tribute to an Iron Bevan. We've created him in virtual reality. Given all that he's done and where we are today, had it not been for an Iron Bevan, perhaps we wouldn't be here today talking about what we're talking about. So on that note, I'd just like to say thank you to Accelerate for all the support that you've provided us and all of the people that have supported us on our journey. And thank you for listening to me today. Thank you.
Thank you. That was a really great introduction to this session. And that gives me great pleasure to introduce Professor Ian Weeks, who from Cardiff Medical School, who's going to maybe enlighten us as to the CIA, not that CIA, the other one, Cardiff Innovation Accelerator. Thanks, Ian.
Thanks very much, Ian. Yeah, so Accelerate, I mean, what a fantastic revelation it's been. It's been a hell of a journey over the last few years, but a very successful one. If I can, who's what do I do to load these up, Ian? There we are, wonderful. And I didn't even press it. Now that's technology for you. So I'm not going to talk for too long. Is Peter around? Peter? Oh, there you go, Peter. Do you want to come on up? Save the delay. So the really interesting part of the presentation here is from Peter from Agile Kinetic. But what I thought I wanted to do was just say a few words about where we've come from with the Clinical Innovation Accelerator. If I can get this thing to work. There we are. I'm not going to go through each of the numbers in this in great detail, but one of the things I just wanted to point out here sums it up really. This kind of diagonal talks about partnership and what accelerators allowed us in CIA to achieve. We've got the 8 universities involved, Welsh universities engaged. We supported 155 business, academic and clinical collaborations. All the health boards in Wales have been involved, and we've directly supported 64 Welsh enterprises. And when you look at the relatively short period of time over which Accelerate's been running, I think that's pretty remarkable. And it's the same across the piece. This is what Accelerate has achieved for us here in Wales. Point's already been made, it's coming to an end. And we really have to try and reproduce this going forward in some way, shape or form. And so I guess my plea to all of the influencers and people in power up there, see what has been achieved and see what this model can help us do. I think the other important things to mention as well, if I can get this darn thing to work, there we are. Key to this as well is you'll note 58 early career researchers and assistants being involved. These are people who have got experience, who have been trained up and will form part of the workforce in this arena in clinical innovation in the future. So vitally important that we develop our workforce because that's something that sadly has been missing. So accelerators scored on that one as well. And I think the other key point, if it flips, I don't know whether it's me being slow or whether it's the, there we are. Social enterprises as well, another key area in terms of the socio-economic side of people and also the health of people. So I think you'll see just from those metrics alone, just how much has been achieved through the Accelerate project. So I'm going to basically stop there and hand over to Pete, who's going to talk about what Agile Kinetic have done, and look forward to hearing all the exciting stuff that you've done. Thank you. Thanks, Peter.
Thank you very much, Professor Weeks. Thank you very much for having us here. It's fantastic to present what we've been doing. So, just see if I can get the slides to work. You don't have our slideshow. I do have a copy on a laptop. Okay. Okay, sorry. Yeah, sure.
Okay, while we're doing that, what I thought I would do, have I got time to, Ian, just go through a couple of other details? I think for us, it's how we get the engagement going, and obviously working with the Life Science Hub has been absolutely critical to that, and all the opportunities for working through their events with other organisations in Wales. But one of the things that we found extremely well is something that we tried, which predated Accelerate, but fitted quite nicely into the Accelerate model, and that was essentially creating a clinical innovation multidisciplinary team. And essentially, that was formulated in 2016, so quite a while ago. And what we found from that was really the willingness of people to be collectively engaged in innovation, and by various means, and it didn't take much persuasion or cajoling, we got a huge team of people together from various areas of expertise. So we had clinicians who who were interested in innovation. We had academics who were interested in innovation, and we had people from industry who wanted to be part of wider innovation and look for more opportunities. And even with some of the professional people that wanted to be part of the critical mass. So we had people who were experts in intellectual property, people who were experts in corporate law, and various other areas that were important. And under a blanket non-disclosure agreement, once a month, we held physically, prior to COVID, a multidisciplinary team meeting on the University Hospital of Wales site. And to call on, we had, I think it's fair to say, a critical mass of about 40 people plus that we could call upon to attend these meetings. And we invited people with ideas, whether they were quite well-formed ideas or just really the sort of light bulb moment that people had. And we got them to submit to the multidisciplinary team their ideas. And essentially over the weeks and months and years, we just kept on having these meetings with people turning up, pitching their ideas and getting advice and support on that. It wasn't a dragon's den, but a supportive environment. And that was a fantastic way of feeding projects into Accelerate. So again, I think this engagement with all areas is absolutely vital to the success of Accelerate. Are we now on? Great, okay. Right. Sorry for the false start.
Sorry, it can be a little abstract to explain it without the visuals. But essentially, Agile Kinetic have been researching an emerging technology called human pose estimation since 2019. And at the time, I'll just explain how it works. So this form of AI can automatically identify joint angles, joint positions and facial landmarks from any image or video filmed on any device. Now, when we first began to research this technology, it was really just the domain of academics in universities such as MIT. There were no commercial applications. To be honest, it wasn't very accurate, and it took a high-powered computer 10 seconds to process the results for a single image. Despite this, in 2020, just as COVID was starting out, we set out to use the technology to reduce the need for face-to-face appointments in healthcare. The reason for doing this is because, excluding A&E, outpatient appointments across the UK account for almost 85% of all hospital activity in the NHS, almost doubling over the past decade. Additionally, NHS-related travel accounts for 5% of road traffic in England on any given day. And any saved car journey through virtual appointments would represent 2.85 kilograms of CO2. So we began by developing a solution for remote recovery from orthopedic surgery, where range of motion is an important indicator of recovery. And we were using the pose estimation software to do that. The standard approach to measuring range of motion is through use of a physical device known as a goniometer. This is also the main benchmark used in research studies to compare alternative technologies or alternative approaches. But this method itself is flawed because it's prone to human interpretation, which means it's prone to human error, or poor inter-rater reliability. So two different clinicians who could be highly trained could come up with the same, with a different angle for the same joint and same angle. So when we were looking to validate our technology, we were looking for a more robust approach. The Accelerate project and our collaboration with Cardiff University's musculoskeletal biomechanics research facility allowed us to compare our predictions with a sophisticated lab-based system considered the gold standard for this type of motion analysis. It also gave us hundreds of data points to compare for each movement rather than one or two angles measured with a goniometer. So the aims of our project for the initial 5-month project were to validate our 2D pose estimation predictions, to capture 3D lab data of movement patterns, and then to integrate that data into our data sets. But within 2 months of the project start, our exposure to this lab-based system and the clinically relevant metrics that they were able to generate from the data helped us to realize that we were vastly underestimating the potential of our technology. The technology is continually advancing. While we'd been focused exclusively on range of motion when we started out, we now realized that we would be able to help to provide insights related to quality of movement as well. Then, fortuitously, in January, the Alan Turing Institute was offering funding for existing collaborations to make more or better use of the data that they were generating. So we applied, our application was successful, and we rewarded this funding. We were able to recruit 2 data scientists just for 8 weeks to start prototyping some of these metrics that we'd identified. That initial 8 weeks was so successful that we were able to successfully apply to extend our project for a further 7 months. We were able to retain one of those data scientists for a few of those months. And we've since been able to prototype a number of different video-based tracking of different metrics and insights. Some are used to provide clinical information. Others are more for real-time feedback for patients to improve self-care. And I don't know if I can, oh, there we go. So the first one is tracking in real time from a patient's device, be that smartphone or tablet or webcam, tracking range of motion of the left knee in this case. Repetition counting and duration. So this is more for real-time feedback for the patient as they're performing whatever exercise it is they've been asked to perform. Consistency of that movement or those repetitions. This one is calculating the symmetry between joints related to the joint angles, but also to angular velocity. And these reports are generated from that. And again, for patient feedback, measuring the distance between 2 joints. We're also prototyping a scoring system for how closely a patient can match a movement that's been sent to them. Now, we're still comparing the results between our systems and the lab-based systems, but we can clearly see that the results show promise. So the slide you have up in front of you is just 2 different movement patterns. We've used several, and we've used 20 different people. But the results are very consistent in that you can see the lab-based system is in the red, is marked in red, and 2 human pose estimation models are blue and green. And further smoothing techniques are needed, especially when it comes to the angular velocities, but they're clearly following a very similar trend and show a lot of promise. So there's substantial evidence to demonstrate that assessment of movement, such as gait analysis, can be used to diagnose frailty, improve outcomes in prosthetics and orthotics, monitor for improvement or deterioration in various musculoskeletal conditions, and even be used for identification of neurological disease. The problem is that gold standard systems, like the ones we've been using at Cardiff University, typically involve a fixed lab space, expensive motion capture systems, experts to interpret and to process the results, which takes often days for an individual patient. Because this is cost prohibitive, clinicians typically rely on in-person visual estimates or use basic instruments like a goniometer or a stopwatch to inform clinical decisions or to provide outcomes for clinical trials. And both of those approaches require the patient to be physically present. Oops, I've gone forward too quickly. That's fine. Next one I want. Thanks. We now aim to remove these barriers, and thanks to this project, are close to releasing a platform for clinicians or researchers to send any movement to a patient for them to perform while being tracked by the camera on their own smartphone, tablet, or webcam. Patients will receive real-time feedback, and then patients and clinicians will receive a report. We also know that there are hundreds of startups as well as more established digital health companies who are innovating in healthcare. So we are developing our capabilities into an API that allow these other companies to take advantage of them. As one of the winners of the Health and Social Care Hack, we are now additionally prototyping remote digital gait analysis for early assessment of frailty. There are still improvements to be made. The system is not yet flawless. The slide you can see ahead of you, because our systems work very much like human vision, poor lighting or more challenging movement patterns can cause errors. So in this example, the lighting isn't very good, so the model is becoming confused over which foot is left and which foot's right. But we're on a clear trajectory to removing these errors, and just in 2 years, the results are much, much better. So we now hope to continue our research collaboration. We are looking to develop 3D pose estimation, which is more accurate again, because 2D pose estimation requires the patient to perform a movement in a certain plane of movement. And 3D doesn't need that. But we really want to take the opportunity to thank our partners, to thank everybody involved in the Accelerate project. It's been absolutely fantastic, really exceeded our expectations and put us on a much better trajectory. So thank you very much.
Thank you, Peter, and thank you, Ian, for insightful, actually, demonstration of the capabilities of kind of remote diagnosis and monitoring. Our next speaker in this session is from the third of the Accelerate partners. There's no pecking order, you understand, it's all no particular order, as they say in Come Dancing. So I'd like to introduce now Professor Keith Lloyd, who is Pro-Vice-Chancellor for Medicine, Health and Life Sciences at Swansea University, and also maybe invite Jordan Copner to the front as well.
Bore da. Mae'n bleser bod yma heddiw. It's a pleasure to be here today. My name's Keith Lloyd. I'm Pro-Vice-Chancellor at Swansea University, and we're going to talk about the Healthcare Technology Centre. It's been a real pleasure to be part of this collaboration over the last few years. Wales received about £1.4 billion of European regional development funds. Those have been replaced with about £600,000 of strategic development funds. That's quite a gap. It's through collaborations like this that we can actually bridge that gap and find ways of working together. So I'm going to talk about Accelerate Healthcare Technology Centre, which was part of the Accelerate project, but I just wanted to thank, I'm up here speaking, but I just get to come and talk about stuff. Other people do the real work. And particularly wanted to thank Naomi Joyce, Alex Evans, Natalie DeMello, and the whole HTC team, some of whom are here today. So thank you very much, guys. You did a great job. So Accelerate, the Healthcare Technology Centre, supports the translation of promising ideas from life science, health and care into new products, processes and services. That's what we do. We've been working across Wales. It's been a particular pleasure working with colleagues in ATiC and CIA during the lifetime of this project. What we do in HTC... it's one of those slides. We've created a dedicated HTC laboratory with state-of-the-art equipment. Do you know what? Let's just build the slide. Can we have all of it? Oh, it's gone now. Okay, well... We've got a dedicated laboratory, but not advanced PowerPoint facilities. So we've created a dedicated laboratory with advanced facilities across Swansea University, an innovative multidisciplinary team, and all three elements of Accelerate have offered a different mix of skills and things that they've brought to the Accelerate programme. And we've created academic partnerships for grant and funding applications, which is how we're going to help bridge that gap between European funds and their replacements. Have we done? Well, we've engaged, thank you, we've engaged with more than 200, sometimes you need humans. We've engaged with more than 200 enterprises, created 60 new projects, 35 new products. We're going to hear about some of those in a minute. We developed a new purpose-built laboratory to help design and deliver some of these products. We've secured additional investment and placed students with industry partners so that they can become the next generation of innovators. That's really important. We want to build innovation into as many of our student pathways as we can because it's really important. Next slide, please. The labs have won, HTC has won a number of different awards over the time. Innovation Forum, it's put on exhibitions, it's won laboratory efficiency and sustainability awards. And we've worked with the TriTech Institute in Hywel on a health and social care technology challenge. Particular congratulations to Chris Hopkins from TriTech for the award he won yesterday, which I think he's going to say something about later, perhaps. We've had Welsh health and social care hacks, and the team put a huge effort in around COVID-19. It's a huge effort. Here are some of the companies. Next slide, please. So, the Chuckling Goat, they are doing work with goat's milk around fetal immunology and people's microbiome. Inature make microneedles for different drug delivery systems. And what HTC has done is it's brought a range of companies at all stages of technology readiness, from kind of fundamental discovery science right the way through to clinical applications. And next slide, please. I'm now going to hand over to Jordan, who's going to tell you about one of those innovations. Thank you, Jordan.
Absolutely. Thank you, everyone. My name is Jordan Kopner. I'm the founder and CEO of Kopner Biotech, and it's a great pleasure to be here today to tell you about the successes of my company with the Accelerate program. So I can get my PowerPoint up. So before I really get down into the collaboration with the Accelerate program, if I go to the next slide, just to briefly cover the company itself. So we established back in 2020. We're based in Ebbw in South Wales, and we're a Welsh startup focusing primarily in the research and development of novel 3D cell culture technologies. We've built an extensive portfolio of IP to date, both patents in the UK, worldwide, and also trademarks. Our products cover all the way from the off-the-shelf scaffold technology up into high-precision software and hardware for the bioprinting sectors. As well as the Accelerate program, we've recently completed a smart company collaboration with Gelagen, another Welsh biotech SME, to create an extrusion bioprinter with a project worth £120,000. We've also recently secured an Innovate UK smart grant worth £450,000 to develop an inkjet bioprinter. We hope to work on the development of actually 3D printing vascularized tissue beds for big pharma and tissue engineering. So moving on to the actual collaboration itself, I really want to get down into what is cell culture and why is it important. So in terms of cell culture, it's the growth and maintenance of cells outside of the host body. In terms of human cells, this is incredibly important for drug discovery of early novel targets, as well as actually growing up cells for replacement tissues and tissue engineering. For quite some time, cell culture was conducted in a 2D manner, both in Petri dishes and culture plates in a kind of basic monolayer. But mammals and humans aren't 2D, they're actually 3D. So growing cells in this manner is not physiologically relevant. And so creating 3D structures to actually better mimic the human body is very, very important. To date, most scaffolds on the marketplace kind of follow a very basic wood pile lattice structure. And whilst this is an improvement on 2D culture, it's not without its limitations. That one being that cells seeded onto these scaffolds tend to randomly disperse and form random populations as opposed to a balanced complement system, which is what you would see in regular tissue. So if I can move on to the next slide. Kopner Biotech uses state-of-the-art software and hardware built in-house to create these novel structures. We can actually 3D print concentric shapes, namely circles, to a very high standard of high batch-to-batch consistency. The importance of doing that is mostly the actual pore size and distribution can be very well controlled. By doing this, we can actually introduce very discrete oxygen and nutrient gradients and encourage cells seeded into the center to naturally emanate towards the periphery. The direct result of this is a balanced complement system of cells and something much more relevant to the human body. So we had the capabilities in-house to design and manufacture these devices, but we didn't have the biological capabilities to validate these structures. And so that's when we came into contact with the Accelerate program down here in Swansea in the Healthcare Technology Centre. So I can move on to the next slide. The primary objectives of our protocol, of our collaboration, firstly, to deduce the optimal protocol for sterilization. Even though we actually produce these scaffolds in an organic solvent-free environment, which is very sterile, we still need to go through further checks to actually ensure sterility before then introducing cell cultures. Following that, we need to validate the biocompatibility to ISO 10993 standard. This is very important to actually encourage customers to uptake our products downstream. They can easily adopt our technology into their workflows if we can keep to these ISO standards. And finally, to investigate the efficiency of cellular attachment. We had around a 6-month project, so these were very nice and easy kind of targets to shoot for and create a great base for then further work to take place downstream. So if I move on to the results. So firstly, ethanol was the ultimate way to sterilize these scaffolds. A simple 15-minute wash was enough, and this is very good because all cell culture labs always have ethanol on hand to sterilize their tissue culture hoods anyway. Then moving on from there, we validated that there was no cytotoxic effect, both direct and indirect of our scaffolds. And we actually used a specific fibroblast cell line, the L929 fibroblast cell line, because it's very well at adhering to certain materials. And what we actually saw was that not only did our cells adhere very nicely, but we did see that effect that we were aiming for, where the cells naturally emanate from the center towards the periphery. And we've kind of now gotten rid of that key hassle that most researchers were having in terms of random populations in their scaffolds. And also I should say as well that our proliferation from day 1 to day 7 was on average 4 to 5-fold. So these scaffolds are incredibly important in cellular proliferation for downstream applications such as tissue engineering, and actually creating a lot of cells prior to bioprinting. One aspect that we didn't see coming, which was very exciting, was the fact that we can actually control the capillarity effect inside of our scaffolds and create an ultra low attachment environment. And we could actually form spheroid cultures in real time just 7 days post-seeding. Most protocols use a hydrogel for this, which is very expensive, it's very tedious, many steps, and also there's human error from protocol to protocol. So to have an off-the-shelf ready solution for spheroid formation was very exciting to discover in real time. So moving on from here, essentially the current state of play and where we are. We currently trade in the UK under 2B Scientific, and we've recently signed an exclusive distribution channel in Switzerland with Lucerne Chem AG, one of the biggest players in the region. We're also going to be exhibiting our technology at 2 separate conferences in Basel, Switzerland in November, one being the Festival of Biologics and the other being Biotech X. Customer testimonials have shown time and time again it's a low-cost, high-efficient platform for spheroid formation. We've actually gone one step further with some customers now investigating organoid cultures. And we have an ongoing collaboration both with Bath and Cambridge University to explore this in more detail. I should also mention one other thing we've done as a company was sponsored Professor Giamis in the University of Sussex, and he has taken on a number of PhD and master's students from Ukraine during the current situation there. So we are very happy to supply these scaffolds free of charge so those students can finish their studies safely here in the UK. Thank you so much for letting me come up here today and talk to you about our technology. If you go to the next slide, I'm always just an email away, so if you ever want to collaborate or learn more about technology, then it'd be great to hear from you. Thank you for your time.
Thank you, Jordan, and thank you, Keith. Just if I can take the metaphor of the scaffolding, I think what you're seeing from our first 3 presentations is a scaffolding, a supporting scaffolding for Welsh innovation in health technology. So to cap off that scaffold in the first session, I'd like to invite my colleague, Associate Professor and Director of Research at ATiC, Dr. Sean Jenkins, along with Gethin Roberts from Iterate to come and close off this first session.
Hi, good morning everybody. I actually was so enthralled by the talks earlier I forgot that I had to do one. Just very, very quickly, because I'm conscious of the time. Do you want me to? You do it. As a few people have already mentioned, it's not the technology that matters, it's the people and the stories. So bear with us on that side. So what I wanted to do is try and round off this session, sort of looking at some of the achievements, but also looking towards the future as well for ATiC and Accelerate. So if you want to push ahead. So working together with our colleagues in Cardiff and Swansea University and the Life Science Hub Wales has actually been a really fantastic experience over the last 3 or 4 years. The diversity of stuff that we've worked on is quite amazing, I think. We've worked on projects that involved real hospitals through to virtual hospitals. We've worked with people with dementia, with learning disabilities. We've worked with clinicians. We've worked with industry. And it's really fantastic how the collaboration between us as well has been able to support these companies to develop these amazing new technologies. And part of that, the unique nature of what we've been doing, that sort of multidisciplinary, sort of inclusive, diverse approach to the work we've done has enabled us to get recognition worldwide as well. So ATiC was the first reference laboratory for NOLDUS in the world, and that was because of the kind of mixture of research approaches and technologies that we were using within a sort of design research-led environment. So I think that flavour, that uniqueness that Accelerate has brought and the funding has offered us to build those partnerships has been really, really important. And you can see from some of the stories today how effective that partnership has been. Part of that has been working with industry. So Gethin's kindly offered to talk about his experience of working with Accelerate. But you can see there's been an awful lot of different types of businesses and enterprises that we've worked with, from early startups, literally graduate entrepreneurs, right the way through to larger, perhaps more well-known companies, and operating again with partners in some of these sort of multi-partner collaborations have been really exciting. So we mentioned Innature earlier, that's a good example, and also Kenning with Cardiff on the Future Hospitals project. So there's been lots of interaction between the partners and building up those long-term relationships, which has been fantastic. Also as well, working internally with partners such as the psychology team in UWTSD or colleagues in the Welsh Academy of Physical Literacy, working with them as well on research projects, which have, given rise to research papers and conference presentations already. So I think that diversity, again, across Welsh industry is really encouraging for the future in terms of meeting the needs of the health and well-being of Wales. Next one. Interesting thing about this collaboration has been the ability to work with NHS Wales as well. And that's, although working with them directly, we required sort of industry partners as part of that relationship. What's happened as a result of Accelerate is we've built up some really strong relationships with the health boards, which are going to continue, and you'll be able to see some examples of that in a minute. So obviously, we mentioned the award-winning Professor Chris Hopkins. Congratulations, Chris. Obviously, we've got a really good working relationship now with TriTech, and that involves sort of secondment of Chris to ATiC for the next 5 years. Also involves Billy's secondment, and there's a few things that we'll talk about over the course of the day, projects that we've done together and ambitions for the future. Another exciting thing to announce is a collaboration between ATiC, Swansea University, Cardiff University, and potentially other universities in the future, with the 3 rehabilitation engineering units in Wales. So that's, Dr. Lorna Tasker is going to talk about that later today, but that's been funded by the Wales Innovation Network. We've got about £90,000, which is going to help us fund some pilot projects and develop a network and an online platform to support collaboration in the future to meet the sort of rehabilitation needs of Wales post-COVID. So if we could move on to the next slide. Another exciting thing that we've achieved through Accelerate is building up those relationships and partnerships that have allowed us to work more closely with other research centres as well. So not only internally within UWTSD, but externally as well. So we've been able to built up a really good working relationship with the Owen Institute, and we're currently working with them on an Innovate UK funded project, which actually Gethin's involved with as well. So that's about £500,000 over 18 months, and addressing the challenges of healthy ageing and sort of ageing workforce in the future. We've also been able to work with them and Cynyddu, and I think we've got Dr. Jane Mullins here today to talk about an initiative that's grown out of that as well, to do with dementia, sensation, and potentially designing responses for people living with dementia. And a lot of that's been stimulated by early work we did with Kimberly Littlemore and Pocket Medic. Some of you may have seen the films that Kimberly's produced, but what's exciting about that relationship is it's been building momentum in that community and lots of interest about what potentially we could do next to support people living with dementia. So, and I think Kimberly's actually and ATiC have been shortlisted in the Green Gown Awards as a result of that project in terms of impact on society. So there's lots of exciting things developing, with those relationships that we've built up over the last few years. Most exciting for us, I think, we've talked about the future. We're working together as a partnership to try and build Accelerate 2.0, and that's a work in progress. For ATiC, I'd like to thank the Vice-Chancellor and the senior management team. They've committed to supporting ATiC in the future, so we've got some transitional funding from UWTSD now until we can get to the point where we're a self-sustaining research centre. The full team have been made permanent members of staff now to take us beyond the European funding, and we're going to be moving to a new home in the innovation matrix on campus in Swansea around this time next year. So we'll have a dedicated facility to continue working with our partners in terms of assistive technology, digital healthcare, and medical technology. Last slide from me. So I think it's better that Gethin explains how the collaboration has worked, but ATiC is going to continue collaborating. We're going to continue innovating in health and well-being, and we're going to continue transforming lives. And as part of this partnership with Accelerate, I think it's allowed us to achieve an awful lot, and I think that partnership could continue to achieve an awful lot more to meet the needs of health and well-being in Wales. So thank you for that. I'll introduce Gethin.
Cheers. Good morning, everybody. So, have we got my presentation? So, my name is Gethin Roberts, and I'm from a company called Iterate. We are a product development consultancy based in Chepstow, and I'm really pleased to be here today to talk to you about quite a long and emotional journey that we've been on with ATiC and my design team. And so, back in the end of 2019, we were approached by a lady called Karen Coley. Karen has got a form of muscular dystrophy. If we could jump to the next slide, please. So this is Karen. She's got, it's actually an undiagnosed form of muscular dystrophy, but she has the inability to be able to move either of her arms. She has a small amount of movement in her wrists, and so she struggles to be able to perform daily tasks like brushing her teeth, brushing her hair, using a computer mouse, and this kind of thing. So off the back of an Innovate UK project that we worked on, Karen had seen some of the outputs from that particular project, and she approached Iterate to help her develop a new system. So the system that you can see on screen isn't the one that we created. It's something which already exists in the market. It's by a company called NITA, and it is an assistive system for people that don't have mobility in their arms. And with a small remote control, it's meant to be able to allow people to provide mobility. But because Karen doesn't have any mobility whatsoever, this system is not really suitable for her particular use. The other thing that Karen really didn't like about this is the obtrusiveness of this product, because Karen works full-time, and she didn't like the attention that this actually grabbed when she went into a room and just generally out shopping and that kind of thing. So the brief for my design team was to be able to create something that would actually give her the mobility in her arms, but didn't have the same level of obtrusiveness that this existing product did. Okay, so as I mentioned, we wanted to be able to achieve 4 key functions really to allow Karen to reach a mouse, to be able to brush her hair, brush her teeth, and also feed herself. So we visited her, we spent some time with Karen, and we took key dimensions of her body posture, key dimensions of her wheelchair, to be able to start to generate some design ideas of how this possible system could come together to give her the mobility in her arms. So we've got quite an established design process that we work on, no matter what that product is that we're actually creating. And so typically we carry out research, we go through concept designs, detail and prototyping. And so this kind of slide summarizes a big part of that actually. So we carried out quite extensive research within our office, and what we were really doing was trying to get a better data set of various limb lengths, various reach lengths, to be able to help better inform us really on the design that we were creating, because without a broader set of information at this point, you know, we only had the data that we had from Karen to act on. So we wanted to put Karen's data into perspective really. So we went through quite a thorough research phase, and very early on we decided that we wanted to use, or we felt that the best method was to use linear actuators to be able to create some kind of motor-driven system to be able to move Karen's right arm in particular directions. And so we created some design concepts, particularly how the product could look, but also the electronic and mechanical design as to what components we needed to use and how this would integrate into the arm support system. Okay, next. Okay, so when we'd created a design that wasn't the final design, because we planned for a number of prototype iterations, we built our first off prototype. And it was really at this point that we were kind of struggling with the idea as to, you know, how do we test this design? How do we validate that what we've done is right? And which is really at the point just before then that we reached out to ATiC to be able to help us understand the scenario, I suppose, better than we did previously. The kind of the backdrop to this entire project was COVID-19 as well, and we had really limited access to Karen throughout this whole period, which didn't make the delivery of the project particularly easy, because she was very vulnerable, and even when we were out of lockdown, there was reservations for our design team going to see her. So when we created our first prototype, before we actually delivered it to Karen, we carried out testing, or ATiC carried out testing in the lab to be able to just assess the general functionality of it. Which is what you can see on the left-hand side, the lab testing. And what we were really trying to understand was, were we hitting the key points that we'd targeted, and did it offer an improved level of mobility? And I think that at this point the answer was yes, really. And so we then visited Karen, and we fitted this motorised armrest to the side of her chair. And there was some immediate lessons that we learned from doing this. And what we found was that her position in the chair wasn't typical to an able-bodied person, and that she would actually, her natural resting position was to be twisted in the chair. And so as a result of this, when the arm support was in the most natural position for her, it was almost nearly fully extended. So the travel that we provided to allow her to reach into the table in that natural position had essentially been consumed, and so we were only given an extra 40-50 mils worth of travel. The second thing is the position of the rear support that we put behind the elbow wasn't comfortable, because her arm would naturally go off to the side rather than in a vertical and horizontal position like you could see in the test participant. And so, and then a third thing actually was that because of the natural resting position, when the vertical actuator moved the arm upwards, rather than bringing the wrist up to the face so that she could perform tasks, it would actually move the elbow up towards the face. So there were some fundamental lessons that we learned from this that we built into the design moving forward. So, as I mentioned, we'd planned for a number of prototype iterations, and so what we did very quickly was to implement these design changes, print a revised prototype, and take this to Karen. And on this second visit, the team from ATiC, so Sean and Ian, visited Karen with my design team to get a better analysis of the revised prototype. And even though this was much more improved, what we found is that it still really wasn't reaching some of the key points. So if we could just jump on to the next slide. So ATiC were able to take video evidence of the movement Karen was experiencing when the actuators were being moved, but also, and probably most importantly, 3D scan data of start and finish points for each of the tasks that we were aiming to perform. And so, as I say, even though this revised prototype was much better than the earlier one, we were still quite away from missing some of the key targets. So it was at this point we realised that the introduction of a third axis plane would be very valuable, because the arm support, using the remote control in the left hand, the arm support would allow Karen to move her arm forwards, and that was the reach was much better than we'd experienced before. But also that vertical movement still wasn't quite there because the hand was still away from the face. And I think that kind of forced us to reflect on some of the earlier tests where, as an able-bodied person, you're more naturally inclined to compensate for reach into the face. And while Karen is able to do that, I think we underestimated the extent that we were compensating in that way that she's not able to do so. So this third plane was introduced to be able to reach across the body, as well as moving forward and backwards and upwards. Okay, so this, my colleague Chris tells me that this is the most important slide of this presentation, and I'll do my best to explain it, because it was the critical information that we didn't know that we needed at the beginning of the process, and I think without ATiC's involvement, we would have never really hit on this. So we changed the configuration of the design so that we had essentially the two actuators would work synchronously, and so that would enable us to translate the rest position into the correct vertical position, but also achieve this sideways movement that we didn't have in the previous design. But the 3D scan data provided us with a real deep understanding of what that movement journey needed to look like. Because even though we had a start and a finish point that we'd taken from our measurements, understanding what that comfortable window of movement could look like was really, the gem in the whole project, really. So if we could just jump on to the next slide. So these are some 3D CAD visuals of the final design that we've produced, and we're very nearly close to delivering the final working prototype to Karen. And so the premise throughout the project has still remained the same. So we've got a horizontal actuator followed by a linear actuator, but the way that they work together and the introduction of this third axis to move the arm inward to be able to reach to the face, but also to avoid the actual controller on the wheelchair, combining all of these elements based on the understanding that we obtained from the input from ATiC, has allowed us to reach this point, and that we're due to deliver this to Karen shortly, and we're confident that this is going to achieve what she wanted to achieve from the beginning. Okay, so this is just the conclusion. So as I said at the beginning, we are a product design consultancy, and it was only really because of our experience in electronic and mechanical design and also additive manufacturing that Karen felt that we were the right people to work with her on this project, although we'd had no previous experience of designing for disability. And I think what we've learned is that designing for disability is hard, and that we're commonly designing for a known group of people. But when you're creating product solutions for a very unique individual, we found that it's a complete mindset shift, really, to be able to design for such unique circumstances. So that's been a huge learning for our business. And I think finally, just to thank, Sean, Ian, Yaja, Nick, and the team at ATiC for their input on this project, really, because without their intervention along the way, this wouldn't have been anywhere near what it is today. So thank you.
Well, thank you, Gethin, and thank you, Sean. Well, we've had 4 presentations so far, and we've just scratched the surface, really. What we're hopefully seeing through these presentations to date is that, and I hope what we've whetted the appetite for the rest of the day, is that innovation is complex, incremental, sustaining, disruptive, radical, but we like to think it has to be human-centred and it has to be transformative. And I think that's what Accelerate has provided, is a framework to enable disruptive and transformative innovation to flourish. So we're going to have a break now, so if we can gather back here by 11:30, when we'll take the story to the next level by having presentations of various partners outside of the big 4, should we say, who have worked together with Accelerate to develop what has been a truly remarkable Welsh success story. So please, have a cup of tea, take time to have a chat with some of the exhibitors up on the balcony and around the room, and see you back here at 11:30. Thank you so much. Can I invite people to take their places again, please? Colleagues, if we can invite people forward to take their seats. I know, yeah. This is less lunch. Okay, the longer we take, the less time you'll have for lunch. So, can I encourage people from the coffee area to come forward? I see it's corporate comms doing all the talking back there. Okay. Thanks, Tim. If you can shepherd people forward. Well, welcome back, everybody. I think these events I've seen now are notorious because there's so many clinicians involved in the audience coming and going between clinics and meetings that it can be a bit disjointed. So if we can come back quite promptly at the end of the sessions, and there's plenty of space at the front as well if you want to come forward. It's like, I made a joke at this at a staff development event the other week. I said, I know you all like sitting in the back seat, but there's plenty of room up the front next to the driver. And thank you. Nobody laughed when I said it in the staff development. Okay. Well, this morning we had before the break, we had really a kind of an overview of the contribution of the four primary partners in Accelerate and 4 case studies of specific successful relationships. This session really examines the whole notion of accelerating innovation through collaboration, and we've got some really exciting speakers in this session. So I won't do everybody en masse. I'll introduce the speakers individually. So can I call upon Professor Chris Hopkins, who is Head of Innovation at the TriTech Institute at Hywel, and newly appointed Clinical Science Director here at the University of Wales, Trinity St David. Chris.
Thank you, Ian. Thank yous, first of all. It might have been done already this morning, so my apologies if I'm duplicating. Thank you to Medwyn, the Vice-Chancellor of the University, for the support for today's event. Thank you to Ian. But more importantly, thank you to ATiC. Sometimes we forget how much work goes in behind the scenes for the organising around this event, and I had first-hand experience of a few telephone calls from Sean yesterday. So they're gonna tell me off for this, but all of the ATiC team, if you're not already standing, can you stand, please? And let's have a round of applause for the ATiC team. Thank you. The next bit, it's been a bit cryptic this morning about some sort of award ceremony that I had the honour of attending this week. It was NHS England, and it was the Chief Scientific Officer's Award for Excellence in various categories. And I had the privilege of accepting the award for Excellence in Research and Innovation on behalf of TriTech, ATiC, HTC, and all of our partners and collaborators. So my thanks again to everybody involved in that. I am going to go off-piste a little bit. I'm going to talk about, well, very little detail in my speech because I'm going to leave that to the various presenters now that follow. But I just wanted to talk about maybe the intrinsic nature of collaboration and why it's really, really important that we continue with this this vision of commercial partners, academia and health working together. Okay, so a little bit about TriTech first of all, for those that don't know. We established TriTech back probably about 18 months ago during the height of the pandemic to really drive technology, research, evaluation and an element of advice and consultancy for local industry partners as well. And it's gone from strength to strength. We've got a team of engineers, scientists, researchers, clinicians, and a dedicated team that do nothing but look at digital and hard technology innovation opportunities. And some centres specialise in particular areas. We don't. We look at every single opportunity and try to assess what the patient impact and organisational impact is on those technologies. So some will fall by the by, some will continue then to a mature position. 15 years ago, somebody said to me that, well, they actually called me a maverick at the time, which I took quite negatively, if I'm honest. But after a few days of reflection, I actually thought that's quite a positive comment, because I don't like the status quo. I like shaking things up, if I'm honest. And we have to. If I think of health in particular, we cannot continue the way we are at the moment. We do have to change and change fundamentally. And we can only do that with the support of our academic colleagues and our commercial colleagues as well. So next slide, if we can have a little look at, I won't talk, sorry, we can skip this one. I won't talk about TriTech or the innovation team as a whole, but I want to talk about these individuals more than anything. So people have already alluded to this. I have a joint post as of 2 weeks ago. I'm now the clinical science director within ATiC, and I'm also the head of innovation and TriTech within the health board. If you look at Professor Keir Lewis, our clinical lead, Keir is the clinical lead of TriTech. He is the medical director of Respiratory Innovation Wales, and he's also an academic within Swansea University. I hope you'll start to see now where I'm going with this now, with these partnerships. Dr. Leighton Phillips. Dr. Leighton Phillips is our Director of Research, Innovation and University Partnerships, but he also has value-based healthcare within his portfolio as well. And as of very recently, he also holds an honorary chair within Aberystwyth University. So that title is wrong. He's now become Professor Leighton Phillips. Why is that important? As far as his portfolio is concerned, it's the value-based healthcare elements, because value-based healthcare is an intrinsic part of the evaluation work we do. Dr. Rachel Germain, my deputy. Where is she, Rachel? I've lost her. She's got a hand up at the back there. Rachel has a strong research background, but also has an honorary senior lecturer post at Swansea University. Next slide, if we could. And if you notice, I'm not just, because even though we're separate organisations, I consider this a team. It's a complete team. I consider Sean and Ian friends, not just colleagues, and I also consider Naomi in Swansea University and HTC a friend and colleague as well. Billy Woods, I'm going to single out Billy Woods and Matt Lawrence here, because again, they've got joint posts. Billy is a clinical scientist by background with a specialty in rehab engineering, but he has a joint post within ATiC. He spends 50% of his time within ATiC, and he spends 50% of his time with us in TriTech. And likewise, Dr. Matthew Lawrence, very strong research background again, spends half of his time in HTC in Swansea University and half of his time in TriTech in the Health Board. What does all that mean? Well, talk about finances first of all. We've all bought into this partnership. So all of these joint posts are funded by the Health Board and by the university. But ultimately, why do we do it? We do it because Billy, I'll use Billy as an example, Billy will sit in our various team meetings and he'll be part of the various projects and opportunities we're discussing. And then the latter end of the week, he'll go down to ATiC and he'll be speaking about other things in ATiC. But it's about a bit of a mind melt, a bit of a fertility sort of opportunity, really, to start to see what's going on in the university, what's going on in health, what's going on with these commercial partners as well, and start to bring it all together to really sort of strengthen that collaboration opportunity. Next slide, if we could. I'm not going to go into any detail on these. I'm just giving you a bit of a flavour, really, on some of the case studies we've worked on over the last few months, few years. This one is on Neuroco. It's a Neuroco. It's a pain management device for osteoarthritis of the knee. And that was a collaboration between TriTech, ATiC, and the commercial partner Neuroco. I'm going to leave that. I'm not going to talk about any detail because I'm sure Billy will pick up on this in his presentation a little later. Next one. Next one is an evaluation of a new primary care pain service that Dr. Matthew Lawrence is working on in conjunction with Pfizer. The important bit here for me is that there are spin-offs to this that have generated additional opportunities for Swansea University in particular around other work. Case study 3, if we could. This is Lumen. So this isn't technology. This is more general innovation. But again, this is working with an organisation called Moondance Cancer, who fund any real cancer improvement opportunities across Wales. And this is talking about early access to lung cancer opportunities and treatment. It's also a finalist. The model is still in pilot stage at the moment, but it's also a finalist for the UK Mediplex Innovation Awards this year. Next one, please. NG Pod. Again, we've got Marcus. I think Marcus is up next from NG Pod. This was an opportunity between TriTech and NG Pod themselves. And the important bit here, anybody that's got a clinical background here, the important bit is that we've known for years that nasogastric tube placement is a risky procedure. And more often than not, we take aspirate from the stomach, measure the pH level to make sure that that tube is in the right place. If it's in the wrong place, the consequences can be quite catastrophic. So this is a new device, a very simple device that gives you a simple yes or no whether you're in the right place or not. And then case study 5, and this is my own. This is an AI MRI opportunity to look at prostate cancer. So what we're looking at is applying the Gyfer model. Gyfer are the commercial partner in this. It was funded by Moondance Cancer over a 9-month period to run a pilot and an evaluation. We're looking at how effective this model can be in detecting cancer or not cancer, as the case may be. Now, preliminary work, prior to actually running this in a real-world environment, was suggesting sensitivity levels of plus 90%. And specificity of over 90%. What we found in a 9-month period is that the sensitivity is very good, hitting about 96%. The specificity at the moment is only hitting 22%. So it's that application of an ideal model into a real-world environment is giving us an additional question. So we're looking at extending this evaluation now for a further 4 months to see if we can improve the specificity results. But again, it's an example of collaboration between numerous partners. And I think that is it. No, it's not. No, it's not. There's one more. Collaboration for me is key. Collaboration is fundamental to everything we do. We can't do everything in isolation as far as ATiC is concerned, as far as TriTech is concerned. You're just not going to get anywhere. It has annoyed me over the years that, it's been very silo mentality. People are quite protective over their ideas and their innovations. But I'm sad, I suppose, really, that I'm at the last 10 years of my career, and now it's opening up. So I intend to make the most of the next 10 years, and I'm extremely pleased for the future generation of researchers and scientists and everybody else who are hopefully going to capitalise on this enormous opportunity. All of these are the partners that we've worked with, and I make no exception. They are commercial, academic, and health partners. And that's something that has to continue post-Accelerate. We can't be protective over these ideas. If there's one thing we've learned from the pandemic, when you need to resolve complex health issues, it needs to be multi-sector as far as the approach is concerned. And there's no reason, as long as you've got collaboration agreements and you've sorted out your IP and everything else, as long as you've got the governance around that, there's no reason why we can't continue to collaborate in the future. That's me done. Thank you.
Thank you, Chris. I think that echoes the theme, isn't it, of multidisciplinary and multi-sectoral partnership. to help us solve problems. Now, we're living in challenging days where we need both sides of the brain to work together. The creative, expansive, as well as the analytical and the scientific, to work together to solve our greatest problems, particularly in health. Well, I'd like to call up Marcus Innocent now, Chief Marketing Officer of NGPod, to give us an overview of the project and the collaboration. I think Chris mentioned this in his presentation. So, Marcus, over to you.
So, first of all, thank you very much for inviting me here. Actually, after hearing some of the projects and products this morning, I feel really old school. I have a hard medical device. It's a little thing there, and it's a bedside test. But actually, what it can do is make a massive difference to patient safety and to staff time and health system resources. Can I have the next slide, please? I want to talk a little bit about why collaboration is so important to a company like NGPod, and what we look for in a partner. And I'm going to talk a little bit about what we don't want as much as what we do want. But the good news is, as Professor Walsh suggested this morning, you are better at what we need in Wales than any other bit of the UK. But before I really get into it, I think I should make the point that from a commercial perspective, and particularly from the point of an SME or a startup, which is in essence what we were, you shouldn't bring an innovation to start off with to the UK healthcare market. You shouldn't. Unless you're a masochist and unless you're really resilient and you have backers who have very deep pockets, or you're prepared to give a lot of equity away, and you have a game-changing product, and you really know what you're doing. And also, unless you're prepared to find and work with, collaborate with partners, trusting them, and forge a mutually beneficial relationship. Because quite honestly, folks, introducing new health tech innovation into the UK is hard, and I absolutely understand why people develop their IP here and launch on a distribution export only model. And we really, really considered that. We didn't because, as you might be able to get, I'm from the north of England, I'm from Yorkshire, and everybody else in the NGPod team is from the north of England. Sadly, some of them are Lancastrians, but I can just about manage to be in the same room as them. And we are all really stubborn, bloody-minded people, and it was a matter of pride that we have been successful in different companies in the UK market before, and we were determined to start here and bring the benefits here. I can have the next slide, please. So I'm going to talk a little bit about NGPod, give you a sense of how did that happen? Give you a sense of what the product is, what it does. Talk to you about the barriers we face, and I'm going to talk to you about the money it takes to get even to the point we are at, and some of those numbers may actually surprise you. And then I'm going to talk about what we're looking for, what we look for in a partner, and what we found certainly in the TriTech team. So can I have the next one, please? So a little bit of context. As Chris said, NGPod's a new way to determine the correct position of a nasogastric tube before you use it. We use about 1 million nasogastric tubes in the UK, and it's really important to check the position, because if you don't get it in the stomach, and it's a blind insertion, if you don't get it in the stomach, you stand a chance of having it in the lungs. And if you put hydration, nutrition, and medication into the lungs, you either really injure the patient or you kill them. And using a misplaced nasogastric tube is a never event. It is up there with the class of incident that's the same as cutting off the wrong limb, leaving something in a body cavity, entirely wrong site surgery. Thankfully, we're only the 4th most common never event. It's much more common to do wrong site surgery. You know, NG Pod, one of the good things about it is it uses the established first-line method of checking nasogastric tube position, pH, but massively improves how it does that compared to the legacy methods. So it takes out a lot of, it's much more successful than aspirate and pH, and it takes out a lot of the human factors. Can I have the next one? Cool. So just to give you a bit more background, as Chris said, we have known this is a problem for a long time. And despite many reports, MPSA and recently BayPen and the HSIB saying what we're doing is rubbish, the technology we have is rubbish, we've kept trying to do the same thing and it's not getting any better. And if I can have the next one. This is the number of never events related to nasogastric tubes since using a misplaced NG tube became a never event. And as you can see, it's not really going down. The dip, actually, if I was to be cynical, was until that spike in the middle, hospitals in England got fined if they had a never event. So the reporting wasn't very good and the numbers were suppressed. And as soon as they didn't get fined, the reporting got better. You know, it's kind of, it sort of makes sense. So we have a recurring problem that isn't getting better. Next slide, please. And when you look at the reasons, and this is from the last 2 years, complete data, apparently misleading pH test result. People have to interpret that. Placement checks not described, but the biggest one is actually X-ray misinterpretation. So if you can't get an aspirate, you have to send the patient for an X-ray, and a human has to read the X-ray. And not only is that the biggest cause of never events, it also causes between a 6 and 12 and sometimes longer delay in the patient receiving their treatment. So this is a big problem, not just from a safety perspective, but from a recovery perspective. Have the next one, please. The legacy systems have multiple issues relating to them, and these are not stuff from me. This is stuff from the HSIB report. The HSIB actually managed to find problems with pH strips I hadn't thought of. I am very grateful to them. And next one, please. NG Pod. Oh, that looks not like my slide. But NG Pod gets all over those and is much more successful. So that is, so next one, please. The other thing to say is NG Pod is a completely UK-based company. We are based in Runcorn. We were almost based in Wales. We nearly came over the border, but the incentives in Halton were slightly better than the incentives in North Wales at the time. But I will say we are about to move our sterilisation to Wales. So with Ekin Surgical in Cardiff. So we're going to have a Wales connection. So next slide, please. Now, I've just given you a whistle-stop tour of NG Pod, and you would have thought that given what it does, it would be adopted by a healthcare system, it would be really easy to get it in, we would make it available, and it would walk into the NHS. No. We're 17 months into launch. Now, you know, some idiot of a chief marketing officer decided to launch it in the middle of a pandemic. But we do have 6 accounts now currently using it. We are no longer pre-revenue, but we are definitely not in profit. And I'm going to show you why. Next slide. So I said I was going to give you an idea of what it costs to get a pretty simple medical device to the point where you can start selling it. This is entirely pre-revenue. So capital equipment, 190 grand. That's for manufacturing. And these are our numbers, so some more complex devices will be much more. Just getting the regulatory approval is 170k. And every year, our notified body comes back and charges us £10,500 per audit. And if they decide they'd quite like to do another audit, like if they're a bit quiet and they're not making their financial targets, they just decide they're going to do another audit, and you have no choice. One of the good things about manufacturing in the UK is that if you manufacture abroad, your notified body can fly to China, India, anywhere else you're manufacturing. They travel business class. They charge you £3,000 per auditor per day for the travel, as well as the price of the travel. And they just decide they're doing it. So we're lucky. We're in the UK. We only have to pay £10,500 per audit when we're not even selling any yet. So we have spent 2.9 million on the device and the technology around it. We have had a £900,000 grant from Innovate UK for the automation of the process, especially around, we use a sensor, and it's for the automation of the manufacture of the sensor. And on the clinical trial, so there's just the clinical trial, £250,000. That's a really cheap clinical trial, really cheap. We did some of it ourselves. We have suffered from slowness from doing that. But we got 125k, so we got match funding from that, again, from Innovate UK. So if I can have the next one. Plus, now, we are manufacturing and we are running a business, and it costs £60,000 a month in wages, marketing, facilities, so the office and what have you. Now, the senior team, none of us are full-time. The business can't afford to pay us full-time. We do more days than we're paid to do, and none of us take what we would normally get. So that's a suppressed figure, but you can see that actually it takes a lot of money to get one really simple device to market and keep it there. So, and this is going to inform a little bit about what we want from a partner. So if we can have the next one. If I look at the barriers, you know, we have a product, it's game-changing. I love this product, it's the most exciting product I've ever sold. I'm old, I've sold a lot of products. But what we've got against that, and this is only a summary, is, you know, we've got depleted resources in the NHS. We know we've got a staffing crisis at frontline staff. So bandwidth is narrow and priorities are multiple. We have had a pandemic. That didn't help. We've also got a situation where culturally any change is seen as we don't want to do it. Interestingly, that has come back after a period in the pandemic when change was enforced and everybody could prove that we could do it. But now we seem to have gone back a bit. And also, we've got a situation where change is equated with risk, even if the change you are making reduces the risk you know you've had for 20 years, and that you know you are still injuring and killing patients. But it's, people focus on making this change as a risk. You know, and kind of, it's quite difficult to shift that. We've also got a very hierarchical NHS, and we've also got very fragmented decision-making. I'm not saying these things as a criticism. This is how these are the barriers we approach. And I was saying to the guys earlier that, you know, there's 1,200 hospitals in the UK, and it doesn't matter how good your clinical trial is, doesn't matter what evidence you've got. Every single one of them wants to do an evaluation. So, you know, one of the things is, if you want innovation in the healthcare sector from med tech companies, the small, really innovative SMEs will go bust if that's what we have to do. And that's one of the reasons why we're in Wales. And I'll come onto that a little bit more later. So, if I can have the next one, please. So, partnerships. Next one. We have a really limited resource to engage. If I'm doing exploratory discussions with a potential partner, I'm not spending it pushing accounts through a sales funnel. I am not out there training clinical staff how to use the product and getting them really comfortable with it and nagging them to use it. It can be really difficult to justify to internal stakeholders and investors why you are exploring something intangible sometimes when it's at the beginning. And so I wanted to talk a little bit about what an SME needs from a partner. Next one. So key things that we're looking for. We need partners that bring something we can't do. We need partners that know relevant stuff, and stuff could be anything that we don't know, and know systems in a way that we don't. And we need partners who are going to take the time to understand what we're doing and why it's important. And this is a big one, and this is perhaps a little undiplomatic. We need partners that do stuff, not just talk about it. We need partners that give as well as take, and I will come on to that a little bit more. We need partners that open doors, that don't just point us at them. And actually, when it works really well, walk through the door with us. People that work the system with you, that get passionate about the mission, and actually my experience is, in Wales, people have understood, taken the time, and got passionate about what we potentially bring, that stay committed, because it takes ages, and that ultimately make progress come faster. Next one, please. So, I have kissed a lot of frogs. Okay. This is again perhaps controversial. I would not come to spend a day out of my time with limited bandwidth that we have talking for an academic health science network in England. I would not do it. I'm doing it here because we have a two-way relationship with Life Science of Wales and with TriTech, because they actually do stuff. And what happens quite often is, some NHS organisations, the NIA, AHSNs, government departments, they want you to fill in a lot of forms. They want you to explain a lot of stuff. And then they send you forms every year asking you questions so that they can take credit for any progress you make without actually doing anything for you. And yes, that does piss me off, okay? Because I have so little bandwidth, our team has so little bandwidth. But I'm happy to come here because stuff has happened in Wales. Next one, please. So, as we said, we worked with Life Science Hub Wales and TriTech. And quite honestly, when it came up, I'd just about given up on trying to get support and assistance from organisations in England. I should have come to Wales sooner. When I ended up with a chance conversation with Andrew Hall from Life Sciences Hub Wales, Andrew moved on shortly, but he passed me on to Jonathan Morgan. And actually, this is the bit about people understanding the mission, taking the time. Jonathan really got what NG-Pod could do. He took a lot of time to understand it and worked really hard to find out not just where we should go and who we should talk to. He took us. He did things like, it's a shame he's not here because I could, really sort of raise his profile. People move on a lot in Wales. Andrew Hall moved on quickly. Jonathan Morgan's gone the robotic surgery thing. You need to leave people doing stuff, especially the ones that are working with me who are really good. He didn't do passive signposting. He spoke to people, he hunted them down, he booked meetings, and he came to the meeting. He made stuff happen. That is what we need in a partner when we're an SME with an innovation. We had some really quite high-level meetings with stakeholders. I could not have got those people in a room, and it was a virtual room, but we were in a room. And we ended up talking to people who could remove barriers and who also created some opportunities for us to talk to other people. Manufacturers and innovators need people to help us through the system. And actually, John introduced me to TriTech and Matthew and the value-based healthcare programme. Now, I have to say, TriTech services are not inexpensive. They aren't clinical trial money, but it was a lot to us. It was a lot to us. And I had to work really hard to get the money out of the business because it wasn't budgeted for. And we had discussions with AHSNs about real-world validations. And actually, it was ending up, we were going to have to do all the work. And, you know, it fell flat on its ass. So, you know, there was a bit of a punt. But the approach is different in Wales. The difference was with TriTech is they added something we didn't have, and they were going to do something that we couldn't make happen on our own. Matt has run our service evaluation. He's coming up soon. Boy, we have had our money's worth out of that. The report, but again, it's that commitment. He has gone over and above what he should have had to do. Some of that, I'm sure he will talk about, is the system, but he has done it. And again, it's he has dragged himself into units to try and keep the momentum going. The report's almost done. I won't steal any of his thunder, but for the last few months, Matt has cared about this project at least as much as I have, and I would like to publicly thank him for that. If the results are good, which we believe they will be, I'm going to be working with Christopher Rolls who in Life Science Hub Wales to take it forward, see what other levers we can pull. Matt's already opened up some other discussions for me with SMTL, who are really interested. It has been a really different experience in Wales, not just the organisations and structures, but actually the people. You have some really good people here, and they care about the projects they're involved with. And when it gets hard, they don't go, oh, well, maybe we won't bother. And from an innovator perspective, that is very impressive. Next slide, please. So we talked about this is what we need. Next one. I have to say, these were my asks. And actually, what I've had from Life Science Hub Wales and from TriTech is this. I haven't had that anywhere else. So what I would say is, and we were early adopters for TriTech. I don't think you'd even had the launch meeting and we'd signed up, you know. So we were early adopters. I'm not saying it's perfect. I think the guys have learnt a lot from the early projects. It is going to be really useful to us. I think it's going to be different to what we thought we might get, but it's still going to be really useful. So thank you for listening. I hope that message was not too undiplomatic. Diplomatic is never a term that's used in relation to me. And next one, please. NG Pod, if anybody is interested in having a discussion about having a go and rolling it out in a health board, if there are any health board people left, I would love to have that discussion with you because we have tried it in Wales and proves it works. Thank you.
Thank you, Marcus. I think we like people to say it as it is, and it's important to say it as it is, isn't it? You know, I think one of the things that COVID taught us early on was cut through the waffle and let's get on with some action. Thoughts come to mind. How often do we put things in the too hard basket because they take too long to develop? So it's cheaper to buy it off the shelf from overseas. But then, as we learned in the last 2-3 years, supply chain reliability falls apart when there's pressures internationally. What about our carbon footprint? What about building up the resilience of our own industries? And that's been part of the mission of accelerators, to build up resilience within the Welsh manufacturing sector. So, music to our ears always, okay? We need some truth. Next speaker is the Chief Commercial Officer from Cynyddu Limited, Jackie Crooks. So, Jackie, please come to the podium. Thank you.
It's a long walk. I should give you a clap. Thank you. slide, thanks. Hello everyone, nice to meet you. Jackie Crooks. I am from Cynyddu, and I've spent 30 years in the IT industry, and I'm just going to this morning do something slightly different and share my observations and insights about the power of collaboration and mindset on innovation. And next slide please. So I formed Cynyddu back in 2016 with a former colleague. At that point we'd spent more than 2 decades in IT, and we created a company that when we started it, we knew we wanted to do something in IoT, but we didn't know what we wanted to do. And we then invested, so I really identify with Marcus's journey as well. So we started bootstrapping and built and created from the ground up an IoT software platform. And the gap that we had identified was we'd spent a long time selling into NHS Wales, into NHS England, Ireland and Scotland. And we knew there was a gap in the market for someone who could be small and agile and help big organisations to adopt IoT and to really drive those efficiencies, to improve patient experiences, to lower risk, but importantly to lower service costs, because the NHS is stretched to breaking point. It needs to do more with less, so technology is the way forward. Next slide. So in those couple of decades where I worked for very large American corporations, I thought to myself about how I would contrast and compare the different impacts of culture and leadership. I haven't named these organisations because I don't want to end up in litigation. So organisation number 1, they were the new kids on the block. They had big ideas, they were a disruptor, and at that point in time, very much diverse sales teams, very willing to see and to grasp early on that actually you get a high-performing team when you can blend age and experience and different life perspectives and different skills. And if you work hard to build a really strong culture, then that rewards you with collaborative environments, more innovation, more learning, more empowerment of teams, more empowerment of individuals. So that was a very fast-growing organisation, constantly hiring new people because of the growth, but that was constant new energy coming into the business as well, and the succession plan never stood still. So the impact of that culture was that they were constantly growing and gaining market share against their competitors, so a really great place to work. And then organisation number 2, also a good place to work, but very steady, not terribly innovative as well, seen as a very safe pair of hands by UK government, NHS and defence, and still so today. Direction was set in the USA, but what they got wrong was it was a one-size-fits-all, so it didn't matter whether you were in Wales or in India. You were meant to take the policies and apply them locally, even though it would be challenging for your customers and for your leadership to roll that out. The sales environment lacked diversity then. It was majority male. It was, I guess they had very extensive experience and they had been very successful, but it was very territorial because their knowledge was their power and they were unwilling to share that with other people. And that led to an environment that was very uncollaborative. Everybody was just looking out for themselves. It was lacking innovation and learning. Everybody was also quite complacent, so there was limited hiring, so no new energy coming into the business. The succession plan was a carbon copy, so if someone senior left, they were replaced with someone just like them, so there was no fresh thinking and fresh energy. And the result of that style was they were just losing market share to competitors. And several years after I left, they were actually acquired, and then the business was split up into multiple businesses. So they are no more. So the one thing I would say to all of you, and I've been so impressed this morning, I said to Chris Hopkins at the break, my home nation is Northern Ireland, and I would like to take a little sprinkle of this collaboration magic that is happening between the NHS and academia in Wales and sprinkle it at home, because it is fantastic and it is the way forward as well. So work hard to try and empower your team. So it doesn't matter if it's you and one other colleague or you have 10 people working for you. Invest in building those teams that have the right attitude, they are ready to can do and just get on with it as well. So our innovation journey really started in Wales as well. So we picked up an innovation contract with Life Science Hub Wales in 2019. And out of that, this small piece of innovation around automated patient flow became really transformational for our company. So we worked with clinical engineering, nurse teams and an A&E consultant. And really it was the A&E consultant's vision. He was working in a small regional general hospital in Wales. It was massively understaffed. A&E was also massively understaffed. They were constantly breaching their 4-hour and 12-hour targets. And they didn't have enough staff to check where people were in the process. And the collaboration that happened there was actually so simple but so magical. So clinical engineering understood the process, nursing understood a different part of the process, and the A&E consultant knew what he wanted from it. And so they provided all of that process insight. We provided the technology insights and how we would capture the data and then what we do with the data. And out of that, we created an IoT-enabled wristband. And then when people arrived at A&E, they would check in, they'd be asked for their consent to wear the wristband. 99% of people said yes. And it was only a 1-month trial, but what that did for A&E, for nurses who were just so time-strapped, was anybody could look at a screen at the nurses' station and see immediately how many people were in the waiting room, how many had been triaged, how many were in majors, minors, rhesus, x-ray, waiting for lab results. And the data that came from it was powerful. But the big lesson for us was stakeholders are so key to the journey, and the A&E consultant took a job in Qatar. So that was the end of the project. The clinical engineer who was leading moved on as well. So that went on the shelf, and but innovation is never wasted. Even if innovation fails, the insights and the learnings are so valuable. And about 6 months later, the Ministry of Defence came out with a competition for personnel accounting and locating on the 2 UK aircraft carriers. And so Joanne, my business partner, and I revisited the learnings from that regional general hospital in Wales, repurposed the technologies, repurposed the automation and the workflow, and we submitted that as a bid. And over the last 2 years, we've had 3 very major trials with the MOD, all paid for as well, Marcus, so MOD next. That has been phenomenal. And in July this year, we picked up a £1.2 million contract, which is so transformational for a small company from Belfast. And it really all started in Wales with just the insight of other people. So thank you, Wales. Next slide. I think what we learned when we first got selected for a trial with Defence, we'd spent our lives selling into the NHS and government, knew nothing about Defence, and we were really quite worried about it. But at the other end of the journey now, we realised how alike the NHS and Defence really are. You're very traditional organisations, very hierarchical. You're heavily reliant on your people. Safety of life is paramount. There's a lot of systems, processes and checklists because of that. You don't want to kill anybody, and the Navy don't want to kill the wrong people. So those are similar challenges, really. And capability is learned through training, and we saw that firsthand with the fantastic response to COVID. It just kicks in. So the incident happens and you all know what to do, and that is amazing. But you're both at the same point on your innovation journeys. There is way more technology and innovation at the front end. So for them on aircraft carriers and with aircraft, and for you in clinical diagnostics, but there's way less at the desk level. And our world is really not in deep tech and patents. Our world is in making a difference to the mundane, really. This is just a screenshot of one of our customers and a bit of our platform. And the only reason I'm sharing it is to show the transformational impact of very simple innovation. This was £20,000 and a lot of insight from clinical engineering in this trust in Yorkshire. Sorry. And they just really wanted to do something different.
South Yorkshire's never been Yorkshire.
And for us, IoT isn't about the sensor, it's about the data. So it's about data embedded in every interaction. And what this did for this trust that was really time poor, I guess, really, having to walk 30 to 40,000 steps between a small team around a very big complex, was it just gave them immediate visibility and insight of where everything was, the status of it. Could it be taken from A&E to a ward? Could it go home with the patient? And that has just been amazing for them. So the power of collaboration, so really happy to talk about two university health boards in Wales. First, Hywel, and we worked with Chris Hopkins and his team of clinical engineers on a community locating project. So medical devices are so expensive. So in particular, wound evacuation pumps and syringe drivers are a necessity for patients to enable them to live at home and to take medications and to deal with their conditions safely and in comfort. But what Hywel wanted to do was understand where all of their devices were when they went into the community, because some of them go in for a short time and some of them go in for a long time. And they wanted to be able to quickly identify them, retrieve them. It's about patient safety, so they wanted to service them, but they also wanted to redistribute them back out again because they didn't want to have to keep investing in buying more and more of the same thing. And so the knowledge about the device from clinical engineering and the knowledge about the process from clinical engineering combined with our knowledge about the different technology and the connectivity to get the data back to our platform in Hywel, particularly in West Wales where connectivity is not always the best, particularly in some of the rural areas. And that was all quite challenging. But the very simple innovation that came out of that was that Hywel now put a tiny sensor inside all of that equipment. It goes out into the community and it sends back location data to the Hywel clinical engineering team. And that has just saved a lot of management time in terms of looking through old records and sending emails and phoning community staff as well. So a very good example of simple innovation. And in Cymtaf, we worked with pharmacy and clinical engineering on medical gas replenishment. So they were very time poor as well, very stretched during the pandemic. Obviously, oxygen and Entonox really in demand during the pandemic. But the board had a rental model with their gas supplier. And that meant that they would return an empty gas bottle and get a replenished one. But when they couldn't find the empty ones, they were still paying for them on the rental model and getting no value because they weren't getting the full one. But demand was rising and they were really in a pickle. And so, like Hywel, the knowledge from pharmacy, the knowledge of the process from clinical engineering, and our knowledge in the technology space, and the fact that they already had our platform meant that that was a really simple project to roll out. So now pharmacy importers can tell at any point where the gas is and what the expiry date on the cylinder is as well. So it's all about patient safety at the end of the day. And I think those two examples show the power of collaboration as well. And for us, it is about the data. It's the insights that you get back from the data that inform simple things like optimal placement of gas or where you're most using wound pumps or where you're most using syringe drivers. I wanted to say something about failure to innovate because anyone of my generation probably had 3 or 4 Nokia phones on the way through. Nokia had colossal market share. They were not fazed in the slightest by the upstart that was Steve Jobs bringing a smartphone to the market. They thought that their users would be loyal. And actually, they moved in droves to the smartphone because they loved the interface. And although Nokia later brought a smartphone to the market, they never regained all of that control of those users. And I mention that only because the NHS is a huge brand. You are stretched to breaking point. So you need to innovate. So simple innovation and all of this deep innovation that is going on is going to be important to survive because your budgets are only going one way. You don't have unlimited resources, so you have to make ends meet. And technology obviously is the answer in collaboration and innovation. How do you innovate in a highly regulated environment? And I think the first thing is to embrace change. And I can see in this room today that everybody is prepared to embrace change and to collaborate as well. And I think what I learned in the second organisation that I talked about earlier on is if you don't embrace change and you sit back and let change be imposed on you or happen to you, you will resist it, resent it and become frustrated, and that is not a good place to be. So try and start to take your team on the journey, get them in the boat, all rowing the same direction, because when there's a greater purpose, it's a much happier place to work as well. And think about what your environments will look like in 10 years. You're all in different disciplines as well. There are big national programmes probably coming down the line. And what can you do now? What are the small step changes that will make that easier to adopt? And I think mindset and culture are key to thriving. So that positive outlook and can-do attitude as well. And start with the small improvements. And I think some of those small projects in Cymtaff and Hywel, which have not had much investment other than willingness and time, have just really been exceptional examples of what you can do with very little. You are blessed in Wales, 7 university health boards with an academic partner in the title. It's amazing. And then you have your ATiCs and your TriTechs. So they are just waiting to help and collaborate with you, which is amazing as well. But use your industry relationships. There are global healthcare players who are talking to the devolved nations, the UK government and other nations every day about their healthcare challenges. And they are happy to tell you what those are. They have horizon projects that you will not see for 3, 5 and 10 years, and they are happy to tell you about those as well. So keep yourself informed as well. And in Cynyddu, the things that keep Joanne and I awake at night are how can we make the mundane easier? How can we automate the thousands of common everyday tasks that take up people time? And that's really where we're headed. I'm going to finish by saying that change is necessary. So NHS Wales does not have unlimited budget or unlimited resources. It is looking to all of you to make the difference as well. And a 1% step change in efficiency would not touch the sides on the way down. But a 10% step change in efficiency is entirely possible with IoT. We see 200% and 300% change as well, and that would deliver nearly £1 billion of savings, which, you know, split between your health boards and trusts would make an enormous difference as well to deeper innovation as well. So my advice to everybody is to think big and to be bold and courageous in your collaboration journey and your innovation journey, but start your innovation journey today. Thank you.
Thank you, Jackie. I think I did listen to everything you said, but the thing that struck my mind was the NHS tries to save lives and the Royal Navy tries to kill the right people, or worse than effect. I thought it was a good one. I'm going to invite up Dr. Matthew Lawrence now, who's a research associate at TriTech. And as Matthew comes up, I just want to share one little anecdote, actually. We used to run a logistics course here at the university for many years, training the MOD on logistics. And they went on an exercise, done deep cut or somewhere, watching these squaddies being trained how to throw hand grenades. And they came in boxes of 6. So the command was given, typically, throw 5 hand grenades and then end of exercise. And they said, well, what happens to the 6th one? Oh, we just take it back to stores. And our team did an evaluation, and it worked out, say the cost of a hand grenade was 50 quid. The cost of taking that 1 hand grenade back to the stores, getting it checked and serviced by Royal Ordnance and repacked and sent back out was £350. So from then on, they said, throw 6 hand grenades. It was cheaper. Okay, so hopefully there's no more hand grenades coming this way. But Matthew, over to you.
Hi, so I've already been introduced. My name's Matthew Lawrence. As mentioned previously, I work for TriTech, but I'm also seconded half my time to the HTC. I will also mention another cap, and because I'd probably shake me if I didn't. I'm also chairman of one of the Wales Recs, one of the NHS Recs in Wales, and they'd always ask me, whenever I'm in a situation and speaking in front of lots of people, to say, if you want to become part of a rec, please do, because we're desperate for members and desperate for people to come and join the committees. So I'll just do that, and I can tick something off on my boxes there. So I'm going to sort of talk today about some things. I know Marcus is probably going to be upset because I'm not talking about EnergyPod. He probably thinks I should spend 100% of my time on EnergyPod. Some weeks I do, or it feels like I do. But today I'm going to talk about something else. And that's about one of my other projects. And it's not actually going to be about a single project. It's going to be about a program of work I developed with them. And that's with the chronic pain service, something which was mentioned earlier on today as an important aspect of healthcare and one that's probably not being well serviced at the moment. And I'm going to talk about my journey with them and how we developed a program of work together. Here's just a couple of the relationships which I've had to build and a couple of the collaborations I've had to build alongside the chronic pain service. And the reason why I want to focus really on the health board side of it is because we talked a lot about commercial partners today, but I think sometimes as engineers and scientists, and we get very focused on projects and deadlines, sometimes we don't see the broader picture. And I think when we're working in health, we really need to focus on the service that you're helping. You need to really focus on what do they need, what are their barriers, and what is really holding back their service, particularly in a very it's tough time for the health board at the moment. Lots of strained resources, lack of staff, and a growing need as well. So that's what I'm going to do today. I'm going to, actually, I'll just go back a bit, sorry. Oh, no, go on, sorry, lost my train of thought there. The one I'm going to talk about today is the chronic pain service. So before I start talking about the journey of how I developed the programme with them, I'll talk about what they do and who they are. So they're essentially anybody who's got a bit of pain and is causing you trouble in your life, they're there to help you, and they're there to provide services and help you get through that. By the best evidence, they apply this biopsychosocial approach. Never heard of it before. Being a laboratory-based scientist, that's essentially what my background is. And essentially, what they try to do is try to cover the actual physiology of it, the mental side of it, and also then all the social, economic, and community aspects to try and provide better services, to try and get you away from the way we classically deal with pain is chuck some medication at someone. So it's about trying to get people to self-manage their pain, trying to get away from medication, and trying to manage it in a different and more thoughtful way, usually through education and different types of ways. So Fionn John is the clinician who I work with on this project. She has a very multidisciplinary team, with lots of physiotherapists, nurses, pharmacists, consultants, and all sorts. And this is really the challenges that they face. So I actually suffer from pain. I've got bad hips. It's my misadventure in youth, playing sports. But essentially, if you've been involved in the pain pathway, you start off with a niggling pain and you go to try and get some help from your GP. You end up getting sent somewhere else, and then you go back and then you see a different GP, and then you get somewhere else. And it takes a very long time, particularly in Hywel. I think sometimes it can take up to 2 to 3 years before you finally get seen by the chronic pain service, which is held in secondary care, not in primary care. And to get to that level, you need to have a strong referral and diagnosis. 2 years is very, very long time. And pain is a spectrum. Starts off with persistent pain, ends up as chronic pain. And that long journey from persistent pain to chronic pain is generally exacerbated by the process. So the thing Fionn always says is we're missing targets, we're missing the point, and we're missing patients. And I think that's quite a strong message that's come through from Fionn and her team. So it's a bit small, but essentially what Fionn really wants to do is she wants to make sure people are receiving care in a timely fashion. She wants seamless services, so all the different departments talking to each other and working well together. That's very difficult within the NHS, anybody who's worked within the NHS. Reduce those waiting times. 2 years is far, far too long. And get people before they end up having chronic pain. Get them when they've just started their journey, when it's that persistent pain, where that biopsychosocial model will actually work for them. By the time someone gets to the chronic pain, they're generally beaten down, they have poor mental health, poor quality of life, and then trying to bring in education and trying to bring all this other side of it, that biopsychosocial approach, is generally too late for them. And that's something that we found in some of our work. Is we've got to get them right at the beginning, right at that first step, instead of waiting until they get to the end of the journey. I'm not going to spend too much time on this, but essentially the way they deliver their services is through what's called a pain management program. It's about 10 lectures or so, or 10 sessions that last 2 to 3 hours. They're done face-to-face or virtually because of COVID. And essentially the patient gets booked into these and they try to re-educate them, try to help them, try to reduce their dependence on medication. What's quite scary is probably this might even be a bit of a low estimate, but about 30% of people suffer from pain in the general population. And what's really interesting is by the time they get to Fionn in secondary care, and this comes back to that point I was making about people being broken down by the system, 50% of patients don't actually turn up to their pain management program. So even though you're trying to help them, even though they've got to the end of the journey, 50% of them will not take it up. And it's in Hywel, there's a lot of reasons for that. There's a rural setting, so it's quite hard to get people to get to clinics, those face-to-face, and even if it is virtual, a lot of these people may not be very tech-savvy, so it can be quite difficult then, and then the resources get spread, and it's quite difficult. And yeah, physical and mental health comorbidities, which might make it difficult to attend these types of services. In West Wales, we do also have quite a lot of people who prefer their services to be in Welsh. And that can be sometimes difficult, depending on the clinicians and the specialists you have. And length and the time of services are quite inconvenient. 2 to 3 hours and 10 of them over a short period of time is quite hard for some people to take up, especially if they have other life commitments. So what FIA wants to do, and this is why we've been brought on, is to try and bring technology into the paying service to try and get rid of some of these challenges and some of these barriers. So, and this is the problem Fionn had when she started her journey. Trying to understand the regulatory background to everything, understanding the processes, where I need to go, who I need to speak to. That's difficult enough just in our own institution, which I found out this week on one of my other projects, which I got caught out with. And I got some more forms I got to fill out and egos to massage. But that's fine, that's my job. Yeah, and so Fionn needed that sort of help. Someone like myself who has an understanding of ethics, governance, understanding of project management through my previous research studies. So that's why it was good for me to get teamed up with Fionn. And really it all started from HTC. So, like I said, half my time is in HTC. So this was a project which was already on the books at HTC before I even started. It was already being developed by one of the healthcare technologists there. And because of my link with Hywel, TriTech, and my background in governance, I got switched on to the project. And basically, what FIA wants to do is she wanted to develop a digital PMP. So that pain management program, is there a way so it becomes self-directed? Rather than have to have a clinician there, can we do it through an online learning management system where people can log on, look at these high-quality modules, go through each of those 10 courses themselves, self-evaluate, and then it's always there for them whenever they want to go back. They don't have to come back and see a clinician. They can always just log back onto their account, go to that particular module that they want to look at. And so Fionn had linked up with a company called OSP Healthcare. She's got some money from the Bevan Commission and some support from within Hywel itself to finish it off. And what she really needed from me was somebody to help her put in a research project, someone to write her documents, write her protocol, write her patient information sheets, and then manage the project, chase up the patients, help her with the administration of it, collect the data. Fionn's very, very busy. She's a working clinician. She has almost no time to do any of this, and so that's what my role is to come in to help her. And that's what TriTech does, that's what HTC does, that's what ATiC does, that's what we're here. We're the facilitators to help push this on, to help give them that extra expertise where they have the knowledge gaps and the extra pair of legs, pair of hands to push the projects through. So I'm not going to spend too much time, but this is essentially just a few slides on what the system is. It's fully completed, all 10 modules. We're in the middle of doing the study right now, so we've offered it to 106 people. We've consented 106 people. I won't tell you that all 106 have actually decided to log in, which is something I check up, and something I have to constantly be ringing. Again, you think you offer something, and everyone will just take it up, but it does need a human element. It does need somebody chasing them up. It does need someone being that point, that human contact to help them push them through. However, that doesn't need to be a clinical psychologist who's paid a lot of money. That just needs to be, somebody who's an administrator who can help push that through. So, yeah, we're hopefully due to finish recruitment now. We've collected a number of data. What I would say is the ones who have completed it, and we've got the exit surveys, only one person hasn't liked it so far. We've got 90% approval. People really like it. They've really found it useful. A couple of the interviews I've done, and one woman has said, it's massively reduced the medication that she needs to take, and it's given her so much more confidence, and she feels like she can get out of the house and start doing things again, which is, really, really great news. And why I talk this as a programme, because straight after, halfway through setting up this as a research study, Ffion also got the green light to implement a primary care pain management service. So when we said one of the big challenges was Ffion doesn't get to see people until they're right at the end of the pathway when they get to secondary care. So what Ffion wants to do to transform this service is that first point of contact, that GP can refer someone straight away who's got persistent pain before they get to that chronic pain, refer someone to the pain service, have a embedded clinical psychologist within primary care with a pharmacist sitting next to them to manage them, help them, train them, deliver that PMP, whether it is the digital PMP, which is still a research study, so it's not available as an actual service yet, or just through the face-to-face or virtual PMP, and then try and cut down that huge amount of lag in the system. And that's going to, if we can achieve this, it's going to save the system so much money. You think about all those referrals, all that doctor time. If we can cut all that out, we're going to have huge savings within the NHS. I mean, I think just with the pharmacist and what they've done so far, and the amount of, I think Ffion said in a previous talk, I think they've saved a couple million on the amount of drugs they've been able to reduce just by embedding a pharmacist in primary care to manage medication. So there's huge amounts of savings here. What was my role in this? So again, Ffion, no time. She needed someone to write a grant to Pfizer for us to do this service evaluation. So this isn't research. So I wrote a grant with Ffion. We got the grant from Pfizer, and then we also, there is a technology element to it. It doesn't sound like it, but there is. So also managing those patients, bringing in a digital platform, which is Patient Knows Best. So anybody within healthcare, secondary care probably has heard of Patient Knows Best. But essentially it's a tool which patients can log on to, and they can have direct contact with their physicians. They can look at their results from any sort of tests they've done, blood tests. And also it's a place where we can store all our repository of information. So we can store all those learning materials. So again, they don't have to come back to a clinician. They don't have to be ringing up the chronic pain service. Where's this document? Where's that document? It's all in one place. They can log on and get it. So that's just Patient Knows Best solution. Kind of just explained all that. So yeah, we just go straight on. So the next step. So after all that, we've got 2 projects running. That pain management, that service evaluation is probably due to end at the end of this year. So the next thing is the advanced practitioners in value-based healthcare, which is a new program which the Health Board is running. They've picked 8 particular priority areas, and it's going to run through a really fairly intensive course now within the Health Board, run by the value-based healthcare team at Hywel from September to May. And Ffion asked me to be part of her team. So she's brought me on board to sit with her, go to all these meetings, and really help her develop a plan for how she can best make a good business case to the Health Board of how we can bring in these primary care sort of pain service models across the Health Board, not just in one small place, and how we can bring in technology and innovation within. So I'm just going to leave it there. I think that's probably saved you some time there, probably brought it back a little bit. Maybe not.
Well, thank you, Matthew, and it was a really good roundup of that session. And in that session, we focused upon partnerships, we focused upon collaboration. Innovation can be quite messy. It's true open innovation means that you don't know the answer when you start, and it's about actually working with partners to try and refine and model and develop through iterations to achieve the best possible outcome. So hopefully we've got a flavour of that to the speakers in that last session. So thanks to Chris, thanks to Marcus, thanks to Jackie, thanks to Matt for leading us through that. I think the word journey came up many times in each presentation, and it is a journey. And so you'll be pleased to know our journey continues today by lunch. Okay, so we'll have a break now until 2 o'clock. Again, grab a lunch. Make sure you grab the right box, because I think if you've got dietary needs, make sure you go for the right box. Staff there will help point you in the right direction. And when we come back at 2, we move on. We move away from the innovation and technology into patients, and started talking about direct application into how we can empower patients through technology. So 2 o'clock, can I ask you to be back promptly at 2? I know we all want to chat, but use the hour well, visit the stands, have a network, have something to eat, have a cup of tea, but be back at 2. Thank you very much.
Two. Hey.
Two.
Well, good afternoon. Can I encourage people to come forward and take their seats? So if I can ask you to take your seats. I'll say it again, it's not just students that are afraid of the front rows. It's obviously researchers and clinicians who are afraid of the front seats. Well, welcome back. I hope you've had a good lunch, feeling refreshed and ready to go, not too sleepy. This afternoon's session, as we said earlier, is very much now focusing and turning the spotlight on empowering patients through technology. And we've got a great lineup of speakers this afternoon. First speaker is Professor Keir Lewis, clinical lead at the TriTech Institute at Hywel, but also medical director, and also of Respiratory Innovation in Wales. So privileged to have known Keir for a number of years. So prepare to face the whirlwind of ideas and activities. So Keir, the floor is yours.
So thank you again for the invite, Ian and team, and it's a pleasure to be here. Does this work this afternoon? I've been warned. It should work. Yes, it does. So I'm going to talk a little bit about patient collaborations, and I've literally come from a respiratory clinic this morning, so I am a practicing clinician where I still see and still enjoy seeing real-life patients, and it's a privilege to be part of them. These are my disclosures. As I say, I'm the medical director for Respiratory Innovation Wales, which we hopefully might hear about later on this afternoon as well. And then I do some other work for a local respiratory charity. So I'd like to talk about a patient-centered approach, a collaborative approach where patients are designing projects which I've been involved with. And I've picked 3 projects. They're going to have a respiratory bent, I'm afraid, because that's what I am, a lung doctor. And maybe some COVID stuff if you've not had enough of COVID already at the end. But they're patient-led projects. So we're going to start with the first one, so COPD PAL. And this came from an idea of this man, who is a man, many of you might know Ian Bond. He is a man with severe lung disease. And he said, I've got this idea. I write these reports, I write my home peak flow diaries and my symptoms every day on a crappy piece of paper, and I give it to the doctor and the GP, and he looks at it, he may put it in his pocket or file it in the notes, and it's there in black and white. And that's his peak flow diaries and his lung tests. And he said, how about if we made this electronic? Can it be done? And just run it through directly on no more bits of paper. First thing I learned about Ian is I said, you don't need to do peak flows in COPD, that's asthma. And he said, bugger off, Keir, it's my illness, I know it better than you. So I learned the lesson quite quickly from Ian that way. But the idea was great, and he got a lot of us involved in this project. And what he wanted to do was create an app or way of tracking his own symptoms and other people's symptoms to help guide health professionals and say, look, here it is, doctor, have a look. Not just the last week, but here, have a look over the last 2 years, 3 years, 10 years. Why not? So he thought, let's do this app, build an app. And I thought, build an app, it can't be that hard, but obviously I learned again the hard way. We took a design, and Ian helped design and build a company, and they built this first generation app, which, as you can see, looks fun and exciting, all doctor-led, all about symptoms, etc. And we gave it to 25 patients to look at. And we learned the hard way. And the patient said, what a load of rubbish. It doesn't, look at that. I mean, just look at it. So they said, have you actually looked on the internet and Twitter and Instagram? And these are people in their 70s telling me. So good for them. So the patient said, 11 to 25 focus groups. They said, I want something that's flexible, I can use. I want something I can use with stiff fingers because a lot of them have arthritis. Didn't think of that. They said the same things are being asked again and again. And how many apps and patient report questionnaires do we ask the same question every bloody day? And they said, no. Right? Shock number 4. And then it says, if I say I'm really breathless yesterday, you ask me today, are you really breathless? And I say yes. And tomorrow you'll ask me breathless, I'll say yes. And no one's acting on it, there's no flexibility. So again, we're thinking, who's going to act on it? No feedback was provided on our responses. You're just collecting the information. Why would I keep giving you information every day for nothing when no one's acting on it? And they really took us apart at these focus groups. And I sat there and I said, yeah, should include questions as well, relating about the holistic nature of disease. What about my anxiety or my depression, the fact I can't play football with my kids or my grandchildren, the fact that I can't take them to school because I'm so breathless I can't put my shoes on. We don't ask those kind of questions, but we certainly never asked about anxiety and depression, despite the fact that I know as a lung doctor, more than 40% of people with COPD have pathological, treatable levels of anxiety and depression. So they said, look at the holistic nature, Lewis and Bond, and do it better. So we designed it a bit better. And all of a sudden, the app's based on patient feedback and patient collaboration, not designed by doctors and technologists and scientists, it suddenly becomes a chat. It becomes a live action, interactive chat, not a series of boxes that people click which boxes for them that day. And I thought, yeah, my kids did the same. And even better than that, after spending many thousands of pounds on this technology, one of the patients went, why isn't it scrolling? And you could see the technologist go, oh, bollocks. Because we were pressing next page. And I said, you don't do that anymore. You have to scroll a page. Even my kids will scroll a page. You all know this. We don't think of that, but the patients told us. So we got it wrong. We had scales. And it doesn't project well. But then it was saying, this is a pollen count today. This is the temperature of today. This is your chance of having an exacerbation. This will drive your symptoms. And then the app starts to learn with AI or machine learning to give a personalized risk and give feedback to that patient. Red, green, yellow every single day. So they were monitoring their symptoms and getting feedback. Automated, but it was some sort of feedback. So we tweaked it, and the patients took it out then for 47 days and give us more feedback. And luckily, on average, I used it 32 out of 42 days. And okay, it's going to wane over time. But that was remarkable for the kind of things I've been trying to do with monitoring the people at home with lung disease. 89% said they would use it. 61% actually found it useful. 61%, that's great. That's really good for lung doctors. Normally it's like 10%. But they said they wanted to use it long term. And they said, and this is a bit clunky because you had to give us a phone. We were funded and we couldn't put apps on people's phones in those days because of information governance and clinical data collection. So we had to give them a mobile phone to play with on top of their own normal phone. Big mistake, yeah? So what you learn is from patient feedback, you base it in their own home with their phone. Don't give them another piece of shiny kit. Don't do that, they don't like it. So that's the feedback just from COPD PAL. And it worked, and it runs, and it collects data. We've published on it, and I'm not going to go into too much detail, but their hospitalizations, their GP appointments halved. Again, only for 6 weeks, but they went to see their GPs half as much. They went to see, they had a third of the people needed steroids over that 42 days. Same drugs, but they didn't need steroids because they were given feedback. We were monitoring them and saying, you'd be okay, sit through the breathlessness. So we reduced medications, we reduced visits, we reduced A&E visits, just on 25 people. It's not going to be statistically significant because we only had 25 people for 6 weeks. But there's a signal there which I thought was positive. So is it safe? Yes. Do patients use it? Only if you listen to them. They wouldn't use phase 1, they wouldn't use phase 2, but they did use phase 3. Can it collect new data? Yes, it can. It collects amazing stuff where we're seeing people, I see people once a year, once every 6 months, but now I can monitor people every day, and we can see these what we call subclinical exacerbations where people feel worse for 4 or 5 days and then they get better. They don't see a doctor, but is that leading to long-term lung damage? We don't know, but we can now collect that kind of data for free and they're providing it. And I'm learning. Does it make them feel better? No, there's no difference in quality of life or mastery scores and various psychological questionnaires, but they actually did go and see their GP far less. Does it impact on healthcare usage? It looks like it, but it wasn't powered to answer that question. So that was a patient app. Second feedback, this is a project called Viper. This is virtual pulmonary rehabilitation. And we know that pulmonary rehabilitation, where you have exercise programs up to 6 weeks, 2-3 times a week, It improves quality of life, it improves breathlessness scores, walking distances, time in hospital, length of time in hospital, and number of admissions. But we can't deliver it. We haven't got the staff, and we haven't got the people to support all these people in the geographical area. So what we thought we would try a sort of hybrid where we have a central hub in Carmarthen, that big central yellow dot, where the woman's on the bike, 3 staff there, and we beamed it live to a parallel course up in Tregaron. And that's proper, most of you know West Wales, that is in the wilds of beyond. It's a beautiful place, and it's a lovely little town, the village hall in the centre of Tregaron, where they ran a parallel group. And the reason why we chose Tregaron, because when we wrote to people in Tregaron, would you like to have pulmonary rehab that improves your quality of life, length of stay in hospital, they all said, bugger off, it's too far to go to Carmarthen. There is no way am I going to travel to Carmarthen twice a week for 6 weeks. I'm not going to do it, it's too far. So how can we deliver it? So we set up some Polycom interactive, and we had a district nurse sitting with them in case anyone collapsed, and the group was led through virtual rehab. They said, this is what we want. Why don't we try it in Tregaron? And then we said a second spoke in parallel to Llanelli Living Well Centre not in a hospital, never in a hospital, but outside in a industrial area. And that program ran for 6 to 8 weeks. Acceptance. So 92% of people we offered it to in Tregaron said, we'll go, and they turned up. Traditionally, for pulmonary rehab, we get 40% people attending. So 92% said we're going to do it. Even the hub went up to 80%. And most of them completed at least 90% of the 6 weeks. And these are people who are chronically, severely disabled, who have infections all the time, and they struggle. But the attendance, the pickup rate was amazing. Safety, we had one death in the hub group in the hospital, which is unrelated. They died of burst stomach ulcer on the wards, so they couldn't do pulmonary rehab. And we had one mild adverse event, again in the hospital, where one of the patients, before exercising, he was diabetic, and he went to Greg's and had a big, large donut, and then he exercised and had a hypo attack in the middle of our pulmonary rehab. I had to deem it as non-life-threatening and mild, and don't go to Greg's and eat a donut before exercising again if you're diabetic. That was our one adverse event. No adverse events in Tregaron, luckily, in the middle of nowhere. And looking at the carbon footprint, this was an unexpected advance, because the patient said, I'm driving all the time. So we calculated 12 patients driving back and forth to Tregaron, to Carmarthen, 6 weeks, twice a week. We saved 6,400 miles driving. That's 30 times to London in a family car, or driving to America and back. Remarkable. And their walking distance in both groups improved to the same amount. Incremental shuttle walk distance, they both improved. In fact, the spoke one in Tregaron improved more, because we had 2 particularly good men. Admission rates halved over the following year for the people in Tregaron and in the hub. So it does work, it's still effective, and we followed these people for a year. And the length of stay halved as well. So they went from spending, if they were admitted, 8 days in hospital to 4 days in hospital, because they were educated. They understood COPD, and they understood exacerbations. And they said, I want to go home now, I've had enough, I've had my steroids, get me out of here. And it worked. So the other benefits. I think Viper is a nice model to try at scale. It's virtual. It strengthens the local community. That's one of the nicest village halls I've ever seen, and it's unused 4 days a week. Why don't we use these communities far more than we're doing, and use technology and patients to activate all those other opportunities? Hospitals are crammed, they're dirty, they're infectious, there's no parking. I'd much rather do it in Tregaron if I lived there. And we have new partnerships. Comcon, Polycom, they're all very happy. Even Greg's were a little bit happy. They got their name in print, and it's a free product placement. It developed a staff. So these are quite stressed out and at times demotivated staff. We cannot exercise people. If someone collapses in Tregaron and I'm watching them on a monitor, 100 miles away, I'm responsible. I said, no, the person is responsible, and you can help support them. And the staff suddenly realized we can monitor and exercise people, make them walk around the village hall, make them walk between cones and do elastic resistor exercise training on oxygen, and no one died. Right, so let's take it to another level. And they won various awards. We won international awards and national awards, and even World Health. We went up to World Health, which was one thing I really enjoyed, the One Health Summit in Edinburgh, the WHO said, can you really save 6,000 miles driving with that carbon footprint and make people feel better and save the NHS money? You can if you listen to patients. There we are. There's some of the awards that the team have won, including a Prudent Healthcare winner, which is one in the NHS. And that's the one that I really think is good, if you can win that one for reducing inequalities. But it is about the patients, and the videos are on YouTube. I can send the links. This particular man had very severe SLE, and he did an amazing bit to camera saying, I had an inoperable disease. And he was upset. He was crying. He said, I rode my horse all my life. I sold it 4 years ago. And I gave up that horse. I was crying as the horse was given to my friend. He said, now I've ridden again for the first time in 4 years, when he wants to buy his horse back. And that's the kind of stuff that makes the team feel good, you know. And again, the publications are there on what the waiting lists were, what can be achieved, how cost effective it is, but the patient stories, that's what helps capture people's imagination. Not people like me with graphs, but it's their stories. And I urge you to watch that one, because he is a powerful speaker. And indeed, when we left, the team didn't tell me that they took out the caretaker for lunch that day on the last day of the pulmonary rehab, because he said, oh, this is amazing. This hall is being used. People are using it. I love it. They took him out for lunch and a beer, I think, and a Greg's. So that's Super-D and Viper. One of the current ones we're involved with, and I can see Rob at the back, so I've got to be very careful that he gets the credit he is definitely due, the Mobile Respiratory Unit. So we can't give pulmonary rehab in a community, but now, since COVID, we can't do lung tests in the community. For various political reasons, funding reasons, and safety reasons, people are not being diagnosed anymore with their lung conditions because it's not happening. So a group of us in RIW had this idea, and we've commissioned and funded and worked a mobile respiratory diagnostics unit, because the patients didn't want to come to hospital. They can't get it done in their GPs anymore. 3 years ago they could, now they can't. So can we take it to them? Do something radical? Do it near where they go? So we deliberately placed it in areas where people have footfall. Usual West Walian rugby clubs were very popular. And that's the Scarlets. I don't know if you can see at the bottom left, there's a Del Boy van again. I don't know where Del Boy comes from, but he's there on a couple of these occasions. But it's 2 lorries that drive between Cwmtath and Hywel health boards, and they do these mobile diagnostics, and they do spirometry, blow-in tests, reviews of your drugs, reviews of your symptoms. The nurses do it, there's no doctor on board, and they can upload the test directly to me, the GP, and everybody else. And the question is, it is popular. We're going to get 1,000 patients through it by the end of the next month. That's what it looks like inside. And the battles we've had, isn't it, Rob, about who's responsible for cleaning it? Who's responsible for the hand washing? How often is the hand washing water changed? How many room changes are there in this bus per day, per hour? I said, well, it depends if you open the windows or not and how fast you're driving. But, you know, these kind of things we had to do. And RIW did this, and the patient's feedback has been positive. This is the footfall on the bus, around 20 to 30 plus a week, and it's driving between the 2 health boards. Roughly between Hywel and Carmarthen is roughly 50-50, so both health boards have been engaged. And Karen, this is an example of how you can spin something up between 2 health boards, amazingly, not just 1 hospital. God. So we hope to get 1,100 patients through this, and we're collecting the patient feedback. They wanted this, many of them wanted this, but they have to now give us feedback and say, can it be better? What more can we put on the bus? We're collecting prems, the usual. I love some of the feedback already. Friendly staff, efficient. I was given the results immediately. I'm going to go and wait and see someone else. Closer to home, then is the Wi-Fi was playing up, which is true if you're wherever you are in West Wales sometimes. Difficult to locate. Well, I couldn't find this 2-story big white bus next to Haverfordwest Rugby Club. And the other one of the best ones was we had to walk upstairs. You know, there's a little lift to get up those 2-3 feet. And the other one was, it would be nice to have had a cup of tea and coffee. I thought, that's feedback we've got to give back to Welsh Government. Problems we're collecting, the outcomes, does it affect their admissions to hospital? Can we save on drug bills? Because a lot of these people were stopped unnecessary inhalers or stupid inhalers that were not appropriate because they hadn't had the right test. You give them the right test close to home, you change your inhalers, that actually saves the NHS money. Clinical outcomes we're collecting, it's ongoing, and it's becoming very last minute and rushed. And then we're looking at the value-based teams are working on this to put business cases to a health board or government. Do you want to commission this in the future? We know it's feasible. We know it's safe. Is it cost-effective is the question. It does take a lot of good work, and particularly I will take my hat off in public. Credit where credit's due is Rob and a team behind the scenes doing this work that the health board do not measure, but RIW is holding it together. And we do answer an immediate clinical lead. There is no spirometry in primary care in Wales. How can we match it? Do we just stop doing it? It's like sending someone to a diabetology clinic. I haven't done the blood glucose, but could you see me in your diabetic clinic? No, you need to do the glucose so we can decide how bad they are. And there's some new ideas about mobile x-rays on the bus. And lung screening is coming. It's now been ratified for lung cancer screening and things like that. So it's going to have huge impact on our resources in hospitals. Why don't we take it to places where people are more likely to turn up? Hospital car parks are no good. Supermarket car parks. Rugby clubs. Why not? And I keep saying, why not? And people can't answer me, why not? As long as we make it safe and affordable, why not? Can't be done, can't be done, can't be done. Ionizing certification, it can. So a little bit about some COVID work with patients. This is horrible times for us. Certainly on the acute phase, we tried some ventilators made by a local manufacturer, and we had feedback, and this is a man, he doesn't project well, with nurses giving real-time feedback how he felt that ventilator was in the middle of his acute severe illness in multi-organ failure. Semi-conscious, and he still wanted to give us feedback to make it better. Otherwise, we can't do acute research. So him, and respect to the man at the bottom who died about a week after that photograph, I owe it to the patients, the feedback, their collaboration to us. We owe it to them. During recovery, some work with some patients said, I'm really breathless post-COVID. And some good work at Swansea University and Mel McNavy's team. One of the few randomized controlled trials in the world to actually show that we can improve breathlessness by training people at home with an inspiratory test. They just breathe in and out. And the patients designed that study and worked with us on that one. And again, a little bit of long COVID. What do we do about long COVID? No one really knows. But again, working with patients and clinicians and feedback, RIW and Accelerate funded monies are trying to develop a real-time artificial intelligence-driven chatbot. Because we can't see all these people. There's 3 million people out there who are not being listened to. So these are some of the projects, Super PAL or Viper. These are just some examples of how I've been humbled, how I've been proved wrong again and again and again by patients deciding what they want. And you can use technology and you can innovate. But it is about the patients. And I urge you to have a look at this guy. This is a man who survived stage 4 kidney cancer. And he's worldwide. He's the only one I've ever seen with a TED Talk and had a standing ovation, the TED Talk. And just look him up, because he's got some powerful stuff to say. It is about the patients. Let us design what we want. We'll be your advocates for you. Work with us. So thank you so much.
Well, thank you, Keir. I think it was quite humbling, actually, because we've heard a lot about technology this morning. We've heard a lot about the challenges of doing innovation, but just to bring us back down to what it's all about, doesn't it, which is the patients. So thank you, Keir, for your excellent presentation this afternoon. Billy. So let's invite Billy Woods now, who is clinical scientist with TriTech at Hywel University Health Board, to take us on the next stage of our journey.
Brilliant. Thanks, Ian. Hi, how's it going? My name's Billy, clinical scientist with TriTech, and I'm also on to comment with the Assistive Technologies Innovation Centre, so I've got those 2 hats there. Gary, is this working? Brilliant. So what I would like to talk about today, I'm going to go into depth on a project that I worked on recently, and it's a really good example of not only collaboration between two teams, so TriTech and ATiC, it's also on this theme. It's a really good example of how we can engage patients and get their feedback and incorporate that feedback into the results that we're getting. So the way this project was split up, so TriTech handled the clinical elements. This was like clinical data collection. I see these patients in clinic at the start of their journey and collect all the information relating to their sort of clinical aspects. And then ATiC handled all the user experience sections, so I'll go into details about what that was, but this is where the patient engagement come in. This is where we got the information from them about their journey through this process. And we brought these two parts together into this real-world evaluation of TENS device in osteoarthritis knee. To give a bit of background about the patients themselves, I won't go into too much detail, just to give an appreciation of what these patients were going through. So for anybody that might not know, osteoarthritis is characterised by joint pain, stiffness, reduced range of motion. That can then lead on to things like muscle weakness, like greatly reduced quality of life, inability to do daily activities, just a general worsening of their overall health because they can't do what they would normally do. It affects approximately 1 in 5 adults over the age of 45. And knee replacement surgery is the most common and cost-effective procedure for these patients, but that doesn't generally happen until they're right at the end of their journey, so it wouldn't be done straight away. It's kind of like the last resort, so the surgeon, physiotherapists and other care providers will try and keep those patients as healthy as possible until surgery is needed, but inevitably these patients do need surgery. And waiting lists for surgery already quite long. It's already been mentioned. I'll mention it again, unfortunately, COVID, the pandemic, several lockdown periods just drove those waiting lists even higher. So these patients are already experiencing reduced quality of life. Their state of life's getting worse and worse. So quite rightly, we were interested in anything that we can do to improve those patients' quality of life while they're waiting for this surgery. So, and also bearing in mind pain control regimes pre, during and after surgery is also a key area of research. So looking at TENS devices for pain control was quite relevant. The device itself, so I mentioned TENS a couple of times. I appreciate not everybody might not know what that is. It stands for transcutaneous electrical nerve stimulation. You might have heard of it because it comes up in sporting applications, it comes up in just general rehab applications. It's sometimes helpful for people in pains. I've heard of people that know people that have used it for labour pains and things like that. It's a commonly available technology. It's something that you can buy from Boots or Argos, other stores. The concept behind that, again, if nobody knows, the theory is that TENS device will override the sensation to the brain, so you'd feel the sensation from the device instead of the sensation from the pain below the site where it's placed. But the research around this is quite inconclusive. So pain is subjective, so everybody will feel their pain and have their experience slightly different. So putting numbers to that pain relief is really hard to do. It's really hard to kind of pin down and put a number on that. But one of the benefits of this kind of technology is it's non-pharmacologic, it's not medicine-based. So I think in a previous talk today, medicines were mentioned around pain relief. So if you keep putting patients on more and more different types of pain relief, the potential side effects go up. So we're interested in kind of technologies that bypass that need for medication. And I mentioned NICE guidelines. Apologies if not, NICE guidelines is something that we use in the clinical field to give us indication of what we should or shouldn't be doing, and it's evidence-based. So NICE guidelines state that TENS devices should be considered as an adjunct to normal care. I'll highlight this word adjunct there because it just means in addition to, so these kind of devices would never replace this need for surgery or what the clinicians are currently doing in practice. And I'm just pointing this out to give a kind of picture of the devices themselves. And the devices used in this evaluation were provided by a company called Neurocore, and they were like wearable TENS devices that were kind of mobile, small, and these were what the patients were given for this evaluation. Moving on to very briefly like the evaluation design approach that we took. So the original question was, could these devices help these patients that are waiting for surgery? Could it help their quality of life and their pain levels? We broke this down into these two areas I mentioned previously. So clinically, we were interested in pain levels, their overall quality of life, and their knee functions and how the knee was progressing. And on the other side of that, bringing into these patient aspects, things around lifestyle, activities, hobbies, how they were using the devices, things that would affect whether or not they could use these kind of things. And then we wanted to bring all that together to say, what kind of impact do personal factors have on the clinical outcomes or the other way around. And I won't spend too much time on this. I just wanted to kind of introduce some of the clinical information types that we collected, because I'm hoping it will put into context some of the results that we were getting. So the three things clinically, so I've mentioned already, but pain VAS, visual analog scale, very simple. A patient can record from 0 to 10, whether they've got no pain at all or they've got the worst pain they can imagine. Quality of life, EQ5D. I appreciate many people here probably might not be clinical. EQ5Ds, it might come up a lot in other studies. It's just a patient-reported outcome measure. It's a questionnaire that patients can fill out themselves. They'll answer questions around these 5 areas, and they'll indicate whether or not they've got no difficulties at all the way through to extreme difficulty or unable to do an activity. And from these 5 areas, you can get an overall index score to indicate how that patient's kind of quality of life is. It's a really great measure to see if an intervention's had an impact from like a baseline to a time point on the quality of life. And in a similar vein, knee function score, or CUSBS, This was 7 metrics, but again, this can be scored between no problems at all the way through to extreme problems unable to do. And we can also get like an index score there to see whether or not somebody's condition has progressed. Moving on to the user experience elements that were collected then. So 4 elements were included in this. With initial survey was done after they were first seen in clinic. I'll give an example on the next slide. But the initial survey was asking their first impressions around these devices, any preconceptions they might have had, whether or not they thought it was going to help them or not. It was a little bit more personal. Each of the patients that were involved in this evaluation were given like a user diary pack they took home. I made a joke with them, it was a bit like homework because there were so many pages in there, but it was a chance for them to record loads of information around how they were using the devices, how their pain was changing week to week, and what their experiences were during the course of the whole thing. Interim interviews were conducted during the course of that, so they were phoned midway through to get an update how they were getting on once they had a chance to actually use the device, and again, give us feedback around their experiences. And then final interviews were done right at the end to get an idea of what their overall experiences was, things that they liked, things that they didn't like, and that's where we brought it all together. So I appreciate this is probably not very clear, apologies, but I've got like it was just 2 examples of some of these user diary pages they were given. On the left-hand side, you might not be able to see it, but it says, tell us about yourself and your lifestyle. This was the initial survey that they'd done, so this is where we wanted to start building the picture around who they were as a person, what kind of activities they would normally do, what kind of impact their pain was having on their usual activities. So we wanted to build a picture around if their knee osteoarthritis was stopping them from, like Lewis mentioned, a patient wanted to ride a horse. So we were getting that kind of feedback, you know, their activities or sports that they would normally do, and this is now what they can't do as a result of what they've got going on with their knee. On the right-hand side there, these were the user diary pages they were given, and this was a little bit more in-depth, and there was a chance for them to record how often they were using the device, what settings they were using, where they were placing it, whether or not it was effective. So we wanted honest feedback, so we collected all that in these diary pages. And for the evaluation format itself, just to give a bit of an indication of what the patients went through, so they were pre-screened, and then we called them for like a full screening process, and those that were included come into clinic at Prince Philip Hospital, where I gave them a device, I gave them training, explained what was involved in the evaluation, got baseline clinical measures. They were sent home with the device to use it at home. And then from then, the only kind of input they had from us, other than the interviews midway, was just capturing these clinical measures again at month 1, month 2, and month 3. So we just could see how they were progressing. And then at the end, we got them all back in on separate occasions just to see how they were going, to collect all information and just wrap it up there. 30 patients were involved in the study, and referencing NICE guidelines earlier, usual care was not changed during the course of this. So if they were on a waiting list for surgery, that was not affected. The clinicians' input into what they were going through, again, wasn't affected. So we kept this kind of real world scenario where we wasn't changing their usual care, it wasn't in change of anything else. And I highlight there that the patient consent collected was completely separate clinical and user experience. I just thought I'd highlight that because it was quite a key thing. So the patients, they'd come into clinic, they were given the device, they would sign consent to be involved with us, and then if they wanted to take part in the user experience part as well, when they filled out this initial survey, there was a secondary consent page with that. So the data collection was kept clean that way. And again, apologies for the people in the back, this might not be as clear. So just wanted to give an indication of the kind of things that we were able to do with the results by collecting both clinical and user experience. I'd like to bring your attention to the blue column. If you can't read it, it just says total use overall. So from the diary pages, we had an indication of how often they were using these devices. So we were able to just literally order them from those that used it the least to those that used it the most. So we could just break that group down into half and just see the half of the patients that use it the most versus the half that use it the least, just to see if there were any differences within that group. And I won't spend too much time on it, but we've got answers to some of the questions we gave them, like, you know, whether or not they thought this technology has a place in healthcare, whether they thought it's going to help them, and to see if there were any differences in these clinical scores going through. To kind of sum up some of the clinical scores we've got, I've got a table on the right with the median differences of groups from baseline to month 3, but the summary's in the 3 boxes. So if I looked at the whole group there, the pain score overall as a group, no change there. Quality of life got worse, their knee function got worse as a whole group. But when we broke them down into this least and most device use using the information we have from the user diaries, we're able to see that the least device use, their pain score got worse, quality of life got worse, knee function got worse. Whereas the group that used it the most, the pain score got better, quality of life still got worse, and their knee function had no change. I'll highlight a couple of things there. So the pain score getting worse or better, it wasn't statistically significant, even though it was just an overall change. But one of the key findings for us was this knee function score. So the group that used it the least see a decrease in those COOS PS scores, like the knee function score, whereas the group that used it the most had like a no change. The important thing to note is the way a TENS device works fundamentally, it won't have had any impact on the osteoarthritis, it won't have changed the underlying physiological condition, so it won't have improved the knee. So what happened there? So we wanted to know, and this is where this user experience, the patient feedback element was so important. So again, looking at this least and most device use, some of the comments we got back were really important in understanding what was happening there. So the group that used it the least didn't feel much pain relief, completely fair enough. Felt surgery was the only option. So there was patients that we were speaking to more in depth that felt that, you know, there was a question from us around did they want it to work? Maybe they were worried that they wouldn't get the surgery if it had an impact, even though we reassured them that wasn't the case. But it was interesting to get that feedback from them. And a lot of these patients genuinely didn't have the time to use it. You know, some were working full-time jobs, even though it was only 20 minutes use at a time. Some of these patients had long jobs, they were farmers, they were busy, didn't have time to use it, or didn't like the sensation from the device. Whereas the group that adopted this a lot more, actually used it a lot, they were reporting increased in activity levels, increased confidence of activity. Some of the feedback that was really important was things around, even though the pain relief was only temporary, it was really good for them to have something to come home and use after they'd done some kind of activity, been on a long walk. That was really reassuring for them. Even got a couple of reports around better sleep, reduced swelling of the knee, it becoming part of their routine. So that was really, really good for capture. On the right-hand side there, I've got a word cloud from Dr. Lles, who was part of the user experience aspects here. And this is just for the device itself. So again, taking this patient experience into account, even the patients that didn't feel like it was helpful to them were still giving us reports around the device is easy to use, it's easy to put on, it's simple, it's effective, not effective, but you know, it's easy to get going, but it didn't help me. So it's good that's good feedback that we could then give back to industry partners using this kind of process. And if I was going to look at the benefits, like the benefits of collaborative approach, if I was going to look at this separately, so if I only had the clinical data to go on, and the user experience elements were never part of this, all we would have to go on would have been, you know, no overall change in pain score, overall worsening of quality of life, overall worsening of knee function, and the feedback from those patients would have been quite limited, so it would have been easy just to write the whole thing off. It's not effective, wouldn't be any need to look any further. Contrast that against what we got with clinical and user experience. We're able to separate this group by device use. You know, even though there's a small number of patients, it will still give us an idea of if it's had any impact there. That most and least use highlighted something quite key there, this knee function score, and the fact that the ones that use it the most didn't see much of a change, and that there might have been reasons behind that, and that could be related to patient confidence rather than the device itself, but it's important that we were able to do that. The user experience interviews gave insights into adoption of the technology, so these things around, you know, their impact for their day-to-day life, their jobs, sensation levels, where they were using it in the home. There was so much more information that I haven't really got the time to go through in this 20-minute presentation, but we collected, you know, a lot more around that. It really gave some good insights onto why patients would adopt this technology and why they wouldn't. And we also got this feedback around activity levels, sleep, and change into swelling. So if we hadn't done these user experience elements, this would have been completely missed. We wouldn't have had that information to go on. So, and yeah, I already mentioned it, but feedback around device use is quite good for industry partners. If we did this kind of layout again, even with a different device, that feedback's really good to feedback to industry partners. And some closing thoughts there. So this collaborative evaluation is a great pilot for future work. We learned a lot between both teams, TriTech and ATiC, how to run this kind of evaluation, how to bring together these clinical and user experience elements. And off the back of that, if we were going to do future work with TENS devices or these patients, we now know where we'd take it next. So that the pain levels were quite subjective for these patients. So things around activity levels and sleep wasn't something that we'd set out to capture. But if we were going to do it again, we would then look at that next time, and we wouldn't have picked that up without the user experience elements that we did. And we captured way more data than was needed, but this was part of the learning we went through. We've got lots more data than I've been able to present today. Some of it was really key, some of it was less useful, but it was great for us to explore all those elements. And the patient engagement was actually really high. So we gave them all these user diary pages, didn't know how much of these would actually get completed, but most of the patients we spoke to were really engaged. They actually wanted to give us a feedback. They wanted to tell us about what their problems were, how we could help them, and how these devices could be made better for them in the future, which was really great. I'll just close up there. There was loads of people involved in this project, but 3 people I'd like to single out primarily: Mr. Peter Cynyddu for his clinical input into all of this, and Dr. Sean Jenkins and Dr. Lles, who isn't here today, for their user experience expertise in this whole thing. And thank you. Cheers.
Thank you, Billy. I think it's the first 2 presentations really emphasise the importance and the, in one sense it sounds obvious, doesn't it? Ask the people you're working with, ask the people you're treating, and they will bring insights which you can't do by yourself. So I think that's two great exemplars there of patient interaction empowerment. Well, our next speaker, I'm sure he's going to carry on the same theme in terms of that patient empowerment. So I'd like to introduce Dr. Jane Mullins, who's part of the Arwen Institute at Swansea University.
I'm a bit short, so should I just project? Can everyone hear me? So I'm just getting over tonsillitis. So okay. Thank you for a start, Ian and Sean, for inviting me. My presentation is going to be very different to everything that we've seen so far, and I don't know if that's a good thing or not. I do relate very much with what you said, Chris, earlier about being a maverick. I'm a nurse, and I've always been a maverick, and have always listened to the voice of people who have dementia, even 20 years ago when people weren't listening. Plus also what Keir was saying about the why not, why not. I'm always saying why not to people. I'm always bashing up against negativity all the time. So, but fortunately, I found my place, hopefully. Right, how do I do this? Oh, there we are. Which one is it? There we are. Working at Swansea University Arwen Institute, which is headed up by Professor Andrea Taylor. So I'm sort of representing our institute today. Basically, the Arwen Institute sits under the Centre for Innovative Ageing, alongside our sister site, which is the Centre for Ageing and Dementia Research. So all our research is around working with older people and people who have dementia, but also bearing in mind not everyone who has dementia is older either. The Arwen Institute is part funded by the European Regional Development Fund through Welsh Government, and it brings together researchers with older people and with the creative industries. The aim really is to produce products, environments, solutions to our ageing population. We also have a state-of-the-art living lab now at Swansea Uni, where we can actually start trialling some of these products. So any product designers that want to come and meet with us, we can actually start to work in there to try and create innovative solutions to our ageing population. So basically, what I want to talk to you about today really though is that recently we have just set up a sensory and attention network within the Centre for Innovative Ageing, because all of our backgrounds really are very much involved with, usually with sort of cognitive difficulties or sensory difficulties that older people experience. So for instance, Professor Tales, she's, all her research is around understanding vascular dementia and Alzheimer's disease in terms of their people's visual processing, how people are seeing when they have dementia. Also, alongside Emma Richards, her work very much is around hearing loss and place, and we're actually working on a bid at the moment exploring hearing loss for older people in noisy environments, which is a huge issue because we're listening to people and we're actually finding out what the problems are. Dr. Gary Christopher, he's a gerontologist. All his work is around psychology of aging, how people look at using nostalgia in reducing distress with people who have dementia. And that sort of links to my work. I'm a dementia nurse specialist and have my own training company as well as my research hat. And my passion is very much about helping people who have dementia communicate their needs, because over time they will start to struggle to communicate their needs or actually understand what's being said to them as well. So I'm going to talk to you a little bit about this, but actually I'm going to hand it over to people who've got dementia so you can listen to them a minute. Oh, gone the wrong way. So the network is quite new. Sean's joined us and we're hopefully going to work with ATiC quite closely with some of the ideas. We have researchers, practitioners, family carers, filmmakers, VR experts. So we're really trying to bring in sort of the creative industries as well. And some of the ideas already that are being talked about are about how colour and pattern can improve care for people with dementia. Looking at disability aids, and it's interesting looking at the gent upstairs who's created the colourful podiatry things for people with amputations. So looking at these sort of things, making things, understanding more of the sensory issues that people may be experiencing. And my passion, particularly my PhD, was all around looking at using multisensory ways to communicate with people who aren't able to communicate very well, who have dementia. So all our work we do is in co-production with people from the 3 Nations Dementia Working Group, who all have dementia, and they lobby government as well at the needs. They are really quite an activist group who are quite brilliant in telling us what they want, because they're sick of being told what they think they needed. And because most people are going to have difficulty expressing their needs later on, it's really important that we understand what their needs are earlier on. There's a dementia engagement and empowerment group who are the same. They're, again, getting their voices heard very much about what their needs are, what they want people to understand in terms of maybe their care or any medical treatment as well, or services. So really, I'm going to hand this over to part of my training.
Can I
put it on pause?
So I have a photograph of my family.
Sorry.
Wearing silly hats, which kind of sums the girls up.
My little Basically, this film is about finding out what's important to people. And most of the people in this film have dementia or they're carers. And I'd just like you to have a think about this yourselves, really. What's important to you? And what do these... If in a few years' time, most of the people in this film won't be able to express themselves. So actually think about what's important to them. And it's a bit of fun. It's very sensory. And then we can think about how that links to why things are important, really. So... And it's named My Favourite Things, which is named by Dr. Andy Woodhead, who was living with Lewy body dementia.
So I have a photograph of my family wearing silly hats, which kind of sums the girls up.
My little crystal guardian angel. I look at crystals and things quite a lot. Smells are important to me. So along with this crystal, I think what's important to me is the smell of lavender.
I was a landscape gardener for 20-something years. So I love the outdoors.
I don't know if people can see, it's a bit old really, but it's a photo book with me and my kids. So I'm a single parent and I have 3 kids, 2 girls and a boy.
It's a photograph of my dad, which I've got, there you go, you can see it nicely now. This is the last photograph that was ever taken of him. It's not a particularly well-posed photograph, but because it's the last one, it means a lot. He died not long after that photograph was taken.
My grandfather was a miner and he started working in the mines when he was 13 years old. And this was his lamp that he actually used. I think I don't know what it was run off, paraffin maybe? But I'm not living in Wales anymore, but you can take the girl out of Wales, but you can't take Wales out of the girl. And my Welsh roots are so important to me.
So I've brought this was a present from somebody. I do actually have a little flag thing there, sometimes on my desk. So it's actually a kind of, I don't know, a glass mirror made little rickshaw that somebody, a colleague actually brought from Pakistan, actually quite a few years back, and I've always kept it quite like that. This really, for me, is about heritage. Even though I'm Yorkshire born and bred, my parents came from Kashmir, Pakistani side of Kashmir.
Originally, I'm from Mumbai, but my ancestors are from south of India. So I have a mix of, a pot of mix I am. So I have my coffee, which comes from south. And this is the coffee I get from Mumbai. And this is a filter coffee, like I can't do without it. And when this is finished, I panic, So I always call for extra, and my sister sends it to me from Mumbai.
I have eaten Marmite since pretty much the day I was born.
I love this stuff. I'll have it on toast, biscuits. I'll just stick my finger in it and lick it. It is the best thing since sliced bread, for me, personally.
This is actually a semolina powder. Semolina, we call it in English, and we say upma. So I get this. This is like a breakfast, you know. If I have it, you mix water with it and then oil, and then I put a bit of another sauce I have. It gives that oomph and the taste, you know, like it's not bland. I remember when my mother was there, she used to make it so often. And she said, why do you make upma so often, you know? So she says, it's tasty. And it is, she didn't say it is easy, but she said it's tasty and it's good for health. But
when I have it, it reminds me of mum and dad when I was a really young child, because they would make me toasted fingers, and they just set a jar in front of me and I would dip the toasted fingers in the jar and eat the Marmite.
Something that reminds me of home, you know, and then sometimes it brings memories, you know, like.
It brings me a lot of memories from my childhood. It reminds me of my granny, which obviously is a nice feeling to have. So every time I smell lavender, I feel really comforted.
I knew one particular aftershave that I always use, right? And the amount of time, especially if I go to my son or something, and my granddaughter, she's 17, she'll walk in and she'll say, Grandpa's been here.
I love the smell of the sea. I love the smell of the sea. That reminds me of just amazing holidays with my wife and my kids along at Shell Bay, which is about half an hour down the road. Yeah, great times.
One of my favourite songs is Somewhere Over the Rainbow by Eva Cassidy. And it just takes me, you know, somewhere over the rainbow, I suppose. Music
has always been my kind of thing. Like, I've been in a few bands over my time, and I have here, you can see that. That's a CD of the band. That CD is about 34 years old, and it includes some of the tracks of the band. And I love listening to that now and again. It puts a smile on my face every time I hear it, because some of the music I just think, wow. Again.
I have a recorder, which is something that I absolutely love doing. It's kind of the only thing I have in terms of me time at the moment. I do it once a week with a group of 5 friends. We have a consort, and we play in people's gardens and at charity do's around Salisbury.
And that explains, if you like, my love of colour. I painted that myself. I think of colour being associated with mood because Picasso is known for his blue period. He went through a period where he painted only using the colours, different shades of blue, and it was much to do with the moods that he had at the time.
And the last thing I brought was a notebook and a pen, because I'm a writer. I write constantly. I'm always writing poems and little short stories, and yeah, blog posts and things. So I think that'll always be important to me, just to have somewhere to scribble down ideas.
It's an English translation of the Quran. One of the commandments is about honouring mother and father, and that is also about respecting older people. And so I bring that into my life, that what are the values that we have within faith? So I, as a Muslim, what does that mean? So there's a verse in there, for example, a small chapter that talks about, for you is your faith and to me is mine, which means that actually we can be equal and different.
I've been to a few groups for people with dementia. It's all things like Vera Lynn, World War II stuff. I'm only 57 years old. I don't want to hear that sort of stuff. I want to hear my generation of stuff, like, and because of that, I've never actually went back. I just thought, again, That's not what I want to hear. You have to get to learn to know the person, know their likes and dislikes. It's as simple as that. And once you do that, everybody's going to be happy.
What's important in terms of whether it's our memory, what's important to me, or what's my favourite things, what connects me, is that whole host of trying to understand the person as a collective, a whole person, and not just one aspect of that person.
So I'd just like to thank all the contributors to that film. I know it's very different from everything we've listened to today, but I think it shows the diversity of personal experience and what's important to people. And really looking at, if we can, what came out of that film really are things that we need to think about in terms of the senses. So when we're working with people who perhaps can't communicate very well, we need to be looking at different senses in how we can communicate. And objects are obviously important, whether they link to food or to memories. But the big things that seem to be important are family, happy memories, you know, and so the significance, this is what the research is about, is looking at the significance of these things and how when somebody isn't able to communicate, we may have some information on them that we can work with, whether in care or when people are in hospital, because people who have dementia, when they go into hospital, go through horrific experiences because it's a totally alien environment and nobody understands where they're coming from. So the aim from this really is, it may be something you might want to think about yourselves, what senses do you pick up on, but really we're looking at working with Sean at ATiC, because my research is around using multisensory ways, and it's at a very conceptual level at the moment, and we need to now try and find a way to turn it into something more tangible. So if anyone's got any ideas of turning it as some sort of tangible intervention, this is the bit I'm struggling with at the moment, please get in touch with me. So thank you for your time. Anyway.
Thank you, Jane. I mean, it was a very different, it was a change of pace then, wasn't it? But it was, I think it's important change of pace because, again, it puts people front and centre and people's lived experiences as well at the heart of healthcare and innovation. And as we move on, I'd like to invite now Professor Alka Ahuya, forgive my pronunciation, who's a consultant child and adolescent psychiatrist and national clinical lead for the Welsh Government in Technology-Enabled Care Programme. Welcome.
I am quite loud. I'll put my telling off voice otherwise. Good afternoon, everybody, and thank you very much for giving this opportunity. Sean, I know it's been a challenge putting all this together. I work as a child psychiatrist, and obviously I'm also a mum of 2 teenagers. So technology is something, I wasn't born in that generation, but I've learned as I've come along. I've also learned how to make the quickest Lego tower, and I've also learned how to rap, and I'll give you a snippet of that. Next, please. So just to talk about, how we work with young, I work with young people, but obviously with my national role, I've started now working with people across the lifespan. So I'm going from dementia right to the other side. We've done a lot in terms of technology, developing apps and doing sound walks, which is, again, I'll talk a bit about that, a 3D recorded medium for young people with autism when they're going through transition. We've done things with electronic feedback, a whole repository of digital stories, virtual reality, some work we're doing with Sean and his team, developing something for, again, young people with autism who often resist going to dentists, and unfortunately they're the worst in terms of dental hygiene, and virtual groups. And this is something that was 10 years back, so not COVID related, but obviously has become part of everyday life now. Next one. I'll talk about some case studies and give you just a snippet of how we've worked with young people, their families, and the wider public, and how that really brings a whole different lens. And I know Kia was talking about it. We often tend to go with, I'm a clinician, I know best, but I think when you work with young people, you just have to sit back and put your hands up because they do know much more when it comes to technology. So about me, as I said, I work as a child psychiatrist. My area of interest is autism. And when I first started my consultant job, I still remember it was very early on. I had one of the mums who came in. She was running late for the appointment. She came with a young boy who was going through an assessment. And she said, I'm really sorry I'm late. I've just gone to see the pedophile and we've come to see you now. And I was, red flags, child psychiatry, safeguarding, tell me more about him. And she said, oh, he's based in the county hospital, which is, I work in an R in Bevan. I said, what does he do? And she said, he sits in the room and he asks you all sorts of questions. Cut the story short, it was a pediatrician. But these families go through so many people, it's very hard to understand what the system is, what the pathway is, who's talking about what. So About Me, a paper version of the passport, came out from some of the dissatisfaction among the families about, how does autism get diagnosed? Why do I see so many people, speech and language therapists, child psychiatrists, and they wanted a one place where they could capture all this information, and they didn't really want to repeat because it can be quite traumatic going on repeating to every clinician you see. They thought it was fantastic. It fitted in with the nice guidance that came around that time that has to be very patient-centered, very family-centered. So we started working with a group of families and young people across Gwent. We've got 5 local authorities, so it was trying to capture feedback. And the kids were very good. They just got on with it. They were quite blunt. And again, young people with autism, that's what I like. They tell you as they see it. Starting off with, the color scheme, it had to be something quite subtle because, again, you mentioned about sensory issues. They didn't want something that's going to scream out to say autism passport. So it was about me. So it's something about me because, you don't want something on your shelf saying that you've got autism. And in terms of, again, language, I remember we were doing the last section and we were calling it glossary. And they were like, what is glossary? Why can't you say commonly used terms? So we went through the whole process, got this, launched it. We even won some awards for it. Next, please. And then they said, you know what, if I had to take this around, I'm not going to be walking with a paper passport where I go. That's so old-fashioned. Parents loved it, but the kids couldn't imagine. And at that time, I remember I was on call, and I had a phone call from A&E. In fact, I had 12 phone calls from A&E within an hour for this young person who had gone in and trashed the whole A&E department. And they were trying to sort of settle him down, and they said, oh, he's one of your psychos, you need to come out. And that's usually the language we hear. And the next thing, when I was driving up, I had a phone call from the exec team saying they had to shut down A&E because of the damage that had caused. Cut the story short, went there. This young boy had autism. Nobody had asked him what else was going on. He had come in with palpitations, and they were worried that he had arrhythmias. The family were trying to say he doesn't like crowded places. He doesn't like noisy environment. He had a meltdown because he was waiting there for 3 hours, and everybody was trying to get on top of him. Somebody was putting a blood pressure cuff. Somebody was trying to take his temperature. He just couldn't cope with it. What had happened that evening was he was in school, and the teacher had, marked some work and said, Johnny, you did it very half-heartedly. But Johnny, being very literal, had thought he had actually done it with half his heart, and probably he's just got half a heart, and that got the palpitation going and the A&E visit. So going back to the passport, would this be something you would take with you if you landed up in A&E to show people that you've got a diagnosis of autism? Kids said, no, we're not carrying this along with us. And when you go to A&E, you don't actually go back into the house and pick out something from the shelf. Why can't we have an app? So again, the young person who here happens to be coincidentally from Swansea. He, along with his friends, worked on this and developed a prototype app. And as we can see, we launched it in 2014, and since then we've had much refiner version where people can capture about their diagnosis, about their assessment, resources, and also things that matter to them. What makes them upset, what calms them down. Next, please. So as I said, it was thinking about them, taking them along with the journey, and being very transparent about it. Next, please. In fact, he and I went up to Manchester to get the award as well in the previous slide. We then developed an eating disorder app because, again, eating disorder is something that the cases have gone up so much, and especially in the given climate, the demand is ever increasing. And it was not just for patients, but it was for carers, it was for peers, it was for education staff across other agencies to make them aware and find out what services are there. So we went about local authority-wise every part of NHS Wales, and you could put in your postcode and find out what services were there in your area. But also in terms of resources, there were some checks in terms of if you were concerned about somebody in your family or yourself, you could do screening tools, which often are not 100% reliable, but at least it's a start. But in order to develop it, we wanted to make sure it's something that the young people would buy into. And that time we were working with some of the local high schools, and we went in and we said, we really want to work with them, find out what they would like in the app, a bit like what you were saying here, you know, not going in saying that this is what I want. And we were presented with the school council. Now, these are the brightest, the best of the school kids. And, you know, they were very good. They helped us design some of it, but we weren't getting very far. And how do we go out to the masses? So my colleague suggested, you know, can we come around lunchtime? And I know it's an eating disorder app, but you can never go wrong with Domino's. And can we order some Domino's? Next thing, we had a queue when we went next time because it was lunchtime and everybody wanted a bit of Domino's. So that was fine. The Domino's went down well. They helped us design the logo. They helped us design the content, the layout, just the way they wanted it. But we wanted to go beyond that because we were working with third sector as well. So we said, can we extend this into one of the lessons so that we get a wider, because a lot of young people will have eating difficulties, but not necessarily eating disorder, or sometimes may not even talk about it. And the input we had was almost from 5,000 young people in the end. And you can never go wrong with food, cakes, Domino's, you know, that's the secret. Next one, please. Similarly, the sound walk. This is a tool that is often used during transition and can be used by anybody, key worker, family member, lay person. Moving to high school is challenging for any young person. You know, my two kids started high school. First few weeks were a nightmare. You know, where do you get the bus? How do you move from one lesson to the other? It's very different to primary school where there's a lot of TLC. But for young people with autism, it can be even more challenging because it's all new, a lot of sensory overload, and it often can be quite difficult to navigate, as a result of which they often drop off. And once you drop off, the longer you are away from school to get back can be quite a challenge. So what the young people themselves suggested, is there any way we can get used to the school before we actually start it? And most places you can go and visit high schools before you start there, but it's usually first thing in the morning or end of the day when you don't get a true sense of the noise or what else is going on, because it's the best time. So you go there, but it's an empty school. So we went with a group of young people along with our digital providers and captured all the sounds in a school during daytime, starting from the school bell to what happens in the playground, to what happens at reception. Now, obviously, we can't do it in every school, but we had a generic map which the children put together, and then the red dots on that are plotted sounds. And we thought we had done quite well. When we went back, they said, what about, you know, the noise that happens when somebody drags a chair? Because children with autism are very sensitive. What happens when somebody's photocopying in the background? Can we capture that noise? So we have started building on, and you know, you can sort of go on increasing the number of sounds you can capture on that. And this is again available on the NHS Wales website. We have evaluated it, and it's just been amazing. It's a bit like based on behavior, where, you know, the more you expose people to something in a comfortable environment, they get used to it and they're more comfortable with it. Next, please. I'll talk a bit about virtual groups because, again, we've been trying to do this for the past 10 years, but, you know, we talk about technology, but often it's not the way it should be working, because the first challenge we faced, we tried to do it in a school. The firewalls in education don't match up with the firewalls in health. It was a no-go area. We were then told to use Skype for Business. Skype for Business only works within the NHS. It doesn't marry with public Skype. So anyway, I am quite resilient. I don't give up. And I know some of you have said that, you know, you just keep going. We then managed to do them alongside, you know, sort of some of the group of parents that were already running a group. So what it was, they were given a choice. So some of them would join in virtually and some would be in the room. And the dynamics was quite interesting. And this has been going on pre-COVID, and we still do that because unfortunately for autism, there aren't that many support groups or resources people can access. But something clever that came out from the parents and carers were, because they used to be co-facilitators, you know, it was a professional and a parent doing it, was can we develop some sort of a toolkit? So, you know, we talk about these things, but what about parents who can't attend these groups physically or virtually because they are working or they've got childcare? So they called it a survival toolkit. And again, the link, I'm happy to share, it's on YouTube. There are about 25 suggestions, tips about anything from toileting to eating to going to school that is captured, and anybody can access it. Next, please. Coach, again, some of you may have heard, bit cheesy, but again, the young people suggested that. And again, some of my colleagues here, you know, Gemma was very much part of it. This was a Health Foundation funded project which we started doing in 2019. It means connecting with telehealth to children in hospitals. So it was offering video appointments to children and young people, very much pushed by them because they said, you know, they talk to their family and friends with their mobile phones and they make video calls and FaceTime and Snapchat. Why can't they do that with their doctors and nurses? Now, this was before COVID. I know everybody does it now, but it was quite groundbreaking because we started initially in the hospital with those with eating disorder and severe self-harm. But the more we did of it, we felt we could do it in the community. We started linking in with some of the schools because unfortunately we had 2 suicides coming up to Christmas 2019, and a suicide in a school can often create a lot of anxiety. So we started virtual drop-in clinics there. And next, please, I think there's some animation. It saved time. Next, you know, we could discharge people on the pediatric ward in a timely manner, reduce the stress on the staff because we've got a very small team. Next, please. And again, carbon footprint we've heard. Next. And saving bed days. So apart, you know, everything from the logo to the name to the evaluation, the young people were very much in forefront. And sometimes it can be challenging, and Gemma can tell you that because they will tell you as they see it, and you've got to make changes, but then that's the way you do it when you work alongside patients and families. So we've heard change about changing, and we do have to change. Even as clinicians, I know some of my colleagues find it hard, but that's the way it's going to be if we want to work and make them use things that we develop. Next, please. Again, this was a body image eating disorder workshop where the young people put together tools that were online, and also you can see the logo. They didn't want something that's going to be too obviously related to eating. Next, please. Again, my national role, and I've got some of my colleagues, Sharon, Simon, Gemma there, is as a national clinical lead. And as part of Tech Cymru, which is technology-enabled care, we've got a very active young persons advisory panel, and they do keep us on our toes. So they've done loads of things. You know, they've published things alongside us. They've been part of national debates. A couple of them came along with me to give evidence at the Children and Young People's Committee on the COVID recovery plan. We ran a summer school along with them this year because, again, a lot of sixth formers, you know, didn't have an opportunity to shadow clinicians or come into healthcare settings because of COVID. And on one hand, we talk about recruitment, retention, but if we don't give them that exposure, how do they work? So we did a virtual summer school where they gave them a taste of what sort of disciplines, what sort of specialities are there, and what it would be to be in the day of a nurse, day of a physiotherapist, dietitian, psychologist. So we're going to build on that. And again, they've put together a lovely YouTube video on the impact of COVID on the environment. And this was anything from 2 to 23-year-olds that contributed. It is just unbelievable. Next, please. And these are some of the publications. So these are sixth form students, medical students doing their SSC, some of the Duke of Edinburgh students who didn't have an opportunity to do their voluntary placement work alongside us. We've got an HEIW digital fellow, and we've just appointed one of the medical students who's doing a digital fellowship alongside us. Next, please. This is the most recent piece of work we're doing. Again, Health Foundation funded terms, which is technology-enabled remote monitoring in school. This is, again, looking at young people with eating difficulties who need to come in to have their height, weight measured on a regular basis. But often it means young people having to miss school, having the stigma of coming to a mental health setting. Can we do it remotely alongside education? We've heard of all the advances that have happened with technology. You know, you've got Bluetooth devices where you can measure weight, blood pressure. That can be done, you know, in a school setting, and the kids absolutely engaged with us. In fact, again, this is a logo they've done and digitized it. Next, please. We went in with 100 sheets to get feedback from high school, and I was telling Gemma, oh, you don't be cutting trees unless it's needed. And in the end, we had 560 or so that we had to print out because they were desperate to have a say. And we've got this windscreen model that we're working on. So when we go into school, they start doing this. And Gemma does that all the time as well. So looking at, you know, across this way, because young people can have difficulties that can very often move from something quite mild to a crisis. Next, please. So this is just showing you some of the pictures of the workshop. Next, please. And as I mentioned, we've got loads of digital stories on the YouTube, which are very much co-produced, but also some of them are totally done by parents themselves and carers themselves, anything from toileting to sleep to myth busting. Next, please. So again, it's very exciting, and I get quite excited when I work with young people and their families, but it can be quite challenging as well. I think from their perspective, it can be very empowering to give somebody that respect, that importance, and be an equal partner with you. And to be honest, some of them do know a lot more than I do. I've read textbooks, I know what the textbooks say, but I'm always open to parents, coming in with printouts. Sometimes it does get a bit annoying, where they'll say, in Australia, there's this new treatment happening, have you read about it? It may not be evidence-based, it may not be evaluated, but it's worth just having that discussion and making them aware that everything that's there on the internet is not good, but I learn as well. There can sometimes be clash of agendas as well, especially some of these very experienced patients, you can find that the agendas and their intentions can be quite different. There can be other challenges where, we've gone into school to work with children and we've been told, the whole team lands there, we've got the animator, we've got the rapper there, and we've been told it's Inside Day today. No, did nobody tell you that? I was like, okay, fine. So, it's getting into that rhythm, and it's getting to sort of understand people have their own challenges. Next, please. And again, it's not a familiar territory. You're going into their houses, you're going into their schools, you're working alongside them. So you've got to be quite flexible. And I know all of us are busy, but these things often take much longer than you think they would. And it's being open to change, open to, even if it means changing the whole protocol or the whole project that you are doing, because it will bring a lot at the end. And I don't give up. I am a cockroach. That's what my friends call me, because cockroach is the only animal that survives in vacuum. So I really don't give up. And I think that's really important when you do these things. Next, please. That's my last slide. I've got a little video. I don't know if I've got 2 minutes to show that. Yeah. I won't show the whole one. It's the wrap I was talking about, because we were, again, the NHS, printing out leaflets for patients and families to tell them what autism is. So we started asking young people and said, why do you want leaflets? Can't we do a video? And this was pre-TikTok days. I'm sure they would love to do a TikTok video, but I'm fighting for that. And if you can play that. So it talks about autism and what it is. And they did the wrap themselves, and they did the animation themselves as well.
What we start with, a song that's relative about how we feel, feeling sensitive.
Loud noises can get me fretting, and large crowds can be upsetting.
It's hard to cope with some demands, people struggle to understand.
Full of emotion through my vein, but I find it hard to explain.
It's sometimes hard to keep control and dig myself out of a hole.
Good days, bad days, I always try to be confident, but I am shy.
It can be a struggle to reach our place. I might get flustered, I need my space.
Every day I stick to a routine. We're here to tell you what we mean.
We see the world from a different angle, can get mixed up and into a tangle.
Sometimes I need extra time to project thoughts inside my mind.
It's why we find it hard to make friends and follow all the brand new trends. It's why we find it hard to make friends and follow all the brand new trends.
This is our track, this is our beat. Being autistic, we're all unique.
All the words come together, makes us know whatever the weather.
This is our track, this is our beat. Being autistic, we're all unique.
All the words come together, makes us know whatever the weather.
The harder we work, it sticks like gel. We're determined to do well.
We love the support and steady pace and amazing staff from the base.
Hoovering, cooking and ironing skills, bed making, baking, paying the bills.
Lots of work to revise, but I'm cool, I can memorize.
Work really hard, I aspire to climb to the top, higher and higher.
People struggle to do a task. Sometimes I hide behind a mask.
No matter what happens, what you see, end of the day, I'm still me.
Lots of interests, that's the plan, and I for Tito is who I am.
You're just you, and that's okay. So maybe we can be friends someday.
This information we're proud to share. It's good to see the world is aware.
We're here to help you understand. Spread the word, give us a hand. We're here to help you understand. Spread the word, give us a hand.
This is our track, this is our beat. Being autistic, we're all unique.
All the words come together, makes us know whatever the weather.
This is our track, this is our beat. Being autistic, we're all unique.
All the words come together, Rain, sun, snow, whatever the weather.
Thanks a lot. And two of these kids were actually excluded from school, and one of them, again, I can't mention name, is a very famous YouTube blogger, and we did this animation together. So I do think it's, you know, something for them to gain confidence and know they're able to do it. Thank you very much.
Again, thank you so much for that. Again, another inspirational presentation about, again, taking that different approach, tackling problems from new and innovative ways, and above all, finding out what people have to say. Well, our final speaker for this session is Dr. Lorna Tasker, who's Head of Rehabilitation Engineering at Swansea Bay University Health Board. Lorna, welcome.
Well, thank you ever so much for the invitation to speak today. It's a great pleasure to share some of the work that we do in rehabilitation engineering in Wales. So some of the slides I've got here is showing some examples of the work, specifically where we work closely with our patients on a daily basis and the innovations that result from that. And some of our key project areas. I've got two of my colleagues in the audience, Dr. Mark Botel, who's my deputy, and Jonathan Howard, our clinical scientist. I'll be sharing some of their work today. It's just a way of quick introduction to the department at Swansea Bay. We're a department at Morriston Hospital. Got a brilliant and dedicated team of 22 now, expanding all the time. Multidisciplinary clinical scientists, engineers, technicians, nurses, quality managers. And there are three core services that we provide on a regional basis. Our special seating service for wheelchairs, our pressure ulcer prevention and intervention service. That's an award-winning service, unique in Wales, where we've got nurses and engineers going and seeing patients in their homes, in residential homes, care homes, providing that holistic assessment for those patients that are vulnerable and have complex pressure ulcers. And finally, our functional electrical stimulation service is a service providing treatment for patients who experience drop foot. And it's a walking aid providing electrical stimulation throughout the gait cycle. And we're really pleased that we've, over the last couple of years, achieved our relevant accreditation to ISO 13485 for the regulatory requirements for design and manufacturing of medical devices. So there are 3 rehabilitation engineering units in Wales, as you can see here. And what's common with what we provide is we work really closely with the Posture Mobility Service, which is the All Wales wheelchair service, essentially 45,000 service users. In rehabilitation engineering, we see less than 5% of wheelchair users where they need that engineering, bespoke, customised solution for their needs. And amongst us at our centres, we have specialist services hosted by them. For example, in Cardiff, there's a clinical gait service. So on a daily basis, we're presented with design challenges where our goals for our patients are to improve their posture, their biomechanics, the anatomical position in order to enhance their function, independence, and also importantly to reduce risks to our patients, to reduce the chance of musculoskeletal damage, deformities such as scoliosis, and also pressure ulcers, and that's what's highlighted here in some of the animations. Pressure ulcers is damage to the skin and underlying tissue. Incredibly costly to the individual in terms of quality of life, but also very costly to the NHS. Well, if we're able to save one pressure ulcer, one of those category 4 pressure ulcers, that can cost the NHS up to £14,000. And in 95% of the cases, off-the-shelf equipment can meet these goals and with the correct assessment, prescription and provision. But it's not all about the assistive device, and so I just wanted to share really a major part of our role is empowering our patients and educating our patients. And in the area of pressure ulcer prevention, we are really fortunate to have some Welsh Government funding several years ago now, and we've built on this work, but I just wanted to share some of the early work where we evaluated mobile app technologies with 3 specific aims, where we wanted to see how we could provide our patients with the information they need to support and empower them for their own well-being in relation to pressure ulcer prevention, how we could provide that toolkit, that digital toolkit for our community nurses to support their delivery, and also how, given the challenges of the geography in Wales as well, how we can improve and evaluate this accessibility to specialist services like ourselves, using digital communication of wound images. And there are a number of workshops, patient workshops that we carried out, and the need for a bespoke app was identified. And you can check out the YouTube video there where Tia, one of our users, describes her experience of using this app. This app's called Offload, and it's a piece of project that's run by Dr. Mark Botel alongside our PUPIS clinical team and a number of collaborators that we've worked with and still are. It's currently used by over 300 nurses and therapists in the health board, and it's a resource hub. It's got interactive guides, videos, information that our frontline staff need to really tool themselves and to talk to patients about the risks of pressure ulcers, how to prevent and intervene when we need to. And we've got plans in place for that to go onto the App Store early of next year. So I've talked about the use of technology to educate. This is about using technology to prevent via early identification. And this work is looking at technology to identify sitting time and movement monitoring as a risk identifier. And the work so far has involved looking at care home scoping, and the work we've got planned will look at sensor technologies, looking at some tech development to really support care homes to recognise that risk, because immobility is the largest risk factor for pressure ulcers. So some of the solutions may involve looking at prolonged seat occupancy for residents in a home. And we're really hopeful that some of this work will be transferable to other health concerns like falls, for example. So this is a really exciting piece of work that we're working on with a number of collaborators, which we're grateful to. So as I've already mentioned, sort of in rehabilitation engineering, we see that real sort of small number of cases where off-the-shelf equipment doesn't meet their needs. And that's where in rehabilitation engineering, we have to design and manufacture customized wheelchair seating. And the process is highly complex in terms of assessment. It's an iterative process, really working with the patient, their carers, other healthcare professionals, and it can take a number of months to get it right. And it's looking at a number of factors, the posture of the individual, what's the safe sitting posture, the biomechanics that are involved in that, a number of practical needs. These are very vulnerable individuals, so we need to look at the home environment, and often they'll have medical needs where we would need to design solutions to accommodate feeding or ventilation equipment onto the wheelchair. So some of the images there are the outputs of our 3D scans, which is part of the process to manufacture the seats. And then there's a range of in-house manufacturing processes that take place on site, including upholstery as well. And it's a very involved process, and to get it right, for the individual. So just to talk about an area of innovation that's resulted from working closely with patients. Typically, as a department, we've always provided seat cushions, bed supports, etc. With this group of patients, the challenge was to find a solution that would adapt to all environments. And a new clinical pathway is developed as a result of this work. It's pressure protection for children with vulnerable spines. This group of individuals may have congenital conditions like spina bifida, where they're at risk of skin breakdown and often have to have plastic surgery to manage that. And the team worked very hard to prototype a number of solutions and developed a method to adapt specialist undergarments, vests, often putting pockets of silicone in the correct places to provide that level of protection. The solutions were very much co-produced with the child, the family. That was really important, how it would fit into their daily lives. And some of the outcomes have been that these garments have prevented further surgery. So there's been really significant outcomes, improved quality of life. These children have been able to participate more in the activities that they should be participating in, facilitating their development. Another example of this theme is using our existing computer-aided design and manufacturing methods, but this time to fabricate a bespoke rucksack with the 3D scan of the patient's shape discreetly hidden in the rucksack. This was really important for this young man to provide that protection for his skin and allow him to participate and to go to school, to go onto the bus, so that he had that protection. And really simple, but really effective, and it's what he very much came up with some of those ideas about what would fit him and suit him. So I want to talk to you a little bit about our paddle work. This is work that is led by Jonathan Howard, our clinical scientist. He's in a final year of his PhD. And this research is looking at the engagement at the next level, really, with the end user throughout the whole process, the design and the provision process. Looking at personalised assistive devices for challenges in daily living, whether that is eating, writing, personal care. So the process begins with a user identifying a particular challenge that they'd like to overcome in daily living. And prototypes are created using our 3D printing facilities. The user trials those devices, they provide feedback, an iterative process which you're familiar with, and can take many of these cycles to get it right. It's very much user-led. We all know the importance and the role of assistive technology in reducing the burden of chronic conditions on the healthcare system, the wider society, the independence, the self-management that's important when we get it right, and the results of health and well-being that come with that. But what this work has been looking at specifically is some of the barriers to using assistive technology, and I think it's really remarkable that the literature cites up to a range of abandonment rates between 20 and 70%, and some of the issues that come out of that is the design, and that's some of the sort of barriers as to why assistive technology may not be used by our service users. We've also identified a gap in provision and an inequity in provision in the NHS in customised solutions, where something's not available off the shelf. These users don't have anywhere to go. So using our existing methods in wheelchairs and pressure ulcer prevention, the aim of this research is to provide simple, customised solutions to enable that greater independence, improve the health and well-being, and importantly, to reduce that abandonment that we see. So the trial has involved 16 users to date. and the range of neurological conditions, physical injuries, congenital impairments, or with upper limb impairments, I should say. Range of devices that you can see there, and I won't do it justice. Jonathan can tell you a lot more about it than I can. Eating, writing, personal care, putting deodorant on. You know, it's some very simple challenges there. Housework tasks. Taking medication was a really interesting case study there. And on average, 4 to 5 sessions it took when the clinician working with the user to work through the solutions. So this is just a summary of the qualitative data collected, and some of the themes that are coming out is that reduction in formal carer help is really important. And as a result of that, the improved well-being is obviously a huge theme. But some of these users are explaining how they're able to now find more time to have that social interaction and quality time spent with family, which they wouldn't be able to do before having some of these assistive devices. And the reduction in medication is a really interesting one, where having the independence to administer your own, I think in this case it was pain medication, it meant a reduction in other more potent medication. So some great outcomes there. So quantitative data is being collected currently, and it's supporting what we're seeing on the qualitative side. So there are many next steps to this work, but one of the areas that we're really keen on is how the designs that have been created can be reused, adapted to other users that have similar issues, making that process cost-effective and sustainable. And it's great from events like this, we've already started to make some connections to make that happen. So that's the end of my sort of giving you a flavour of some of the innovation examples of the work. I thought I'd just end on some of a bit of a flavour and context on what the challenges are in rehabilitation engineering in the NHS. By no means are these challenges isolated to rehabilitation engineering. We now know, and there's evidence to support, that there's an increased demand on rehabilitation services as the direct and indirect effects of the pandemic. We are seeing a higher complexity of patients being referred, and we're dealing with. Patients did miss out on vital services during that period, and as a result we are seeing the need for more specialist equipment and bespoke equipment. You know, and I'm so passionate about ensuring that, you know, with these challenges and the future challenges that we've got, that we do have that research and innovation space and dedicated time and opportunities to do so for our workforce. It's incredibly difficult in the NHS to do that. It's really important that we protect those opportunities to work on those challenges with our collaborators and partners, as you've heard today. Innovation and technology transfer is difficult in the NHS, scaling up adoption and commercialisation when it's appropriate. But our experience tells us there are opportunities, and I think hopefully from the slides I've shared, there's examples of where empowering our patients, you know, ensuring that innovation is clinically led, alongside our collaborators and partners, you know, there are many, many opportunities there. So leads me on just to conclude our latest initiative. I'm really pleased as all of the 3 rehab engineering units in Wales to be working with ATiC. This latest collaboration is a result of 90k pump priming funding from the Wales Innovation Network. And the aim is to co-create this network in Wales with our partners to address some of those specific challenges that I've touched on following the pandemic. And some of the outputs that are planned: the secondment of a clinical scientist specialising in rehabilitation engineering to ATiC. The money will be used to fund 3 collaborative pilot projects in the centres. And given the challenges of the geography in Wales, been able to develop a platform, whether that be through digital means, and to really help us network and develop that network with our partners. And ultimately hope to secure future collaborative funding to progress some of this work. So it's really exciting. I'm really looking forward to working with ATiC and our partners to develop this network. So thank you very much.
Thank you, Lorna. There's one thing you said then about, there was one little box which said about reduction in informal carer help. And how fundamental is that to the NHS, not just in Wales, but in the UK? There's a figure I've often probably misquoted, which is the potential support ratio. Back in the 1950s, there were 9 people of working age for 1 person needing care or support. By 2050, that's going to be down to about 3 to 1. So when we talk about needing extra manpower or human capital into the health service, where are these people going to come from? So we've got to be smarter, we've got to be more innovative. A lot of the distributed and remote healthcare diagnostics that we've seen promoted today have to come in. And also maybe provocatively, maybe we have to open our doors a bit wider to friends from overseas to come and join us and work with us. So that's another moot point. Right then, the next session promises to be really important because it's about bringing together some of the ideas from the day. So we have a panel chaired by Carrie-Anne Quinn, Chief Executive Officer of Life Sciences Hub, David Evans, Deputy Director of Life Sciences and Innovation, Health and Social Services Group at Welsh Government. I thought we had a long title. And Professor Keir Lewis, Clinical Lead at TriTech and Director of Respiratory Innovation Wales. So before that, there's a break. I'll leave you one thought. In the last session, we had 2 mavericks. So I'll leave you to work out over coffee which one of the panel is Goose and which one is Iceman. So enjoy your coffee and see you back here at 10 past. Thank you.
Thank you, yeah. Thank you.
some.
Questions?
Yeah. So I think.
I don't mind where you have me. Oh.
Do you want to kick off?
Yeah. Okay, we're going to see if this microphone works. Can you hear me? Yeah, at the back? Yeah, brilliant. Great, thank you. Delighted to have the opportunity to talk to you today. And thank you so much to Sean, Ian and all of the ATiC team for this event. It's been a really fantastic day. And whilst I knew some of the projects that we've heard, I've just found the whole thing really, really inspiring, and it's been a delight to be able to share the day with you. So you've got a panel session now, which is your opportunity to grab the mic and ask some questions of us. So I'm Carrie-Anne Quinn, I'm the Chief Exec of the Life Sciences Hub. You've heard a little bit about the Life Sciences Hub today already, and I'll take a minute or two just to tell you a little bit more about our work, and I'll invite each of our panel members to also just give an introductory couple of minutes within their talk. But who we have with us this afternoon is David Evans, who is the Deputy Director of Life Sciences and Innovation within Welsh Government. So yours was easier. And then we've got Professor Keir Lewis, who is the Clinical Lead for Hywel and somebody else, and the Medical Director for RIW.
Somebody else. Somebody else.
So in essence, I'm here representing the Life Sciences Hub, which is really that industry front door for health innovation. We work with businesses here in Wales, we work with industries across the UK and internationally to really understand the technologies that are being developed, the products and services that are being deployed in health systems all over the world, and ensuring that we are able to access and identify some of those solutions that can meet some of the health and social care challenges in Wales. So our organisation is in essence an integrator. We bring people together, and everything that we're able to support is as a result of collaboration. For us, the Accelerate programme has been a massive success and a really clear demonstration of the power that innovation can bring forward when you're bringing together academia, the health system itself, and then industry solutions. And what we've heard today, I feel, is that there is so much innovation already taking place around the region. Some of it's organic, lots of ideas coming out of our health systems, lots of pockets of amazing work that's taking place. But actually, not all of the solutions will come from within a health setting, and it's by working with industry and academia that will really enable us to accelerate these opportunities. And the other thing we've heard a lot today is that budgets are tight. You know, we're economically we're in a difficult position, and there are lots and lots of challenges. And it's vitally important that at this critical juncture, that innovation is at the heart of decision making and at the heart of policies, because it's only by the adoption of innovation that we will be able to deliver the services that we're seeking to within the confines of the budgets that may be available. So that's all from me. Just wanted to give a little bit of an introduction as to the kind of work that the Life Sciences Hub is involved with, and just to say thank you for having us today and being able to be part of this. So if I could just turn to my panel members, and maybe David, just to get a perspective from government.
Very happy to. And again, thank you to Sean and ATiC for the invitation today. It's been really, really inspirational day, isn't it? You come away from days like this with lots of energy and enthusiasm again. Once I've been introduced, I was thinking of you and your question, and I guess being the tallest on this panel, I'm probably Goose, but then thinking, he didn't have a very good end, did he? So I'm not sure I want to choose Goose for who I am as a Maverick. So there's a couple of things I just want to share, as I say, looking through it perhaps from a Welsh Government lens on the back of that. So that's sort of national context. I mean, Chris, you said earlier today, perfect timing, you know, the status quo, you know, we just cannot keep doing what we're doing. And I've seen the minister, you know, write and say on a number of times, you know, that health and care innovation has got to be central to enable us to respond to the challenges we've got. But I use that word, so there's one of the listeners. Intuitively, we know innovation's the only way out. What I think is harder is us having that narrative that paints a little bit of a roadmap. How is it going to take us out of that? You know, whether it's solving, you know, the pressures we've got, the backlogs, or keeping people at home. So intuitively, I think there's a bit of a challenge there about how we make that bridge on the back of that. Looking back, you know, 5-10 years, boy, you know, we've come an awful long way. I think if you held this probably 5-10 years ago, would you have the richness of the material, you know, and where we are? So, you know, so I think, you know, just to celebrate that level of innovation activity. But I think that also gives you a real opportunity to learn, doesn't it? So what have we done over that last 5-10 years going forward? And I guess, so a lot of that now will be reflected in the Welsh Government's integrated innovation strategy, which will be launched in December. And that's interesting because it's integrated, because health is just one of the 7 chapters. And I think that's quite important for us. But you know, if we look at all the sort of feedback from yourselves and others that sort of over the last 6-9 months helped develop, so you know, what's the evidence, what's the narrative into that? There's a couple of simple messages that seem to keep coming out time and time again. And the one of them is around how do we get greater coherence around the innovation ecosystem, around everybody in that room. So words like focus, joining up, and my favourite, which is impact. You know, that's the type of thing that seems to be, you know, coming through in that. And so, you know, so there's a number of key themes, you know, I guess that's going to be in that innovation strategy, which, you know, we'll, you know, have questions on that have been raised today, you know. So there is that about how do we get our improved alignment, you know, between the actors and the infrastructure, you know, in there. The age-old one of, you know, how do we establish a system that gets adoption? You know, it's only an invention until it's adopted, then it's an innovation. You know, and you know, I hear that time and time again. And something, you know, Marcus and Jackie, you picked up today. You know, the issue around right culture, you know, rewards, right leadership in an inherently risk-averse perhaps sector. You know, those challenges. And you know, and how do we really knuckle down around sort of aligning some of those 2 to 3 priorities, where again, you know, COVID showed us when we really focus in and put our shoulders behind one thing, how quickly, but how well we can do some of those things. So, and you mentioned it, Carrie, and you know, the other thing that's come through is we need to take a more strategic, sort of long-term approach to innovation funding. And we all know about this at the end of the year, and that's just, but you know, the reality is that's going to be really challenging. So, you know, a number of you know, if you get EU funds, will have had a letter from the Minister for Economy this week, you know, that talks around, you know, that seismic change really, you know, around going from European structuring to what will be domestic UK, you know, funds, and what that'll mean for us, and you know, therefore how important it is working with industry, you know, and things. So I think lots of challenges there, but actually from today, just lots of opportunity as well. You know, Wales is small. You know, people want to come and work with us here in Wales. So I think if we can get that narrative, you know, if we can get that roadmap together, and if we actually can get Wales working really, really well together, you know, it's a great opportunity.
Thank you, David. Thank you. And Keir.
Thank you. I hope you can all hear me as well for the microphone. So I'm reflecting on what we were supposed to be talking about. And for about, I've been a respiratory consultant for about 20 years. And in that time, I've done lots of startups, lots of pilots. You heard about 4 of them. Super Deep PAL, the first one, it's gone. Efficiency through technology funding, £100,000. The technology was efficient, it was worked, it wasn't adopted, it wasn't scaled up. It was given to our health boards and the NHS for free, it wasn't scaled up. We didn't think about scaling it up. Viper, that one about virtual pulmonary rehabilitation. And I thought that was really good. You could have virtual cardiac rehabilitation, Vicar, virtual stroke rehabilitation, Visor, virtual geriatric rehabilitation, Viagra, you know. But it hasn't been scaled up, it hasn't been adopted, COVID did get in the way, it hasn't been scaled up, dead. Pulmonary rehab waiting list in Hywel is 170 weeks again. So it's there, we know it works, it's adopting and scaling up. The mobile respiratory unit, you know, we have to show value. And now we've learned to show value, we hopefully will get it commissioned as a service. So what I've learned in the last 20 years is it's fun. Innovation is fun. You've got to be, all you guys and girls in this room, you're all cats, you enjoy the fun of innovation. You're not reactive, your personalities will tell you this. How do you control that enthusiasm, and how do you translate that early work into the sometimes boring bit of adopting it at scale? Oh, I want to do something else now, I want to do some more fun bit. So there's got to be other people around us who can take it forward with their strengths and their personalities. That is missing in Wales. It's missing in England, but worse in Wales. It's too fragmented in Wales. We have pilotitis after pilotitis after pilotitis. No one is pushing it forward to the next level. And that's the most frustrating thing. And I think it is good with some brilliant ideas again and again. And 3 years ago we had a similar conference, to be honest, brilliant ideas then. None of it. How many of you can name your health board innovation lead? One. Yes, you had two, three. How many can name the innovation hub secretary and leader? What's the difference between the hubs and the leads? So there's a disconnect. And what I was put in, just from a health perspective, I mean, the cracking slide that you were saying, you need space and you need time. You didn't put time in, you need time. And just from a clinical perspective, the NHS is the 4th biggest employer in the world. That's a huge number of clever, young, dynamic, fast-thinking people who are not being used properly to innovate because they haven't got time. Well, they say they haven't got time. You haven't got space. So what Chris did and Leighton, they said, give us some space and give us some time. Buy a half a session of Keir's time, build a space in an institute, and we'll create an institute of space. Then people suddenly will come. And if all health boards started doing that, that would be a good thing. And you imagine if you had proper designated space with research people coming in, and Sean can stick his PhD students next to your guys and with the patients. Physical space. And unless the health boards and Welsh Government understand you need space and time, and if you put the time into a clinical person's job description, like consultants, we're obsessed with things called sessions, GPs. If you put that in at the health board level, what Phil Clare was talking about it, but do it. Stop talking about it, do it. We have got protected time for things like teaching, audit, all these things is now part of our jobs. No mention of innovation in any clinical job plan in Wales. That's crazy. So if we had time and space, we could use our people better in the health boards. And the other thing I was thinking, and this is what my response to the innovation document, is why can't we do that nationally? So we've got Health and Care Research Wales, a national organisation that does research. We've got HEIW, a national organisation that does training and teaching. And it helps. It's improved from the Welsh Deanery. It's working. What about having a national innovation centre that all these RIC people in the hubs and the R&D directors can feed up to, where you have standard contracting, where you can police consultants and say, with that half session a week, what have you achieved with innovation this last 2 years? Job plan and give them appraisals, with standardised contracts, standardised IP, help those bright young people, give them somewhere physical to go and manage them nationally, as well as within the health board. And I think if each health board bought into that, and Welsh Government bought into that, then you can adopt at scale. And the 80% of innovation will fail, but the 20% of those projects that are looking amazing and looking really good, they die. We start again in 5 years' time. So I think Tech Cymru is a good thing. It's national. Alca's pushing it nationally, capturing this. We're building, I work with Tech Cymru a bit as well, we're building a national registry of all tech-enabled care projects. So if you want to know what's going on with autism in either Bevan or North Wales or COPD in West Wales, it's there in a national database for you. Just take the PowerPoints and take the business cases, have them. We should be encouraging it. So RIW, again, it's a national organisation. So TriTech is within Hywel. But you will have no control over an Ivan Bevan. You've tried. We have no control over a Swansea for our joint projects. So that's your gateway into the NHS through these things like TriTech. You need a national group where RIW, Welsh Wound Innovation, all these other centres could be owned by a single entity with a high-level political agenda behind them. Then the clinicians will start coming in more than they're doing at the moment, I hope. So having a national, how about it's an Institute of Innovation owned by Welsh Government.
Thank you, Keir. So we're going to throw the floor open to each of you to ask some questions, but probably just while you're collecting your thoughts and we're just coming forward with our roving mic, then maybe I could just start, Keir, by asking, you know, if you look at activities within your own health board, what's the one biggest barrier to adoption? You talked there about some projects that didn't come forward, but what's the main reason for that barrier to adoption?
Time. We've done survey after survey. As an ex-R&D director, we did the same thing. And they were all, these people are really keen, they're really busy, and they all say, I've got 28 other things to do, and I've got pressures. The managers are under so much cosh at the moment that they're just firefighting, and it's getting worse and worse and worse. We know what we're doing is not working, but no one's even got time to pull their head above a parapet and go, look at something different. And if you've got that time, and you haven't got to pay money for this, you just got to put it in their job plans and say, on a Wednesday afternoon, like in Google, people have a day in Google, the senior managers, where they don't do anything. Just go and think for a day. Now, the NHS would collapse if we did that. But having a session or a plan, and if you put it in the job plan and give them time, and you have a metric saying, well, what have you achieved with that taxpayers' money? What have you done? Like in R&D, if you got a session in R&D, I would expect, and those people in Hywel, when I was R&D director, you had to have 3 or 4 papers, abstracts, and impact studies. If not, you lose that session, and you go back to being full-time clinical. Mm-hmm. Now, we could do that with innovation and utilize these foot soldiers and these warriors and these people who are embedded in our service and work with patients. And that's several 100,000 people across the UK you can activate quite quick by buying that time with the right job planning. Space comes second, and then probably money after that. But I don't think it's not so much money, it's more time.
Great, thank you. Chris?
Test it. Oh, yeah, it is. Yeah. Oh, dear.
You're on.
It's not a question. It's just to support exactly what you were saying here. I have the privilege of chairing the Healthcare Science Research and Innovation Group across Wales. And whereas there's probably 5 or 6 sort of main actions, one of the probably the most important actions for the future is job planning all of our scientists across Wales. And it was interesting, in the week I had a meeting with Monica Boos from the new Research Academy. She's the director of the Academy. She's an AHP, and she was 100% agreeing with that. You know, so to provide that, because all of the feedback is the same from the doctors, from the AHPs, from the scientists, is they are so up to their neck in operational pressures that they just don't have any space, you know. And those that do are the ones, unfortunately, that tend to give their own personal time rather than their work time to you know. And I can use Mr. Musa, one of our urology consultants. I mean, you know, he will regularly text me at 9 o'clock in the evening, bless, you know, after he finishes his list and everything else, when we need to discuss research and innovation projects. And it should never be that way for me. It should be us providing that protected time. So it's not a question, as I said, it's more of an endorsement really of exactly what Keir's suggesting there. And also managing that is really important. It's not just giving. I'm probably speaking appropriately here, but there we are. I'd rather say it than, you know, doctors have research sessions in their job plans, and they're not always using those sessions for research. So it is around a sort of an appraisal mechanism to make sure that if we're paying you for that session specifically for research or innovation, that's what we expect. And if you don't want to do any research or innovation, I'd rather give that session to somebody else that is keen to do so.
Thanks, Chris. Gareth?
Mine is a question. So yeah, I mean, I completely agree with what you said about time, but I do think there is a money side to this, and I'm wondering about how do we think about how we change that funding model. So, you know, we are the open door to business at Life Science Hub Wales. We have people bashing our door down constantly because there's so much innovation out there. but it always comes to the money barrier. Should we be looking at things like publishing mid and long-term procurement lists with the NHS so that businesses can invest in their innovations, knowing that there will be procurement opportunities in the future? Should we be looking at how our international colleagues do it with incorporating big businesses into our health service? I'll leave it there.
Yeah, that's a really good question. And we were involved with the Pfizer investment into Swansea 7 years ago. And we went to Pfizer headquarters, a group of us, and Pfizer has 6 times the GDP of Wales. So they want to know, where's Wales? Where's the UK? And the only way you could bring in that kind of level of money is infrastructure. So, and again, working with companies in Canada, we say, why don't you fund a professor of, or why don't you fund a PhD student ultimately? And everything we can do differently in the NHS is if you can show value to their service, I don't see why it's not, therefore, unfair to that company, saying, right, if we've shown that this improves patient benefits and it's of value, we should take a short-term procurement to agree to buy that telemonitoring afterwards if we show value. So it's value-based procurement, not volume-based procurement. So in the past, we buy 20 million inhalers from GSK. Now we were starting to say, we'll only buy 20 million, we'll buy 5 million now, and if they show in the real world what you promised us in these randomized trials, then we'll pay you with the other 15. If not, we're going to only give you half the price. So the companies are now going to value procurement. The drug companies are going to value procurement. There should be a similar mechanism for technology procurement. If you can show that this wheelchair can do X, Y, Z and it's of value, then the NHS, we shouldn't then have to write 28 business cases to 28 finance directors and 28 health boards why we should do it. It should be adopted at scale. And that company goes, I've done my bit, now you have to buy 1,000 wheelchairs off us because we know that's what's needed. And health systems will evolve very quick if they get the right contracting. It takes the pressure off the finance directors as well at year end if they base it. If you show value, and value-based was a really good thing that we have to do more in innovation.
Could there be an opportunity to centralise some of that funding for innovation? You know,
Yeah.
if we looked at other models,
Yeah.
then even in Scotland, their innovation organisation deals with the initial procurement of innovation. If, in the way that Kia's just described, that the evidence is there and the results and patient benefits are as hoped for, then contracts are novated across to the health system. So if we look around the world, there are models in place where these kind of systems are happening, and it's not about relying on individual health boards to take a change programme decision and maybe run multiple trials, which is, you know, going back to your pilotitis, that we do see happening across the region.
So I think learning from research, a central thing is once one ethics committee approves a study, the other ethics committees, I remember going to ethics committee after ethics committee, the same protocol again and again and again. Do you remember this? Walking around your car? Now one does it, they all do it. It should be the same for contracting, procurement, I think. IP policy. If there's an IP policy for Wales NHS staff, you're not messing around with different R&D directors with different contracts, slowing it all up and often conflicting with each other. So there should be a central agency of some innovations, my call for Wales. I put it in my responses, and I think Welsh Government will miss a trick if they don't create that central. Where the contracts are all done, you've got a model contract ready. You've got a session contract to argue with a stroppy consultant. It's all ready to go. And then this is what we expect off you. And that can be centralised. And then Pfizer might come quicker.
So I think there's a couple of things there. And, you know, a lot of that chimes, you know, what is the feedback? So, you know, again, there's a consistent issue around, I mean, I describe it as the treacle in the middle, you know, so you've got that, and then you run into this procurement and barriers, and, you know, the treacle sort of gets you stuck in that area. So, you know, we do need to look to see, you know, what are the ways to do that. And for me, that's part of the coherence, you know, because, you know, if you can do it once, do it better, or whatever the way is, you know, that's where we get the coherence. You know, procurement is changing. New legislation coming in, you know, UK government, we've left EU. If you look what's behind that, it's all about collaborative procurement. I'm not saying we couldn't do it under PCR 2015, to be honest with you, but there is, you know, so you know, that's where a lot of that, you know, is going. And I think the other thing I'd say is that, you know, coming back to one of the points, is that if we're more focused around, we really understand, you know, as a sort of, as an NHS, what our need and what we're going to pull through, you know, and we're really clear what two of those three priorities are, then there's more chance of that getting dragged through into adoption and scale, rather than the scattergun of hundreds of things at the moment, and hope that some of them might make their way through to adoption and scale. So, you know, there's probably process, there's probably procurement, but actually that comes back to, you know, a really clear understanding of need, and to say that if that works, we are going to draw it through.
I think a central registry of projects and a central agency where we have a list of all the consultants, physiotherapists, academic nurses, real clinical nurses, scientists, clinical scientists, PhD students doing innovation, who stop caring. When someone comes into Life Sciences Hub, a really good idea, you're trying to find clinicians or people to actually say, let's try it, give it a go. That's a really good idea. It works in France, it works in Germany. Can we try it in where, we don't know. Who is the AI lead for prostate cancer? Well, we've suddenly found one. Who is a clinical person on this? And that has to be held centrally, because otherwise it's embarrassing for you to go back to the company and go, we haven't got anyone else who can do it, because I haven't got time. Yeah. So you offer them the time up front for a year, and that can be not that expensive. It's about job planning more than anything, what you can do with creative sessions. And then that might allow the procurement to follow.
That's the coherence again, isn't it? It's the coherence, you know.
Yeah, absolutely.
It's research, you know, if I can go to Caris and Welsh Government, and she will give me, you know, whoever is undertaking research across Wales or in England. If I go to Caris or anybody and say, well, who's undertaking all these innovation pieces of work, there isn't the thing really. Yeah. And when I did that AI piece of work for prostate cancer, we secured £100,000 from Moondance. It was only a week later, Moondance would ring me saying, oh, we just found out Betsy are doing a similar piece of work. And I'm like, oh, please. And then, thankfully, Betsy were doing on the biopsy end, not the MRI end, so that was more luck than judgment. We don't want to be duplicated, do we? You know, so we've got to be aware.
But also, we don't need to be duplicating other regions, so it's wider than just what's happening in Wales, and at the moment, and hopefully it will continue, within the Life Sciences Hub we have access to the UK's Innovation Service, which is a repository of all health innovations that are being taken place across the UK, and that gets launched formally, so that the sort of the full access will be available next month, so the beginning of next month. So I'll be able to get back to some of you with some information on that once it's available. Yes, and access
and the
to
Tech Wales should be uploaded onto that as well. So we've got about 50 projects now building up with our. But 90% of my research, this is not innovation, but my research, the science translational work, is through an old boy network of people I've trained and graduated with outside the UK, outside Wales. Do you want to? Can you help us with this bid to a large grant? A lot of the COVID work, it literally was ad hoc mobile phones. Are you up for this? Chats in the pub. And that's what was happening, but it somehow worked. That's got a lot better and strategic now. The innovation in Wales and across the UK is still too fragmented to me. It's too scattered. It needs to be pulled into a central area.
I'm going to bring Mark in because I can see you patiently holding the microphone.
Yeah, we've got something. So following on from those themes, so I do think procurement, our route to market and our procurement routes are an issue for us. How we partner with organisations, in the example that you gave, what's in it for the private sector, what can we guarantee them, and it is very difficult for us to do that. I think the question for David and Welsh Government and Health is a lot of those are self-imposed rules, and I agree there aren't really that many legislative barriers for us not to do that, but quite often we get the risk-adverse computer says no, fair and open competition, you may have engaged with this partner, but actually now there's no guarantees and we've got to go out. That puts people off. It also makes adoption difficult as well, because if one health board has worked with one partner, you may want to adopt that, but actually your finance lead will look at it and go, we don't think it's been through the right rigour, we're going to have to go to market. So I think Welsh Government, along with the health boards, need to be looking at that reform within shared services, and I'd be interested in your views on that. The second part, going back to where we started the discussion, I agree, I think it's a time element. I think there's a money element to adoption, but I think there's also a capability element. We talk very much about the solution. We don't often talk about the process of adopting, the people side of it, the change side of it. If I look at some of the stats across Wales at the moment for virtual consultations, which hit an all-time high during COVID, for most health boards, not all, but most health boards, virtual consultations have fallen back to pre-COVID levels. Now, that's not an innovation technology aspect. That's about adoption and taking clinicians, nurses, and people who run clinics through change to understand how to use them and how that can benefit them. And again, quite often I find that when you put in proposals for funding, quite often they'll come back and say, actually, we'll fund the core technology, we won't fund the wraparound, won't fund the project management, won't fund the business support. And actually, some of those things are what actually makes it stick or not. So again, interested in your views on that.
And interestingly there, Mark, I mean, I think that comes back to David's point about that sort of cohesion and bringing all the organisations together. And, you know, as part of that innovation journey, we need HEIW to be part of the process. And that we're thinking about the people implications within that environment. And something that we spend more and more time doing, it certainly wasn't part of our original business plan or raison d'etre, is offering project management support to really offer just that confidence and engagement with industry and sitting alongside some of your clinical teams to help them work directly with industry for projects to be brought forward through adoption. Now, at the moment, that's primarily in a trial situation, and we're still working through and then how is that taken forward in the long term?
Business change capability, and most organisations intertwine the two, and actually I've got project managers who are pit bulls in getting something done and getting it done well. I would not put them in front of people to explain and try and get them to change things. And again, that's quite often where we fail as health organisations, in that lack of investment around what's the impact on the individual, whether it's the patient, the clinician, the administration staff. How do we take them from A to B, as opposed to going, here's a bit of technology, use it, or here's a new solution, use it, and then we wonder why 6 months later things have reverted back. So there is that, but that comes back to time and it comes back to investment, doesn't it?
Yeah, I'll pick up a couple of those. So on the procurement one, yes, Mark, as you know, we've been having sort of a series of conversations with chief executives and their exec team over the last 6 months, you know, the innovation team, just having this, you know, and I was discussion about innovation, and it's been good. But, you know, so, and we've got a conversation with them next week, you know, about what are those half dozen actions we really want effectively, you know, leadership support to take forward. So the one on procurement, you know, somebody described it, what is the rule book? Do we know what it is at the moment? And actually, do we know what it wants to be? And that isn't in one place, you know, so actually doing that might be, you know, sound simple, but actually, you know, would take things forward. I was quite heartened, actually, as part of those conversations, you know, on the second bit, you know, change is about people. It's usually less about the tech. And, you know, on that session around, you know, on listening to people and, you know, and what changes and what works for them, that's just the same as with staff. You know, so yeah, another good conversation there was, yes, you know, if we've had innovation here on the periphery and we've got great things, but actually if we're not linking that up into our workforce plans, into our transformation plans, into our planning about what we're drawing forward, are we surprised that we're not able to draw scale and adopt those and actually then, you know, then make it land? And some of those innovations, you know, will have bigger change for people, you know, than others. But we shouldn't be surprised to say 80% of this change is probably cultural and people, and less, you know, less the other. So again, some good conversations there, which I think comes back to, you know, the point saying focus. Let's come back to it. Let's just, what are the 2, 3, 4 areas we really want to focus on? You know, I know 50, 60% of innovation will always be local, but actually, what are some of those things we want to draw up to regional or national and really make some inroads, you know, into these? And I'm hoping that's where we'll get to be able to say to you, Carrie-Anne, then from the Health Board, is we really want to work in these 3 or 4 areas really strongly, and there's commitment then to try and, you know, draw those through. we'll see.
And we can learn from research here, Mark, as well. So you don't have to have an ethics review to adopt a study, but you have a local R&D review to say, have we got the capability to do this study here in this little hospital now? And if you had a central innovation agency, they could say this is the kind of stuff you would need to do a tech trial on. And people will develop competency checklists, and my buddies in TriTech will all say when I say this, when we evaluate any new service, I'll say there's patient factors that we're going to evaluate, there's technology factors that we're going to evaluate, then what's the big one? The infrastructure behind it. So the technology is not the problem, the patients are hardly ever the problem, it's the infrastructure change. And as we learn with TriTech and with RIW, we've got standard reporting mechanisms now, and look at the infrastructure, what's the impact on staff when you stick them on, give them an extra thing to do on top of everything else. And I would say 90% of our problem, if not 99% of our problem, shoot me if I'm wrong, is going to be infrastructure. So we need a central agency, we need some central contracting, and things like, if you want to be a university health board, say to the chief execs, 1% of your staff have got to have a time for innovation in their contract. Why not? Say that, like we research, you know, simple key metrics that can be recommended centrally, so then the execs have got something to say, right, why have we only got one person with the word innovation as a consultant out of 3,000 staff? Why? And then that's a bit of a stick and a carrot, but then you've got your time being built into it, and then you've got places like TriTech and RIW and everyone else looking at the infrastructure. And a checklist then could be done centrally, like in R&D. And it'll save time, if nothing more, and it'll standardise our adoption processes quicker and quicker.
There's something here, just listening to all of the conversation about how do we build innovation and the process and the adoption of innovation into the planning cycles, so that it's embedded there, and then that touches on your workforce, your infrastructure, and everything else that's needed. And actually, we don't. You know, it's not something that's featuring strongly within those health board planning cycles. And as we've seen today, there's so much fabulous innovation out there, but if we haven't got a system within health to bring those forward, and if it doesn't land in the hands of the clinicians or the patients, then you know it's not really fulfilling its purpose.
Well, I also think a couple of things that we're learning, again, the hard way, Mark, is with RIW particularly, we've got people from health and social care. The leader of Torfaen Borough Council's on the RIW board, and he thinks completely differently to me, completely different access to funding, completely different access to ideas. That is a really good bit, you know, the social care and industry. So one of our other members is head of Industry Wales, and he's advising, and we got together trying to get emergency ventilators for COVID, and we made friends after that. And it can be done, fast procurement, when you really want to do it. So I do think we're missing a trick with social, but I think purely what we can control in the next year or two, without breaking budgets, is have some designated time built into standard job plans, and all health boards have to respond. Where is it? Who's looking at it? What's your innovation doing with the money they've been offered?
Thank you, Keir. Thank you. Jane?
You've sort of started touching on it anyway, but I very much always come from grassroots, being a nurse, and the culture change is so needed. Attitudes need to change, and I know you were sort of, you know, alluding to that. And I'm always one for training and education, and I just wonder, this is a sort of a more grassroots but long term, but we should be bringing innovation into our education of nurses, doctors, you know, healthcare assistants, anyone, so that it because I've worked with a lot of care assistants who are really innovative, because they're really creative. They may not be amazingly academic, but they come up with some great ideas. And if people have the confidence, we've really got to change that negative culture of the NHS that is out there. And I think all that you've said there is alongside with all of this central, you know, whether it is about trying to bring that whole idea that perhaps people have to do more innovative projects when they're doing their degrees or whatever they're doing. So.
And certainly, there's so in the last couple of years, there's been a whole programme launched across Wales called Intensive Learning Academies, One is dedicated specifically for innovation, there's another that's digital, one that's focused on prevention, and then another that's value-based healthcare in the way that Kia was describing. You know, it's how are you prioritising the deployment of products, and does it have the patient's best interests at heart as that's being taken forward. So there's some initiatives that are now starting to come through, but actually what we're not seeing is that wholesale cultural change, and also recognising that takes time.
Yeah, I really love the Bevan exemplars and the Bevan fellows. They're really, you know, young people with some amazing ideas, and when you're as old as we are, then you think we need that fresh blood coming through. And even things like the clinical research awards, health and care research awards, where you buy time for a clinician for 2 years. When that's finished, it's gone. So how can that clinician then carry on what they'd spent a year and a half getting ready? So unless it's embedded into a standard NHS culture job plan, and then cascaded down as well as cascaded up through learning, I just think that's the way forward. And it works in Canada, it works in New Zealand, you know, it works in Brazil. We haven't even tested it.
Can I just answer that?
Yeah.
So this is great that we're coming around and spending so much time talking about culture, I think. So one of the interesting questions I said, so what do we reward? What do we incentivize? You know, what I see at the moment is, you know, we reward and say thank you to people who come up with the next bright, shiny thing. Actually, where are we rewarding the people that actually adopted and scaled? You know, so all those send strong leadership signals about actually what you reward. So, you know, so I'd like to see more, you know, more recognition of some of the people who've perhaps taken, you know, even adapted. Who cares to some extent? You know, I was saying, pinch with pride. If somebody's spent a lot of time, effort, you know, to learn something, pinch it with pride. But you know, I use that phrase, and it's very odd looks. You know, so how do we celebrate and recognise people who've pinched with pride?
Fantastic.
I think universities are working better today than they ever have done. No offence to Ian, but in the old days where Swansea used to fight Cardiff over every small bloody grant, and then they both realised Bristol was going to come and eat them up anyway, and then Bristol realised Imperial was going to eat them up anyway. So there's always a bigger fish, and you know where Wales will survive. And the universities with Accelerate and these other things are actually making friends. 10 years ago, they weren't like this, were they? It wasn't open. This is Glasnost compared with what it used to be. The NHS is still not opening up enough. You know, what's going on in Betsy? Why didn't we know what was going on up there? We need to open up the health boards. They're still working as 7 independent organisations with 7 lots of contracting, 7 different innovation strategies. Why? Same patients.
So I think we've hit our time margin. So I'm going to ask you just to have one closing comment, if you could, just to sort of wrap up what we've been talking about.
I would just say there's great hope if we can get that coherence, and we're small enough in Wales, so let's do it.
I would say come up with 3 or 4 key points after today, feed it into the Welsh Innovation Strategy and say, let's do something that doesn't cost a lot of money, but we can recommend something to Welsh Government to say to the health boards. And with some brilliant ideas here.
And for me, today, I've just been inspired. There's so much fantastic connectivity that's already taking place. And I guess the ask is for each of you to go back to your own organisations, talk to your colleagues, talk to your teams, and really kind of spread some of that enthusiasm. And those that have the opportunity to change some of the systems and change some of the culture, you know, we're already starting some of those conversations as well. But I think there's a responsibility for each of us to really take this mantle forward, because health innovation is absolutely critical for us to really be able to deliver a health and social care system across Wales that we as citizens would like to see for ourselves and our families.
And it's really fun.
Yeah,
it is good fun. It is fun. You've got to enjoy it, otherwise don't do it.
Thank you, Ian.
Thanks, yeah, brilliant. Good.
Well, thank you, colleagues. I think that was a really good way to wrap up the kind of the business end of the day. And but I think it comes back again. I feel we come full circle. We came back to people again. And I was going to make a bad joke then about NHS being the fourth biggest employer. Didn't you say the Red Army was the biggest employer? But, you know, the perils of not adapting, isn't it, to modern technology. So it's been great today. It's been great to welcome attendees from the US, from Lithuania, even from England, whatever next, okay? So I think it's demonstrated that Wales is very much open for business in terms of innovation within health and life science. Thank you particularly to the speakers today and to all attendees, especially those who've stuck with us to the very end. So either committed or you've got nowhere else to go. So thank you for sticking with us. It's been great. But as this was billed as the ATiC Symposium, you'll indulge me as I maybe give a little bit of a kind of our journey and carry on actually as part of this journey because, well, first of all, well, 15 years ago as a university, we had in a product design department, one of our students found a charity in West Wales called Cerebra, and she wanted to do a project with them. I'd never heard of Cerebra. So she started doing this little project with them, and then we got to know them. And then suddenly we were hosting the Cerebra Innovation Centre, which is a partnership between the charity and the university developing individual products to meet the needs of children with brain injury. And that's 15 years later, that's still going strong, and there's been hundreds of kids who benefited from the work there. But that was the genesis, really, of a journey within product design in the university, Sean and myself working together, and through daisy chaining a number of European-funded projects, such as Design for Successful Aging, Institute for Sustainable Design, Catalyst, before eventually we came to ATiC. We had to change the name to chase the funding. So, but we were basically doing the same thing in the background, taking design thinking and applying it to health and healthcare problems, bringing the innovative processes that we use as designers and translating that into health and social care problems. And then along comes Accelerate, an opportunity to bid for money. Well, first of all, it was a call from WEFO for ERDF funding for research into life sciences and health. So as we were the Mavericks then, Swansea College of Art, we applied to WEFO for some of this money. And they said, go away. There's 3 other organisations bid for the money in health and life sciences. Go and talk to them. So who are they? Well, Cardiff School of Medicine, Swansea School of Medicine, and the Life Science Hub. So how are we going to compete with that? So we went along, and we had an amazing initial meeting. And particular thanks to Tom James, who couldn't be with us today from Welsh Government. Gareth Davies at Swansea Uni, who was a real key driver, and carry on again for having that vision to kind of see there was a bigger picture here than just the traditional suspects. So Accelerate was born. I think it's been 4 years since we've been live, and they have flown. It's been mentioned a few times today. I think Keir mentioned glasnost or perestroika, whatever we're going to call it. But basically, there's been a huge thaw in relationships between the universities involved in the process. And Gareth has been on both sides of the fence, Gareth, a university member of staff, and then jumping across to the hub. And yeah, it was dog eat dog. You know, it's everybody's fighting for the same pot of money. But what we've proved with Accelerate is that universities can really collaborate in a rich way, recognises the complementarity of each other's skills and knowledge and research activities. And there's even room for the Mavericks, which I still think we are in ATiC, to play a part in developing and introducing new and innovative ways of thinking into the development of healthcare and health products. So, no sooner had we found a way of working together than COVID hit us. But the partners, and what was really a stress testing, responded amazingly, working with the hub, collective response to the darkest days in our recent history, isn't it? It was the worst pandemic in 100 years. But meanwhile, WEFO being WEFO, we still had to do our targets, we still had to do our returns, our claims. So at this point, a really big thank you to all the project managers from the partners, the finance and claims officers and the partners, and Gareth for pulling it all together. So, you know, we've managed to smash our targets as Accelerate. I think there's 2 targets we're a bit low on, but I don't think any project in Wales has hit those targets, patents and things like that. But we've exceeded targets to 300% in some cases as a partnership. Now, within that partnership, Not every partner has hit every target. But as a partnership, we've exceeded our targets, which just goes to show that we've covered each other's back, and we've all pulled together and we've delivered. So pick up on something on Kia said, and Kia was gone about providing staff with that half a day a week, whatever it is, to do research and innovation. I'd go further than that. I think you need little groups of key staff working together who will kind of work together and cover each other, because perhaps that innovation doesn't happen only in the half day. You might need a full day. And have you got someone covering your back within the health board or within university to give you that air cover to help you pursue that project, and while it's still fresh and it's still vibrant and you've got momentum? So, where are we now? Where do we go? We didn't really cover it in this in this session at the end, but we have ambitions for Accelerate 2.0. We've exhausted every possible angle and scheme to get more money out of WEFL. But we are pursuing other avenues. And so we believe there is life beyond EU funding. It does feel a bit bleak at times, especially where we are currently as a nation. And we could be despondent, but I think that gets us nowhere, you know? At the end of the day, if we don't believe in what we're doing, if we don't feel passionate about what we're doing, we may as well give up now. So in the spirit of passionate commitment and belief in what we're doing, we are engaging with government, we're engaging with research councils, engaging with the private sector to look for life beyond the current funding regime we've benefited from. Because we need to build upon it. We need to build upon these relationships, build upon the success of Accelerate, which I think is a pattern for how other organisations can work together. We've talked about health boards collaborating, we've talked about hospitals collaborating. Give you one example, we're partners in WIN, the Wales Innovation Network, which is all the universities in Wales suddenly collaborating to gang together to try and bid for those larger scale investments from UK government. There's nothing stopping health boards banding together to bid for larger scale investments and demonstrating the value of collaborative work within the research and innovation space. So, as we draw to a conclusion then, just leave it. I think it's a positive story today. It's been an amazing story. We've had a diverse range of presentations, people-centred, technology-centred, financially centred, presentations from industry, presentations from clinicians, presentations from innovators. But the key theme running through it all is the importance of valuing the innovative spirit in individuals. And that's whether someone is appointed as a consultant level in a university or a health board, or, even the cleaner, who has ideas, who has passion, who has commitment, and can see problems, can see challenges, and can respond with an innovative thought and idea. How do we cherish those is the acid test to how much we believe and understand what innovation is. Innovation is a state of mind. It's not a thing, it's a state of mind. And it's the way that we all engage with each other in that process is what sets us apart. Many people have said today, Wales is a special case. And yeah, it is, okay? It's not a basket case, but sometimes it feels like that. We're such a small country, and yet we've got such tribalism. But when we pull together, we can achieve amazing things. We had a delegation down from Aberdeen a few weeks ago, and they were blown away how representatives from government, from local authorities, from universities came together with industry and sung off the same hymn sheet, which they said isn't happening up in Scotland. So, word of encouragement, keep doing what you're doing. It is working, it's frustrating, but we will get there. Thank you very much.